observation forms, and use of visual tools to demonstrate quality feeding, and key interventions like antenatal education classes and use of breastfeeding support phone line post-discharge was established. This is the plot of electronic database in Excel format tracking the feeding practices as recommended by National Accreditation Center. We repeated the PDCA tool, and to monitor the outcomes, the plot of AISMOC indicators, primarily early initiation of breastfeeding within first hour, mean exclusive breastfeeding compliance rates at the time of discharge, and at 6 months follow-up were plotted against the implementation months, which reflected a significant increase from pre-intervention through intervention and post-intervention phase. On comparing our results with WHO Global Breastfeeding Scorecard 2023 for developing countries, the Lancet Global Health Observatory Statistics for middle-income countries, and the International Breastfeeding Journal Systemic Review for Future Management Strategies, our results were comparable with the benchmarks published. To summarize, framing the BFHI is an evidence-based change process, uses research implementation model that allows us to review and recognize specific essential strategies to benchmark IYCF indicators. These are simple yet cost-effective ways to reduce the risk of infant mortality, and JLNHRC could strengthen the institutional breastfeeding policy, establish IYCF monitoring and digital data management system, and facilitate the implementation of International Code of Marketing of breast milk substitutes. Continuing our endeavor towards quality care, in today's era with over-medicalization of birth, workplace and employment challenges, and with commercial milk formulas exploiting the concerns of parents, this pioneering research benchmarking WHO guidelines marks the beginning of a foundational research with a novel initiative in Central India, because we need to catalyze and inspire the best practices. And this is the testimony of our strong institutional commitment to provide quality newborn services. Thank you.
The house is now open for question and answer session.
Ma'am, good morning. I am from AISP Banpur, Dr. Bishrop Mukherjee. My question is, what are the challenges that you faced during you proceeded with your study or your program?
Thank you so much, sir, for your question. There were definitely defined challenges like the initiation of breastfeeding in the labor room per se, because we needed to start the skin-to-skin contact in the labor room itself as soon as the birth happened. So that was a challenge because it required a teamwork with the obstetricians and the pediatricians together. And skill training was another challenge. So we kept on doing that, sir, till we could accomplish the goals. We also had a 4-day breastfeeding skill training by National Accreditation national trainers at Balai. So we enrolled in quality numbers, particularly those staff who were posted in the labor room or in the maternity wards, and we ensured the use of continuous tools. Second challenge which we encountered was when the mother and the baby were separated, it was difficult to continue the maintenance of the milk expression. So again, with the use of tools and charts, we demonstrated that every mother has to learn this breast milk expression technique, and also the previous concept that the milk is inadequate was washed up with the continuous healthcare staff education and skill training. Initially, the mothers also thought that they had to feed every 2 hourly or every 3 hourly, instead of the recent concept that breastfeeding on demand or on the baby feeding cues is so important. So almost these 3 challenges we had, sir. First, the initiation of skin-to-skin contact in the labor room itself. Secondly, the continuation of milk expression. And thirdly, educating the mothers that they don't have to timely feed them, rather it is breastfeeding on demand, on reciprocal feeding, which is helpful.
Thank you, ma'am.
Thank you so much.
Thank you.
Thank you.
Over.
Thank you.
Now I may request Dr. Jitendra Pandey, ISCO Burnpur, to present his topic,
a multimodal approach for the control of violence in health professionals following total quality management protocol.
A very good morning to the chairman, judges, and delegates. My topic is introduction of multimodal approach to control violence against health professionals. Healthcare professionals are increasingly becoming the target for the violence at our workplace. Although we contribute only 1% of the healthcare worker, but incidence is 3.4%. However, workplace violence is preventable and should not be the part and parcel of our life, and we should have got the zero tolerance for it. As statistics says that 8 to 38% of doctors have experienced the violence at some points in their lifetime. 70% of doctors feels unsafe while treating the patient. Following the DMAC protocol, we have got the aims and objective of our study, the former 1.5 year and the latter 1.5 year, defining the workplace violence, understanding and identifying the prevalence and potential cause, learning strategies to prevent it. The type of violence may be verbal, that is direct or telephonic, may be physical, animate or inanimate. The impact of assault on the individual in the form of disappointment, frustration, loss of respect to the profession, turnout on the hospital and management with the loss of image and patient turnover and manpower, along with the financial loss. These are the identifiable cause, and multiple factors have been seen. We have excluded the billing part because chargeable cases are very negligible in our hospital, and violence out of it were also very negligible. So, plotting this chart on the Ishikawa diagram, we can see the patient factor in the form of mental health issues, substance abuse, frustration, anxiety, staff factors, maybe the identifiable cause of burnt out, fatigue, lack of empathy, environmental cause, overcrowding, long hours, societal factors, maybe cultural attitude, and media influence. This has been seen. Visitor behavior, unrealistic expectation, family stress, communication gap, misunderstanding, and lack of empathy all leads to the violence at the workplace. The root cause analysis in our hospital, which was done, has got the YY analysis, and it shows that inadequate security personnel, multiple entry point were the major points of concern. And under the Plan, Do, Check Act, we have got the brainstorming session, which these options were discussed: controlling the number of visitors with provision of single entry point and placement of CCTVs, increasing proactiveness and apprehension, hospital alert system and mock drill, orientation program, increasing awareness, social and psychological. Some legal support, as we can see, Ministry of Health and Family Welfare has got imprisonment for the preparators 3 months to 5 years and fine up to 50,000 to 2 lakhs. One memorandum came on 16th August 2004, where file an FIR with hours of the incidents. Local leader involvement, as it's a double-edged sword, has not been taken into our account. The options discussed were implemented through posters, regular counseling, basic education for health awareness, maximum coverage of BLS training to all employees and family. These are the chart through posters, increasing staff training, better infrastructure in form of CCTV and better alert system, along with the mock drill and time. These are few pictures of the posters as well. Training with the limitations of the doctors. These are few more pictures. This is the old look of our counseling room, which has been changed. Doctors neither a god nor a devil. It has been posted everywhere, placed everywhere in the corridors. Now, the improvement or the result has taken from the feedback from the patient, relatives, and health staffs, dropout rate, incidence rate, and reduction of fear factors in the staff through workplace stress scale. And here is the result, which shows that be it the number of incidents, dropout rate, workplace stress scale, or positive feedback from the patients, all have p-value of less than 0.001, which is a significant reduction in comparison to the former 1.5 year to the latter 1.5 year. Incidence in the ER also has been decreased from 24 to 10 plus to 6 plus. That if we we behave in a sober way, this was the key factor. Addressed more comprehensively. These are my reference. My acknowledgement to the whole team, to all the staffs of Banpur. Verb counts. Thank you.
Thank you. House is open for question and answer. One question per person, please.
If there are no questions from the audiences, yeah, there is one question there.
Good morning, sir, for your nice presentation. I'm Dr. Ramesh. I'm from Bokaro General Hospital. So the most common effect of hospital violence is psychological, stress, PTSD, or any other psychological. So what interventions were taken to control these psychological issues of the employees, and really also involve this study?
Actually, sir, from the patient point of view, as well as I have the YY analysis shows multiple entry points, security, and lack of empathy. These were being stressed. Yes, psychiatry means the whole team has been taken. Storming psychiatrist was there, sir. PTSD, and these were the violence generated by the patient itself is not of that much grievous grave in comparison to the patient parties. And we should have the apprehension that this patient party can create a problem. This has been stressed a lot, and implementation of the empathy into our patient, our staffs has been stressed with much more importance, and training has been given how to behave, how to greet the patient, so that we can apprehend which party can create some problem. As far as the patient is concerned, if we can come to know that this patient particularly can problem, we have consulted the psychiatrist, and this is the normal phenomenon. Actually, sir, Dunning-Kruger effect is there. If you know confidence is lessened. If you know nothing, confidence is high. You have to teach as the much important, sir. For the question.
It was a very nice presentation.
Thank you,
But I
ma'am.
have one question, like what is the administrative controls you are doing to prevent, to decrease
Ma'am,
this kind
the code portal
that
and
wait. Just 1 minute. Second part of my question is, what is your role in counseling? I mean, who to counsel? Is there any role of that?
is a teamwork, ma'am. 100% for the council. When we think that counseling cannot be done, then we call them. Otherwise, each and every person were trained whenever any problem, sister, be it even ward boy, all have been.
Thank you. Thank you. We'll
Thank
go
you,
to
sir.
the next,
Thank you,
we'll go
ma'am.
to the next presentation.
Thank you, sir. I request there should be only 2 questions and no discussions in between the audience. Our next topic is Bulu Sharma, DSP Durgapur. She'll be presenting analytic practical applications of Six Sigma matrices. Mic. Hello? Check. Hello, hello. ठीक है sir.
A very good morning to the judges and the dignitaries here. Again, I'm here to present on, this time, analytical errors, of course. My topic of presentation is Lean Six Sigma approach to improve analytical process in our lab. The analytical process determines the lab report, and lab reports are validated with of running quality control material. They determine the accuracy and precision of the lab reports. Accuracy is related to bias, and precision is variation. Mean from the and coefficient of variation is the variation of the observed values with respect to the lab mean. Now this whole variation is allowed within the limits of total allowable error, which is given by some standard. Clear? Now the day-to-day variation of quality charts are but the quantification of error cannot be done. Here comes the role of Six Sigma, because whatever gets measured gets improved. And Six Sigma can be calculated with this formula, T minus bias divided by CV. The world-class Six Sigma is equivalent to 3.4 defects per million opportunity. That means, if 6 standard deviation of the process can be contained within the tolerance specification, then less than 4 defects per million results will be generated. The Six Sigma project consists of 5 important of define, measure, analyze, improve, and control. We defined our problem statement as the number of complaints we were receiving from the clinicians for a period of 2 months. Our 79% were outdoor complaints, and our goal was to bring down the complaints to 0 or near 0. So we formed our TQM team, and we measured the sigma metrics of all the parameters which were running on a regular mode on both our auto analyzers, DRE CX6400 and Olympus AU640. From the DRE data which was used for outdoor reporting, we can see that all the parameters were below 6 sigma. None was in world-class category. This is very evident from the number of repeat tests we were doing, and we were entering in our daily register. The repeat tests were done in Olympus machine, where the data are quite appealing. World-class category, those are that is below 3 sigma. So we analyzed why the parameters are having low sigma values with the help of quality goal index determination, root cause analysis with fishbone diagram, Pareto analysis, and risk priority number determination. In QJ analysis determined with the help of this formula, QJ less than 0.8 indicates imprecision due to random error corrected accordingly, and more than 1.2 indicates inaccuracy due to systematic error corrected with calibration or machine maintenance. Majority of the reasons were imprecision, though inaccuracy was also a cause. In root cause analysis for low sigma values, we found 5 important causes due to the methodology used. Person-to-person variation, environmental factors, enzymatic assays were dependent on enzymatic environmental conditions. Then equipment failure, DRE had frequent machine failure, and materials used. In Pareto analysis, we found that person-to-person variation and machine breakdown were important factors which were taken into account. Risk priority number was determined with the help of sigma metrics, severity and intended use. Severity and intended use were determined with a verbal survey among the clinicians of our institute. Parameters like potassium, which were having low sigma values and high RPM number, more than 70, they were rigorously corrected with WestGuard multi-route and frequent QC running. This way it became cost-effective for us. This is the process map, how the various parameters were corrected according to the different sigma values. Then in improvement phase, training was given for QC handling, reagent handling, SOPs were made for reagent top-up, QC reconstitution, daily QC run, machine maintenance daily and weekly. And freshly, lab mean was calculated for 60 days, consecutive 60 days. Outliers were omitted and improvement was done. These were some of the SOPs used. The WestGuard multi sigma value. In the Olympus machine, we can see significant improvement. All the parameters, red color, which were in red color, which the drilling machine could not be used for the improvement phase due to machine failure. All the exercises were adopted for 700, and where we can see, though some parameters were still in poor performance category, this shows that we are still in a phase of improvement. The number of repeat 30% reduction, which is shown from the register, have also come down. We have achieved our goal, and with repeated PTC and improvement. To summarize, Six Sigma project was successfully completed in the analytical value in comparison to relevant studies. But it can be proved that it is not just because of the new machine, but learnings and experiences from the Dirui find out the cause of error, to prioritize improvements, allocate resources, optimize selection of methodology, quality of instruments, save lab reagents and supplies, very evident from 37 to 40,000 per month saving on reagent material and QC material. And with incorporation of external quality assurance program, we are preparing for NABL accreditation. These are some of the references.
The house is now open for the question and answer session. Yes, sir wants there.
Good morning.
Good morning, sir.
You have very strategically focused on analytical phase.
Yes, sir.
But if you look at the repeat of tests,
Yes, sir.
one of the important parameter is pre-analytical.
Param-
Pre-analytical phase.
Pre-analytical. So that actually I have done in.
That is a very critical thing, because when the sample is collected, when it
Yes,
is
sir.
transported, how it is transported, if that is not there, repetitions will go on.
Yes, sir. So in last presentation, last AISMOC presentation, I presented on pre-analytical errors.
So second thing is that what is the internal, you talked about EQUAS.
Yes, sir.
What are the internal controls that you have used?
So we use Beckman-Coulter internal controls, level 1 and level 2.
Okay. Do we have any other questions? If there are no other questions, thank you. We'll go to the next presentation.
Thank you, sir. Thank you.
Thank you, ma'am. Our next participant is Dr. Rishi Anand, Tata Steel Plant, and the topic is Optimizing Trauma Pain Management at Tertiary Care Center and Improvement Initiative.
Hello. Hello. Good morning, everyone. Acute pain after trauma is inevitable. Suffering from it should not be. Every hospital must take steps to improve their acute pain services in order to minimize patient discomfort. Why? Because pain is now being considered as a sign, and rightly so. But unfortunately, at many hospitals, it is still being ignored and poorly treated. This is a quality gap. It results in deleterious impact on patient health and leading to poor patient experience. Dedicated acute pain services is a new concept, and it is being propagated worldwide. But unfortunately, at many centers, it is focusing on managing post-operative pain. It is in spite of the fact that it is a cost-saving strategy. If you look at the worldwide publications, you can see that there is increasing focus on acute pain services, but India is still lagging behind. At our main hospital, we observed that ward-based pain management practices were variable and acute pain management services were focused on post-operative period. Had a problem statement, inadequate pain relief in trauma patients despite the focus on pain. So there was an improvement opportunity, improve acute pain trauma patients with protocol-based pain management. We assessed the problem Statistics survey conducted in the month of April to May 2023 using Defense and Veterans Pain Rating Scale over 48 patients. We assessed demographic parameters along with injury history and clinical history. The key findings were almost 1/3 of our patients were suffering from residual pain defined by VAS score more than 5, and all the 5 domains of DVPRS were adversely affected. Pain score was 5.1 and it was unacceptable. So, big numbers, we decided to go ahead with big target. Target was set to reduce DVPRS pain score by 50% or more. It was based on the performance benchmarking of previous study. First, problem analysis. We opted for root cause analysis using fishbone. We found that multiple factors are there related to people, resources, process, and culture. For quantification approach, a team of doctors sit together and then rated them on a scale of 0 to 10. After that, we found that 5 factors are scoring more than 5 and 1 factor is on borderline. Subsequent parameter analysis was done, and then we decided to select 6 key areas for our action. These key areas were targeted using development of pain management protocol to improve escalation, intervention, and assessment, training of doctors to improve knowledge and lack of technical expertise, and communication gap was taken care of by acute pain service team. First, the pain management protocol. To improve communication, assessment, and decision making, a pain management protocol was drafted. We drafted an acute pain service form to take care of decision making and treatment. For the purpose of treatment, we followed WHO step ladder pattern. To improve the training, theoretical classes and practical classes were conducted, and resources were augmented further with the help of higher management. Acute pain service team started functioning in close collaboration with Department of Surgery and Orthopedics that were key to our success. It helped us to improve interventions, communications, and ward-based pain management improvement were also there. This Gantt chart is showing our timeline. We started our journey in the month of April 2023 and continued till July 2024. This project was registered as Systemic Improvement Plan and was part of our annual business plan. For the purpose of monitoring, we conducted periodic performance review. Annual feedback, annual implementation, post-implementation survey was conducted in the month of January to March 2024, over 48 patients, and in comparison to the pre-SIP scores, it was found that all the scores favorably with 50% reduction in pain score. And the burden of pain has reduced, the fraction of patients suffering from residual pain was reduced to below 10%. But the most used modality was pharmacotherapy modification. It indicates the importance of multimodal analgesia in acute pain care. Other interventions included USG guided blocks and epidural analgesia. Day-to-day performance review was conducted for a referred patient. It was found that structured pain management was helpful in reducing pain after intervention. Monthly review was done to assess performance and sustenance. It was found that pain after intervention pain scores were hovering around 3 or lesser. The number of references were increasing. We decided to adopt this as a systemic, as a SOP for our department. So KPI movement was outstanding. We were able to achieve 50% target. Benefits are recurring and sustained, and we can include other pain services like non-traumatic pain, and training of new interns is important to improve it further. So as a summary, we were able to achieve intangible and tangible benefits. We were able to reduce pain and improve better quality of life, and pain scores were as per our target. That's all from my side. Thank you.
House is now open for question and answer session.
Yes.
Yeah, madam wants to ask.
All the videos were statistically analyzed, and p-value was less than 0.05, and they were statistically significant for all 5 parameters of DPRS. Not in that slide.
What are the type of patients that you chose for this?
So basically, we were assessing the patient after admission, within 24 hours admission after trauma. All the patients were analyzed
Was
for
it
the
only trauma
survey.
patients that you have done?
So 48 patients were survey were conducted for the first time in the month of March to April.
So trauma at different levels will have different kinds of pains.
Yes, sir. Yes, ma'am. We will surveying all the trauma patients irrespective of nature of trauma. We were seeing the whether the nature of trauma is similar or not. But they were found to be similar in our
What about
study.
head injury
Thank
and all?
you.
No, not
Thank
head
you.
injury.
We'll go
That
for
is
the
what-
next
that is not
presentation.
well
It was
defined.
completely
Then what
orthopedic.
type of patients that you have chosen for your
Okay, okay, thank you,
study?
thank you.
Because
No further
different
discussion.
types of pain are also defined. So
Yes,
you
ma'am.
have to see that what kind of patients will have
Made
different
even
kinds of
detailed
pain.
analysis of our study. We had studied that what are the pain scores are for different kind of injury, for upper limb injury, lower limb
Earlier
injury.
question answer,
and
no
other
discussion,
injury.
please.
And we found that pain scores are variable, and so our intervention strategy was targeted as per the nature of injury, and that's why we achieved.
Then you have well defined how, what to give for that pain.
Yes, ma'am.
And then you have seen the VAS score.
Yes, ma'am.
Thank you. Thank you, doctor. We'll go for the next presentation.
Thank you, ma'am. Thank you, sir.
Thank you, sir, very much. Our next participant is Dr. P. Shravan Sai Kumar, RSP Rourkela, and his topic is Revolution Healthcare Service Delivery Implementation to HIMS in the Tertiary Care Hospital.
So good morning, one and all. So today I'll be presenting about the concurrent feedback system through HMIS, how it improves quality of care and patient satisfaction in a tertiary hospital. So to start with, there are the effective interactions between the healthcare systems and patients is a need of the hour, where the patient feedbacks will act as a tool for audit tool for improvement of quality of care and enhance patient satisfaction. So now the corporate hospitals are working towards patient delight, whereas the public sector hospitals and government hospitals still struggling for the patient satisfaction. So the current method will will help as a tool in enhancing the patient satisfaction. So need patients were this, who are up in the area redressal. We have analyzed, there were like a traditional feedback system which was recorded at the end of the discharge of the patient. So they were not addressing, it was not addressing the grievances which were faced by patients during the hospital stay. So through this system, we have tried to change the opinion of the patient from dissatisfaction to satisfaction through timely interventions. So the study was conducted at ISPA General Hospital, which was a prospective observational study conducted for 6 months. In the first 3 months, we have analyzed the traditional feedback systems. We have intervention through this tool, and then we have analyzed for the next 3 months. The size were, and it was inclusion criteria was all the admitted patients were included who were voluntarily giving the feedback. Exclusion criteria was the OPD patients and the patients who has technological limitations through given the patient feedback. So the study tool was patient feedback system through HMIS, IGH care application. We have done the root cause analysis for the patient dissatisfaction. All these factors was contributing to the patient dissatisfaction. The main two causes were like there was no proper grievance redressal system for addressing the patient grievances, and the one which had the traditional feedback system through feedback forms was not serving the purpose. So to modify this, we have done a plan to check act cycle, and we have planned for a tool which is like by integrating the IGH care application, which is in practice in the hospital, with the HMIS. And we have sensitized the patients through QR code display, IAC material display in the patient care areas, and through counseling during the admissions about the feedback systems. So we have monitored through the feedback, and the feedback is routed through, like the corrective and preventive actions were taken by the HODs who are receiving the feedback. So this is how we have sensitized the patients through IEC materials. And this is how the feedback section was named as a Prayas. So this is how the feedback works. So when the patient gets admitted, the Prayas section automatically pops in the IGH care application, where the patient can log in with his CR number and provide his, select his category of complaint and describe his grievance, which is routed through the HMIS to the concerned stakeholders like HOD and HOM and others through SMS and through HMIS. So the HODs will act timely to take the corrective actions. So these were the feedback categories which we have employed in the Prayas section. So when we have analyzed the response rate through the feedback forms was just 14%, which was increased to threefold when we have done through Prayas. So the patient footfall for grievances was reduced to 1 per day from the 9 per day in the previous section. So the turnaround time which was mentioned, that was not defined in the traditional feedback section, but through Prayas it was like maximum up to 48 hours. The patient satisfaction score was dramatically increased to 4.67, which was good to excellent. And previously it was 2.2, which was dissatisfied to neutral. So these are the categories where we have received the section. So at the end, during the discharge, at the time of the discharge, the patient, based on the redressals of his grievance, he will provide the feedback. So he will rate from 1 to 5. So final average ratings when we have taken, so for the different categories was shown here. So to discuss, there were no similar kind of studies to compare with the system. Like all the studies in the literature was about the feedback which were taken at the discharge of the patient, not during the stay of the patient. So other PSUs and government hospitals do have a redressal systems which have in the form of administrative control rooms, which are manned by the doctors or the MVA personnel. So to conclude with, this is a perfect tool for the total quality management, as it is involving the top management, it is focusing on the customer needs, patient needs, it is engaging our employees, and it is it is striving for the continuous quality improvement. So it is patient-centric. The patient need not to move to the administrative area for his grievances. It is breaking the communication barriers, and it is helping the professional development of staff through staff engagement, and it is cost-effective method. Thank you.
Thank you. House is now open for question and answer session.
Good morning, sir. I am Dr. Bishop Mukherjee from AISMOC Burnpur. I have a question for you. You said that your patient responses was 51%.
Yes, sir.
Do you think that this can be improved further? If what are the steps you are taking for further improvement of this response?
Yes, sir. Because we have taken in the limitation, the technological limitation, that patients, all the patients may not be giving feedback through the online method. So now we have sensitized our staff too. So if anyone wants any assistance, the staff will help, or the patients who are the bedside, other patients may also help in the patient feedbacks. So we are sensitized staff. We have ward masters who are helping them in providing the feedback.
Are you carrying out any awareness program for this?
Yes, sir. During admission, we counsel them about the feedback sessions, and we have that IEC materials pasted everywhere, sir. So we will sensitize the patients during admission.
Oh, thank you.
I have a question for you.
Yes.
Can we go back to the slide where you were displaying the results at the start and at the end of your study? Are the results statistically significant? It doesn't indicate anything on the slide.
Sir?
Are your results statistically significant? It is not evident on the slide.
Yes, sir. Yes, we have like statistically not measured the results because we are continuing further for the studies. So we have done for just 3 months, so we are further continuing the study.
No, the results may not be significant.
Yes,
also.
yes, sir.
Thank you.
Thank you. We'll go for the next presentation.
Thank you, Shravan. Our next participant is Dr. N. Narayan Swami, VSP Visakhapatnam, and he'll be presenting his topic, identifying the gaps in the services to the patients and improve the system in a cost-effective manner.
Yeah, good morning, respected chairperson, judges, and delegates and colleagues. Welcome to the, thank you for your giving me the opportunity here. I'm presenting this paper only to improve, see the improvement on this thing. So, this is the health center where we want to conduct the TQM and see the results, because the problems facing have been plenty, and we have a lot of complaints. At the same time, we want to have the cost system, control the cost system, as we know the RNL is under the turmoil with losses. So here, this health center is located approximately 22 kilometers from our main hospital. Here we treat approximately 2,500 to 3,000 patients per month with various categories, OPD, emergencies and all. It problem support of our higher authorities. First is the software program we used to treat here in this setup. So decisions were taken for this to cost cutting implementation techniques. One is we want to remove the ambulances, which is costing extra ambulance, which is costing 1,85,000, and the night shift where there are very few patients coming in the night. So we want to relieve the doctor and give this help. So this how this amount is saved. We have projected here. Offline prescriptions to be stopped completely. So does the excess medication and excess spent on the medicines to be cut down. So reduce the patient waiting time is one of the core. So this is the staff at the PHGHC who are involved, the doctor, staff nurse, pharmacist, dresser, attendants, and security. The process is first was to function normally, then only we can control the expenses, because all the treatment goes through this first. If first is impaired, the whole system gets failure. So this is related with the computer internet. So there was the problem with the power, because it is a peripheral unit. The power is from the state electricity boards, and the UPS was also was in trouble, and so we want to update these things and get into to cut down the cost. So our quality management totally focused by avoiding overcrowding, reduce waiting time to 0 levels, at the same time improving the quality. Commitment from both management and employee who serve patients to VHS with optimal utilization of manpower. PDCA and quality improvement charts, diagrams for quality approach has been done. Based on existing changes like receiving patient properly for coordinate patient, doctor time allocation requirement met with involvement of support from cross-functional areas and strategic management's total commitment to the total extent concerning customer satisfaction for feedback and grading outcome. So standard approach was selection of a theme. This is improve total service by providing in time, attending and properly disposing the patient. The present system, there was the overcrowding, the dissatisfaction total service, improper maintenance of materials, costing due to offline prescription. Analyzing the present situation, suboptimal manpower utilization, decreased time for attending the patient properly, disposing the case in time, flow of patients and handling, smooth flow of operations, stopping manual prescriptions, non-availability of first for pharmacy and undue crowding were the major problems to be corrected. They set the different countermeasures in motion, implement the chosen alternative. This was depicted through Ishwaka fish bone diagram and checklist. Changes in manpower deployment, machinery, a gadget deployment, material as well as time slot with optimal space management using required infrastructure. So why we are doing this TQM, or we are doing this to improve this quality? Is the plan is to strategy to begin and initiation. What will change process? Will TQM come to this team progress? And how to measure the success product is expected to each individual or stakeholder proactive approach. Selecting the theme, ensuring the availability of services through the able manpower management, HR finance, avoid delays, avoid overcrowding, synchronization to practical requirement for cost benefit, need to improve standard skill and compliance of services. Operations is quantum of work to be smartly handled, not using the software to handle the situation was the problem. And then commercial acumen there is to maintain proper coordination with synchronize of personal preference to location of the work. So this is a proper utilization of the system, improvement and cost-effective manner was the theme for this thing. Goal is to shift the focus from people to process to achieve higher level of customer satisfaction and be an excellent business organization. For which purpose to address the problems, the following areas were addressed for ensuring continuous improvement. Areas of focus, processing improvement in contact point with the customers, especially OPD and pharmacy. Demand was based on the optimal cost, space, and resource management. So this is 7 QC tools, process flow diagram, checklist, satisfaction. So registration, patient presentation, wait in queue, doctor examines, attend the patient. So these are the checklist sheets we have used for this. And this is what the man, material, and command, CPU and monitor damage stabilization, uninterrupted. We have improved all the employees, retired employees, dependent, excluding children. Method was circular model. We have used where P is equal to experience. These are the variables, tangibles, reliability, responsiveness, assurance, and empathy. So this is offline prescription. After the involvement, we have seen this. This is the graphic representation before and after the TQM. So we can see the linear deceleration in the offline prescriptions, and at the same the improvement in the tangentials and this thing, you can see this, there is a reliability, this is a positive indicator where there is improvement in the services. And there is a definite correlation to the time allocation to the patient being, correction to bringing change in the following question of demand services. Thank you.
The House is now open for question and answer session. There are no questions? Madam will be asking one question.
Hello, I'm Dr. Bonishika Roy Chaudhary from Rourkela Steel Plant. Sir, I want to ask one question. This entire thing is your quality management is based on the internet, I suppose. So what steps, since it's a peripheral area, what steps you have taken to improve that? Since you are saying there's an electricity problem and other problems.
Yes, madam. There was, the alternate power supplies, which was the generator and the UPS which were used was again brought into the conditions by throwing AMC and changing the batteries. And the broadband connection, which was there earlier was the landline broadband, we made it to the fiber net broadband. Apart from that, we have used the Wi-Fi dongles, which even though there is no power supply, if we connect to the net, it is working. So through that, we manage the system.
Thank you.
Thank you.
Yeah, one more question, sir.
Sir, I'd like to ask you one thing. Sir, you must have started with certain objectives when you started doing this process of TQM. And at the end, did your aims and objectives, were you able to meet those? Or there were some lacunae, some shortcomings which you got to realize during the procedure?
Thank you for your question, sir. Yes, we definitely reached that shortcomings because I told you that there was the power supply and demand, there was the offline prescriptions which the medicines are going away without any notice because of failure of the computer system itself and the server connection. So what we made is, we made that system into properly by adopting regaining the functioning of these systems. Followed by, we have done the survey to know whether these people are get satisfied or not with whatever the actions taken by the management. For that also we got a positive result where there is their expectations and pursuance. That circuit model what we have used helped us to solve the issues, and we are on the positive side. So like that we saved some cost and time also.
Thank you, doctor. The session is now closed. All the presentations are over.
Thank you, sir. Here we come to the end of this session. Now, I may request Dr. Jichendranath Sarangi, sir, CMO in charge, Visakhapatnam, to kindly present a token of appreciation to our judges. Dr. Radha Satpathy, sir, Dr. Parmanand Rath, sir, kindly grace the dais. Sir. Thank you, sir. I may now request Dr. Raj Ranjan Kumar, CMO in charge DSP Durgapur, to kindly present a token of appreciation to Dr. P.K. Mahapatra, sir. Thank you so very much. Now I may request Dr. Jitendra Nath Sarangi to present a token of appreciation to Dr. Raj Ranjan Kumar. And Dr. Raj Ranjan Kumar to present a token of appreciation to Dr. Jitendra Nath Sarangi. Thank you, sir. By this, we come to the end of TQM paper session. Now, next is our guest lecture 4. I request Dr. Snehal to kindly conduct this session.
I may now request Dr. Rakesh Gautam, Additional CMO, BSL Bokaro, and Dr. Sonia Joshi, Additional CMO, RSP Rourkela, to chair the session and kindly grace the dais.
There's one announcement. I request all the steel plants to kindly deposit their first prizes and running seals at the backstage today as soon as possible.
I request Dr. Rakesh Gautam, Additional CMO, BSL Bokaro, and Dr. Sonia Joshi, Additional CMO, RSP Rourkela, to kindly grace the dais. Thank you, ma'am, and thank you, sir. In this guest lecture, our time duration is 30 minutes, 25 minutes presentation is there, out of which 20 minute first puzzle will be there, and again after 5 minutes, second puzzle will be there to mark the end of presentation, and 5 minutes will be the interactive discussion. I may now request Dr. B.S. Srinath, MBBS MS, PG, IMER, FRCS Edinburgh, FRCS Glasgow, and Managing Trustee at Bakchi Shri Shankara Cancer Institute and Research Center, Bhubaneswar, to present the topic. The topic is use of artificial intelligence in prediction. Request Dr. B. Srinath to of the institute and senior consultant oncologist at Bakchi Shri Cancer Institute. 1950 has dedicated a decade to care, particularly focusing on. He has worked at prestigious institutes like Tata Memorial Hospital, Kidwai Memorial Institute of Oncology, establishing a comprehensive facility in Bangalore. Dr. Srinath is recognized for his advocacy in cancer preventive surgeries, especially through provoking affordable treatment to underprivileged community. His contribution has been acknowledged with the award such as Karnataka State Rajyotsava Award in 2020. I invite Dr. B.S. Srinath to present his topic, use of artificial intelligence in predictive cancers.
Good morning to all of you. I am delighted to be here this morning in the All India Steel Medical Conference and share my thoughts and knowledge on one of the important emerging topics, and that is the artificial intelligence, its implementation in delivering healthcare. At the outset, let me thank the organizers for extending this invitation to me. Artificial intelligence has become a very common terminology used in the medical parlance. It has been pervading the healthcare for almost last 2 decades, becoming even more important as we go on. This is the Bakchi Shri Shankara Hospital in Bhubaneswar. It is a 700-bedded comprehensive modern cancer hospital. It was inaugurated exactly 1 year ago. And this is our first hospital we started, a 520-bedded charitable cancer hospital in Bangalore. It has also a research center and a community oncology institution. What is artificial intelligence? It's a very broad term used in the computer science parlor aimed at machines which are capable of performing tasks which otherwise typically would have been done by intelligence. It is, in other words, an extension of the human brain, and what is it that we do to actually direct the machinery or the There are many techniques of artificial intelligence which are used. The next 10 minutes, I will be speaking on the basics of artificial intelligence, how to understand it, and the next 10 minutes, probably I will be the application of artificial intelligence in predicting various issues in cancer. One of the techniques is what is called machine learning. All of you must have read about this in newspapers, in journals. What it actually means is identifying typical patterns in a large volume of data by going through methodically, creating various algorithm models, and this can actually use various types of data. It could be a text, which is what we see in case files documented by the doctors. It could be images such as X-rays, pictures, ECG recordings, ENMG recordings. It could be videos. All of this could be actually interpreted, used in the evolving machine learning. And these large known data patterns are then used to test the unknown. How do we do that? When millions of data points are actually available to that, which we know, and from that emerges certain conclusions. These conclusions are extrapolated on those which are being tested. I'll come to that a little while later. The second methodology is actually what we call as dense computational neural network. This behaves exactly like the human brain. If you see that human brain has axons and neurons, neurons are the nodal points, and then the axons connect each other, and the impulses are received at the superficial surface, and in layer by layer, they are connected through various nodes. We identify an image, we identify a border of a structure, we identify from childhood, we identify various things that we read or see. Deep learning, computational neural networks picks up multiple data identifiers in the large data sets that we through the interconnected nodes and releases the output. Now, this is a little bit difficult to understand. I'll just explain to you. The data is stored in multiple layers, just like the tiles that we keep one above the other. And as it gets sieved through, the output comes out. Now, this is a graphic representation. You can see the dendrites there receiving impulses from various points, and then it goes through the myelin sheath, and the output is given through 2 or 3. Whereas here you will see multiple inputs, ends up with 1 or 2 inferences. Now this is what happens exactly when you look at deep learning, or it is called as neural networks. Now you see here that these are the inputs. Nodes are in multiple layers in the analysis. These are algorithms created by the computer scientists, and finally you get the outcome. You can have large number of data points, what we call as covariates, multiple covariates, sometimes even millions. Not be actually assessed by our standard statistical means, can easily be done through this kind of deep neural network technique. Now we actually did one small study. We had about 100 and odd cases of facial reconstruction after head and neck surgery. Some of these patients had to undergo resurgery within hours of the first operation. Actually had to do exploration and cause. There are variable factors. 9 factors we studied to find out what could be the cause for the failure of the first surgery and what made us do the resurgery again. Now, what we found out was that it was because of the administration of heparin immediately and before and following the surgery, that there was excessive oozing, and that was the reason for hematoma formation, and that was the cause for recurrence. Now, re-exploration. Now, the thing is, you can see here that the results were accurate to the tune of about 93.8%. For this to achieve, we had to submit the entire data until 10 nodes, that is downward dissection up to 10 points. Now the next one is, this is just to, what I explained to you is just for you to understand what actually is the neural network. The next one is what is called as convolutional neural network. Sophisticated. What actually is, when you actually analyze the data, you take a large histopathology slide, and when you look under the microscope, you keep moving the slide so that you can see the whole picture. In pathology slide, the whole could be at once, and when you do that, you have to segment and filter so that you focus on the interest and submit it for analysis. Pooling this actually means downsizing the samples and also increasing the image capture. This can also actually capture the spatial hierarchies. Now, what is spatial hierarchies? Now, in a slide, in a tumor, cancer cell, there are tumor-associated fibroblasts, there are lymphocytes, and there is interstitial matrix. Now, it is known now that although the change happens in the gene of the cell, there are lots of influences from the surrounding area which is responsible for what we call as tumor microenvironment, which is responsible for the cell multiplication and chemotherapy resistance, radiation resistance, and all those things. Now, if you want to study that, you can dissect it properly as spatial structures can be dissected and analyzed properly. This is all done through automatic analysis. Now, this is what I meant by the slide. If I'll go to the next slide, you can see here, there are tumor cells, there will be a lot of interstitial matrix. This is a breast carcinoma slide, you can see here. Now, each one of that is responsible for in its own way. In order to understand that, you need to dissect this. Now, for example, I will be discussing again, but some of the molecular markers of the tumor can now be examined, assessed, and their positivity can be quantified even by just examining a hematoxylin eosin staining of a slide. Now, if there is any pathologist, they will understand this very much easily. Now, another one is what is called as large language processing models. Now this is huge number of data is provided for this. It can actually be used for various issues in the hospital management as we discussed just now, patient educational material, clinical decision supports, and even in predicting the prognosis. What are the applications of deep learning? That's in other words, how do we use the artificial intelligence to make the lives of our patients better? You can actually do the image analysis is a very breakthrough. You can unlocking the secret of genomics. What it actually means is this: genomics, next generation sequencing or whole genomic sequencing actually throws up large volume of data, and some of the tumors have more than 1 or 2 driver genes which are responsible for the tumor formation, and particularly in some sarcomas and in poorly differentiated tumors, you see large number of gene changes, which are mutations, which is very difficult to decide which one of them is responsible for creating the tumor, cause of the tumor. When such large volume of data is provided, it is extremely difficult for us to discern what is exactly the cause. This can easily be done by using deep learning methods. Now, predicting treatment response is also very important. It can be done by using deep learning. And I will tell you about the improving prognosis in a while. Now, the next thing is to go for the main issue, and that is predicting cancer. Now, it's a very difficult topic to talk about, because are we talking about predicting the occurrence of cancer or predicting the recurrence of cancer? Are we talking about the prognosis of cancer? What are we predicting? There are large number of issues which we are now seeing, which are being predicted in cancer. So now I have just taken them one by one, and I will just give you a brief introduction to each one of them. The first one is to actually identify the risk of occurrence or early diagnosis. Now, in one of the studies in breast cancer in Emory University, they analyzed 120,000 mammograms. Actually, for analysis, when you do the mammogram on both sides, compare one with the other, the right with the left, right, and identify in the mammogram. By submitting large number of these images for deep learning, you can identify the architectural asymmetry that is seen. I will show you next, and also an architectural distortion in the digital mammography. It may be very subtle that it is not seen commonly. I will be showing you one example of that, but that is much clearly seen. You can see here, when we compare the images, you can see this is the architectural abnormality that is seen. Now, when this is subjected to digital analysis and a biopsy was done, needle-guided biopsy, it turned out to be malignant. Now, so it is now possible for us to say and detect and that breast cancer at a much earlier stage than by using this methodology. Now, how do we prevent? When actually they studied these breast images of 1.2 lakh individuals, they found out that the breast cancer predicted, upcoming breast cancer could be predicted within 5 years. 1 to 5 years, they could predict the individuals who could be at risk of developing breast cancer. Now, I think what it means is you can actually predict the individual who is at risk of developing breast cancer by just seeing the serial breast images of the individual previously done. Now, we use artificial intelligence not only in diagnosis or the prediction, we also can predict of cancer. I will just tell you about that in a minute now. Now, the other areas is not one mode of prediction, not one mode of examination, but multiple modes. For example, you can use the X-rays or images, pathology slides, you can genetic data that is actually given, and you can molecular reports. And when you put all together, you can create a score which will not only give you the prognosis of the patient, but also sometimes gives you new staging methodologies. Carcinomas, when they studied these cells, tumor, they found that there were fibroblasts, and which was usually seen. They studied fibroblasts. They were secreting a substance very similar to epidermal growth factor, which is responsible for multiplication of the tumors. When they molecular study along with radiology, that is the MRI of the liver, they could actually stratify the hepatocellular carcinoma into different types so that the prognosis could be predicted. In our own hospital, what we have done, in a retrospective analysis, we have submitted colonic tumor specimens for gene sequencing, and we have done molecular studies on them like MMI, ARAS and NRAS, and also studied the proteomics. In this, we could actually classify the 5 different immune types, subtypes, which would be amenable for chemotherapy response. And cancer, it is now well established that they have used multi-omics to stratify
For peripheral nerve group block, similar amount of the drug was injected deep to the iliopsoas muscle, targeting the articular branches of the femoral nerve, obturator nerve, and accessory obturator nerve to the hip. The probe used here was the curvilinear probe. Then a waiting period of 30 minutes was given for the local anesthetic to act. Reassessment of the pain scores were done post-block. Those with a lower pain score of less than 4 had the ease of spinal positioning. Patients of both the groups showed similar reductions in the pain score post-block. However, at movement, patients of pen group showed significant reductions in the pain score as compared to the fascia iliaca compartmental block. Hence, the ease of spinal positioning scoring were better for the patients of the pen group and were statistically significant. As for the satisfactions group, patients of both the groups were equally comfortable and were statistically insignificant. Cadaveric studies have shown accessory obturator nerve, in addition to the femoral and the obturator nerve, have impressive contribution to the anterior hip joint innervations. These are basically the nociceptive sensory fibers. So blocking these nerves result in complete analgesia, which we achieve in pericapsular nerve group block, where the drug is deposited quite close to the anterior hip capsule. Whereas on the other hand, the fascial compartmental block targets the major nerves to the anterior hip joint, and sometimes it misses the obturator nerve because either due to anatomical variation or the amount of the drug injected were low. And it definitely inconsistent in blocking the articular branches, resulting in inadequate analgesia. So in this study, we found pericapsular nerve group block has better pain relief at positioning than the fascial compartmental block, and where our findings were similar to the previously done studies. However, we differed in the patient satisfaction score, which was almost equal. These were the previously done studies where pen group showed superiority of the pen group over the fascial compartmental block on positional pain and post-off analgesia. So at the end, I conclude, for hip fracture pain, pericapsular nerve group block offers improved patient positioning for spinal anesthesia, higher patient satisfaction, motor sparing complete analgesia, consistent outcome, and hence it can be a better alternative to the existing regional analgesia technique. Thank you, and these are my references.
Two questions allowed from the audience. There's one hand there. Dr. Rishi. Introduce yourself first.
Good morning, Dr. Rishi from Tata Memorial Hospital. In your clinical context, the purpose of block was to ensure early positioning of patient with. In the clinical context of your case, the purpose of block was to ensure pain-free positioning.
Yes, pain-free
So,
positioning.
but you did not evaluate the onset of the block, because earlier position was required in all these cases. If the onset is faster, the block you will be able
So
to.
we are waiting for 30 minutes. We are not waiting for
But
the
why- but
onset
you
of
could-
the block here.
But you could have evaluated the effect of block and started
The
positioning
onset
earlier.
of, because it was a short paper, we cut shorted, but onset of the block was faster in the pericapsular nerve group block,
And what
10
about-
minutes.
And what
around
about
the-
the time taken to perform the block?
So time taking to perform the block was depending upon the skill of the operator.
As far as the experience and literature is saying that it is more in case of PENG and less in case of FNCB.
But yes, it is true, because the suprafacial iliaca block is the superficial block. But this is also an easier block, will come with the practice.
So will you recommend?
Rishi, no discussions, please.
Thank you.
Anybody else? There's a hand here.
hysterectomy, as it prevents the ascending infection of the vaginal microbes into the peritoneal cavity. Now, vaginal vault can be sutured by laparoscopic and or by endosuturing route. As depicted in the video, in endosuturing, we are carrying out this operation in the peritoneal cavity. We put the sutures through one of the ports and we secure the angles and take full thickness bite from the anterior lip and the posterior lip of the vault. We put intercorporeal knots and thereby we carry out the suturing. Another method is doing by transvaginal suturing. As depicted in the picture, here we catch hold of the anterior lip, posterior lip and the two vault angles by using Alice forceps. And after that, we carry out the operation by traditional method whereby the sutures are passed from down below, vaults are secured and full thickness bite is taken from anterior and the posterior lip of the vault. When comparing these two, in endosuturing, the vaginal margins are inverted and the sutures are not contaminated by vaginal microbes, whereas it is technically demanding, costly, and the learning curve is very much steep. And the suture tension is maintained by the instruments. Whereas the transvaginal suturing is less time consuming, suture tension is maintained by surgeon's hand, but the vaginal margins are everted and the sutures are contaminated by vaginal microbes. There has been a few studies done to compare these two methods of suturing, as there is no standardized opinion has been found. I have quoted a few. Two of the above studies showed that there is less cuff complication in the endosuturing group, whereas the down below study, that is a retrospective one, that found that there was more cuff complication in the endosuturing group. So we decided to carry out this study to compare the laparoscopic and the transvaginal suturing of the vaginal vault at the end of total laparoscopic hysterectomy in terms of vaginal cuff dehiscence and other minor cuff complications. After taking ethical clearance and proper consent form, we compiled the data over a 6-month period from the month of May 2024 to October 2024, and the cases were divided in 1:1 ratio in two groups. Thus, over this period, we got 8 cases in each of the arms. The cases of total laparoscopic hysterectomy due to benign condition were included in the study, whereas those cases where there is suspicion of malignancy or patient is not fit for Trendelenburg position were excluded. To minimize the confounding factors, we did the suturing by running single layer 1,0 Vicryl. Posterior peritoneum was included to minimize the raw surface area. Intercorporeal knots were given. Antibiotics were given preoperative and 48 hours postoperatively. Patient follow-up was done at 4 to 6 weeks and 3 months after surgery by doing per speculum examination and filling questionnaires. The timing of start of the surgery to the start of the first stage and ending of the last stage of the vault was noted. The surgeons used the same endoscopic instruments and the vault was opened by bipolar energy. The parameters that we studied were the minor cuff complication like vaginal bleeding, vaginal discharge, and vault granulation tissue as depicted in the picture. And among the major cuff complication, vaginal cuff dehiscence was noted. When comparing these data, both of the groups were comparable to mean age, BMI, and the comorbidities. Suturing time was higher in the endosuturing group, that was 21 minutes as compared to 12 minutes in the transvaginal group. There was no major cuff complication in either of the group during the follow-up period. Among the minor complication in endosuturing group, vaginal bleeding was less, whereas the vaginal discharge was similar in both of the patient groups, and there was no cases of vault granuloma reported. To summarize, the suturing time was significantly higher in the endosuturing group, complications were more in the transvaginal group, patient satisfaction in terms of vaginal spotting was more in the endosuturing group. We need to continue this study over more number of patients, and of course there is scope for continued professional education. So to summarize, although it is an heated debate which one is better, it can be considered laparoscopic suturing as the preferred approach for vaginal cuff closure at the end of total laparoscopic hysterectomy. Thank you.
questions from the audience?
Are you routinely doing vault suspension laparoscopically?
Thank you for the question. While doing the laparoscopic hysterectomy, when we are opening the vault, it is a routine practice. We cut the vault above the arc formed by the uterosacral ligaments. So while doing the suturing, we take one bite in the uterosacral ligaments also. That prevents the future vault prolapse.
What is the rate of vault prolapse in laparoscopy versus open or vaginal hysterectomy?
When it has been seen, the vaginal hysterectomies that has been done by, if the maculocultoplasty is not being done during the vaginal hysterectomies, the rate of vault prolapse is more in case of vaginal hysterectomies, because most of the cases the vaginal hysterectomy is done in the post-menopausal patient when there is first degree or second degree or complete descent.
Somebody else, one more question?
Hello. What were most of the indication for TLH in your cases? I mean, the total 8 cases were there for total laparoscopic hysterectomy. What was the indication of those cases?
Thank you for the question, madam. Actually, there were total 16 number of cases that went total laparoscopic hysterectomy, 8 of them in each of the arms, and it has been seen most of the cases, fibroid was the most common indication. Whereas the fibroids, those were symptomatic and patient wishes did consent, and no other conservative measures were successful.
Thank you.
Thank you. That should be all.
Thank you.
I may now request Dr. Ramanuj Sharma, BSL Bokaro, to present his topic, a comparative study on MIST, minimally invasive surfactant therapy versus ensure intubation, surfactant administration and extubation in NICU.
A very good morning to honorable judges, respected chairperson and my senior. I am presenting a comparative study on MIST, that is the minimally invasive surfactant therapy, versus ensure intubate, surfactant administration and extubation in our NICU at BGH. Preterm neonates with RDS are commonly deficient in surfactant due to inadequate production. The surfactant is a surface active agent which is composed of phospholipid, mainly in the form of phosphatidylcholine and surfactant specific protein that is secreted from the alveolar type 2 cell of the lung. Surfactant reduces the surface tension, promote lung expansion during inspiration, and prevent alveolar collapse at the end of expiration. Its production usually begins from 20-week gestational age onwards and peak concentration in alveoli beyond 35 weeks. So the incidence of RDS is inversely proportional to the gestational age. Preterm neonates with RDS are conventionally classically treated by INSURE technique, but nowadays newer minimally invasive strategy for surfactant therapy are being increasingly used to manage RDS in most of the higher center. One of them is MIST approach, which avoid intubation while minimizing airways damage and barotrauma. Our aims and objective were to study the efficacy and safety of the MIST versus INSURE by the means of study the need of mechanical ventilation in the first 72 of our life after giving surfactant by either technique, and to also to a study of adverse event during surfactant therapy like apnea, bradycardia or desaturation and hospital stay. The inclusion criteria were preterm neonates of age 28 to 34 weeks, which on CPAP of 6 centimeter of water and with RDS based on the clinical and radiographical criteria, and the FiOT requirement more than 40% on CPAP. The exclusion criteria were presence of any congenital anomalies, need for mechanical ventilation at the time of birth, any congenital heart disease, Apgar score less than 5 at 10 minutes, and those parents who did not give consent. This is a hospital-based randomized control study we conducted at BGH over a period of 9 months in our NICU. The informed consent was taken from all subjects involved in the study, and the study was approved by the Institutional Ethical Committee. The RDS was diagnosed clinically by a score in which used in the preterm, the Silverman-Anderson score, and the suggestive chest X-ray, which done immediately. Every baby should put on nasal CPAP on PEEP of 6 centimeter of water. The picture shows the Silverman-Anderson score, which is used in preterm neonates, which contain upper chest retraction, lower chest retraction, required retraction, and near dilatation and expiratory gland. More the score, more is the severity of respiratory distress, and also chest X-ray with suggestion of RDS. This picture shows the pre-procedure preparation in both the group. In the mixed group, we used a 5 to 6 French semi-rigid catheter and inserted 1 to 2 centimeter beyond the vocal cord under direct laryngoscopy, and after giving surfactant, we withdraw the catheter and nasal CPAP was continued as respiratory support. In the insured method, baby was intubated with appropriate side ET tube, and after surfactant installation, PPP provided and extubated and put on nasal CPAP. A total of 36 eligible baby, out of which 18 babies randomized to group A and 18 babies randomized to group, and every infant was closely observed until they were discharged from the NICU. Now the data, which simplify in a pie chart in the following. Most of the cases was inborn, but the inborn, the most of cases, 78% cases were unbooked. The mode of delivery and Apgar score in both the group were comparable. Also, the mean gestational age and mean birth weight are almost similar in both the group. The history of antenatal steroid and gestational diabetic mother in both the group were similar. Now the outcome. The table show the need of invasive mechanical ventilation in the both the group. The mixed group is less than the insured, and there were significant p-value. Although duration of nasal CPAP duration and O2 therapy and other complicated related apnea, bradycardia, desaturation are less in mixed and no significant p-value, but as the data sample is small, we can consider as it is significant outcome as we discussed in the table. So finally, we concluded that the mixed therapy reduces the need for mechanical ventilation, the duration of CPAP requirement, and the duration of oxygen therapy. It also less duration of hospital stay. So surfactant therapy using mist could be a good replacement for ensuring preterm infant with RDS. The limitation of a study was sample size is small, and there is need for further studies on large sample size. These are the reference. Thank you. Thank you for patience.
Questions from the audience?
Hello. Yeah. My question is, this was a randomized control study.
Yes.
So which was the control group?
Ma'am, actually it's a comparative study. Versus a comparative study versus insure and mixed. So we compare actually hospital-based comparative study. Randomized.
Not a controlled study. There was no control group.
Not only randomized study.
And I have another question. How did you calculate the sample size? Did you, what?
Yeah, we, in our NICU, 55 to 60 are admission and most of the preterm. So based on the, we have a statistician on the calculation on the basis of admission of the preterm. And the study are further going on. So, ma'am.
Thank you.
My question is, in the outcomes, you mentioned that ventilation, the hospitals say the need for CPAP.
Sorry.
Speak into the mic, please. We can't hear.
Actually, the significant p-value come in the need of mechanical ventilation. The other parameter, there is no significant p-value, but as the sample size is small, so we could not statically say that the significant difference. But the frequency of other complication in the mixed group is less than the insured group.
Thank you. No, a third question is not allowed. No. By the rule.
I may now request Dr. Preeti Srivastava, Tata Steel Plant, to present her topic, Analysis of Clinico-Etiological Profile of Early Onset Epilepsy in Children with Special Emphasis on Genetic Testing and its Impact on Management, Achieving New Horizon with Next Generation Sequencing.
Hello. Hello. Thank you. Good morning, everyone. Clinico-etiologic profile of early onset epilepsy with special emphasis on genetic, excuse me, the slide is changing on its own. Just a minute. Please bring to the first slide and start the time. Yeah. Time. Good morning, everyone. Clinico-etiologic profile of early onset epilepsy in children with special emphasis on genetic testing and its impact on management. Early onset epilepsy is defined as onset of seizure in the first 3 years of life. This can be complex and challenging and are frequently drug resistant. So specific targeted therapy based on specific etiology can significantly influence outcome, and there's lack of data on genetic etiology from the Indian subcontinent. So with this background, we took up a study to analyze the clinical, radiological, and electrographic profile. Again, the slides are moving on its own.
See, please stay there.
The slides are going on within 3 seconds, it's changing. Can you stop the... timing is reverse timing, slideshow. Deselect this, unselect.
Start from the beginning.
I'm sorry. May I begin?
Timer is ready.
The slides are still not coming. Okay.
No slide, the timer. Shall I start? Sorry for the interruption. Good morning, everyone. Clinical etiology profile of early onset epilepsy in children with special emphasis on genetic testing and its impact on management. Early onset epilepsy is defined as onset of seizures in the first 3 years of life. These can be challenging and frequently drug resistant. Specific treatment based on specific etiology can significantly influence outcome, and there is lack of data on genetic etiology from the Indian subcontinent. So with this background, we took up a study with the primary aim and objective to analyze the clinical, radiological, and electrographic profile of children with early onset epilepsy, and to determine the etiology of these epilepsies with focus on genetic etiology and impact on management. This was a prospective observational study carried in the IPD and OPD Department of Pediatrics in Tata Main Hospital, where children between 6 months to 9 years of age with onset of seizures in the first 3 years of life were taken. Sample size was 63 and study period was 2019 to 2024. Children with early onset epilepsy who came for at least 2 or more follow-up visits for a minimum period of 6 months, and those who underwent basic workup for epilepsy in the form of EEG and neuroimaging were included in the study. However, children with acute symptomatic seizures were excluded from the study. Data collection was done from detailed clinical notes from IPD and OPD using the HMS platform. Comprehensive EEG report from Neurolab and MRI reports from MRI done from 3 Tesla MRI machines were taken into account. Genetic testing was offered to children in whom a clear etiology could not be established after a basic workup, strong suspicion of genetic cause of epilepsy was there, or there was presence of neurologic disorder or unexplained death in previous child. Tests employed were clinical or whole exome sequencing or mitochondrial gene sequencing as required using the NGS platform. Genetic report were matched for genotype-phenotype correlation to see if the mutation was significant. Discussion with geneticists was done where required. This was the pre-designed patient pro forma where all details were included of every patient. Our results were as follows. There were more number of girls affected in our study with early onset epilepsy. Majority of children, that is 42%, had onset of seizures in the first year of life. History of perinatal asphyxia in terms of 1 minute Apgar was seen in 19% in 19 out of 63 children. 54 children had global developmental delay. 11% had positive family history of epilepsy, and microcephaly was seen in 52% of children. Based on seizure semiology, majority of children had focal onset seizures to the tune of 47%, and frequent seizures, that is seizures occurring daily or every 2 to 3 days, was seen in 60% of children. Based on different types of seizures, the most common were tonic-clonic seizures seen in 43% of children, followed by epileptic spasms or salam seizures in 19% of children. EEG was done in all patients, and 74% had abnormal EEG. Among the abnormalities seen in EEG, 35% had focal epileptiform discharges, and 19% have hypsarrhythmia on the EEG. MRI was done for 54 patients, of which 48% had abnormal MRI. Among the abnormalities seen, 16% had cortical malformation, tuberous sclerosis, and 13% had HIE changes. Genetic test was done in 28 children, out of which 22 had significant genetic mutation, 4 had inconclusive mutation, and 2 were reported normal. Following are the detailed list of 22 pathogenic gene mutations seen in our study, and based on the genetic mutations seen, 32% of children underwent modification in treatment. 2 could not be helped because ganaxolone and a molecule not available in India. Then coming to the etiology profile in our study, it was seen that the genetic etiology was the most common cause of early onset epilepsy, followed by perinatal asphyxia and structural malformation. We went a step further to analyze our study to see if children with high frequency seizures were significantly associated with abnormal EEG findings, and it was significantly associated with grossly abnormal EEG. However, in our study, high frequency seizures were not significantly associated with grossly abnormal MRI. So the question was, why did children with normal MRI had high frequency seizures? We then added children with normal MRI and pathogenic gene mutation to the group of children with grossly abnormal MRI, and we saw that it was significantly associated with high frequency seizure, emphasizing the need to do genetic testing in children with high frequency seizure but having a normal MRI. Impact of genetic testing was measured using the following parameters: ability to make accurate prognosis, which could be done in 78% of patients, ability to change or modify treatment, which could be done in 32%, and prevention in future pregnancy by doing antenatal fetal genetic testing in subsequent pregnancy done in 14%. So in our study, we saw that early onset epilepsy, the etiology could be established in 73%, with 28% had genetic etiology. Birth asphyxia was seen in 19%, and 32% children could undergo modification in treatment. So we see that genetic testing is emerging as an important tool for workup of early onset epilepsy. It helps in customizing treatment. Extended advantage is preventing recurrences in subsequent babies. However, constraints are availability. We at Tata Steel have been able to bring smiles to our 4 Tata Steel employee families where first child was diagnosed with a neurologic condition, but in subsequent we went for antenatal genetic testing and they had a normal baby. So at Tata Main Hospital, we also make tomorrow. Thank you.
Questions? Hello, myself Dr. Manoj Kumar Pankaj, General Surgery, ISPA General Hospital. Madam, my question is, how would perform MRI in a small child less than 3 years?
Yes, sir. Thank you for the question. Sir, in order to do MRI safely in young children is a very difficult task. So in the last few years, we have been able to put a SOP, a protocol in place where we have liaisoned with the anesthetist. We admit such children and do MRI by using the use of an anesthetist support. So we first get any child requiring MRI, we first get a PSC clearance. When the clearance is done, we admit the child, we book a slot, and the next day, the child goes with the anesthetist to the MRI suite, gets the MRI done, and comes back,
That
and then
MRI compatible anesthesia instruments?
So yes, sir, of course we have.
Because it's very risky to give general anesthesia and compatible things. Okay,
Yes,
thank you.
sir, thank you.
Next question, ma'am. Yes.
Yeah, my name is Dr. Rashekar from RIM Vizag. Madam, what is the criteria for your high frequency
Yes,
epilepsy?
yes, sir, just a minute. I would like to show you the criteria for high frequency seizure is seizures occurring daily or every 2 to 3 days. That is high frequency seizures. In children with early onset epilepsies, those mild subtle seizures like a drops, like a spasms might be missed, but those are very disastrous seizures, and in these cohort of children who are suffering from early onset epilepsy, these seizures are very frequent, like a case of tuberous sclerosis, like a case of cortical malformation or severe birth asphyxia, or genetic epileptic encephalopathy conditions. They have seizures so frequent that they might be having 16 to 20 seizures in a day. Very mild one, but they are seizures.
Have you included the atypical febrile seizures in this group?
Sir, I already showed in my study that acute symptomatic seizures were excluded. So a febrile seizure is a type of...
Atypical.
Yes, sir. Atypical febrile seizure is a provoked seizure, while epilepsy is an unprovoked condition, a condition where unprovoked seizures occur again and again. So atypical febrile seizure will not be eligible to be included in epilepsy.
Because there are certain...
Fire salvos, please. Thank you.
Okay.
Thank you so much.
I may now now request Dr. Shweta Verma, BSP Bhilai, to present her topic, Oral Cavity Cancer, Insights and Outcome from Our Experience.
respected chairperson, honorable judges, seniors, and my colleague, a very good morning to all of you. Today's topic of presentation is oral cavity cancer, insights and outcome from our experience. Oral cavity cancer is a serious global public health problem and is the 6th most common cancer globally. This highly aggressive tumor often advances locally and regionally, with tobacco and alcohol consumption being the leading preventable risk factor, thus making early diagnosis essential. Through mass screening, biopsy, advanced radiology, combined with surgical intervention, we can achieve successful outcome. Multidisciplinary team approach involving ENT surgeons, radiologists, pathologists, oncologists, dental surgeon, plastic surgeon is very crucial for improving the survival. South Asian countries, particularly India, Pakistan, and Bangladesh, reports the highest incidence of oral cavity cancer globally. In India, this is the 3rd most common cancer, with most affected age group being 40 to 60 years and a notable male predominance. Aim of the study is to analyze clinical presentation with special emphasis on early detection, diagnosis, and management of oral cavity cancer. This is a retrospective study done over a period of 10 years from 2014 to 24 in the Department of ENT of JL and HRC Bhilai. 270 patients with biopsy-proven oral cavity malignancy were included in our study and were analyzed. In our study, approximately 50% of the patients were aged between 40 to 60 years. It showed a clear male predominance with male to female ratio as 2.6:1. The most common site of involvement was buccal mucosa with gingivobuccal sulcus, followed by anterior 2/3 of the tongue. Approximately 85% of the patients had associated risk factors, including tobacco and alcohol consumption. What are pre-malignant conditions? Pre-malignant lesions are the lesions that have a potential to transform into malignancy if left untreated. Some of the common types prevalent in our areas are erythroplakia, leukoplakia, oral submucosal fibrosis. Understanding these conditions are very crucial for early detection and which can reduce the risk of malignant transformation. Over the past decade, we meticulously identified and followed 740 patients with a pre-malignant condition through our OPD and specialized clinic. Among these, leukoplakia and erythroplakia emerged as the most prevalent lesion. Through consistent follow-up and prompt investigation, we were able to detect 43 cases of malignancy among these patients at a very early stage. 45% of the patients presented with ulcerative lesion. Majority of the patients presented with stage 3 cancer. However, due to our proactive approach, some were even diagnosed at stage 1. Surgery combined with chemoradiotherapy was the primary treatment modality. Wide local excision with marginal mandibulectomy and neck dissection formed the cornerstone of our surgical approach. In our study, radical neck dissection emerged as the most frequently performed procedure. Forehead flap was most commonly utilized for reconstruction. Now let's move to some of the interesting cases operated in our hospital. This is a case of a squamous cell carcinoma for buccal mucosa who underwent wide local excision, marginal mandibulectomy and neck dissection, and the X-ray specimen here highlights the teeth along with the ulcerative lesion. This is a case of a right lateral border of the tongue who underwent partial glossectomy, neck dissection, supraomohyoid neck dissection. This patient presented with ulcero-infiltrative lesion of the lower lip who underwent wide local excision and was reconstructed using carap and zig flap. Here we can appreciate a fungating mass which was stage 4 proven malignancy of a mandibular alveolus who underwent mandibulectomy and neck dissection and was successfully reconstructed using forehead flap. This is a case of upper alveolus malignancy. Partial maxillectomy neck dissection was done and was reconstructed using nasolabial flap. Post-surgical histopathology revealed that majority of stage 2 and stage 3 patients had a moderately differentiated carcinoma. With combined modality treatment, stage 4 patient had a 14% recurrence. 5-year follow-up underscores a critical insight. Patient in stage 1 had a 5-year survival of 78%. When comparing our study with those of other reputed researchers, we observed similar findings in relation to epidemiological factors. These figures emphasize the stark contrast between the early and late-stage survival outcome, which was closely aligned with those of leading cancer centers. To conclude, middle-aged male with tobacco and alcohol addictions are at high risk of developing oral cavity cancer, with buccal mucosa and gingivobuccal sulcus being the most commonly involved site.
histopathology, and CT imaging were instrumental in our efficient diagnosis, surgically addressing the primary as well as neck, followed by chemoradiotherapy, formed the cornerstone of our management. Even with multimodality treatment, stage 4 patient had a higher recurrence and poor survival. So, from my perspective, tackling oral cavity cancer requires a comprehensive approach, which includes regular screening for early detection, public campaigns to raise awareness, training healthcare providers to recognize the pre-malignant lesions, and leveraging the advanced diagnostic tool, which will lay the pathway for more successful outcome. These are few references. Thank you.
Questions from audience?
Hello, it was a nice presentation.
Thank you so much,
I'm
ma'am.
Dr. Ruby. I'm a plastic surgeon here in IGH. I just wanted to ask, you told that there are high chances of recurrences.
Yes,
right?
ma'am.
So, in how much time, matlab, after your surgery and all your reconstruction is done, then in what is the duration between the first chemotherapy or radiotherapy and the surgery?
Yes.
The duration, just I'm asking the duration.
Thank you so much. A very good morning to you, ma'am. Thank you for your question. First of all, ma'am, the initiation of the therapy is very crucial after the surgery. So it must be within 6 weeks, preferably as the protocol is, as the literature says, and protocol followed in the leading cancer centers. It should be initiated within 6 weeks of the surgery. And if the chemoradiation has been completed, we go for regular follow of the patient.
I'm asking how much time do...
Yeah, the time duration for recurrence. You're saying that?
No.
Just a single question, please.
Just a
We can
single
discuss
question
it out
I'll
later.
ask, sir.
The time duration for the recurrence from the initiation of chemo.
I'm just asking how much time do you take? Matlab, in your...
To study the recurrence, we usually take...
No, not recurrence I am asking how much time do your hospital take, matlab, after the surgery of a patient is done, till first chemo or radio is given to the patient?
So in our study, means in my hospital, the protocol is that first, as the surgery is completed, we go for oncologist opinion, depending on the histopathology report. And depending on the different markers like lymphovascular invasion, perineural invasion, closed margin, extracapsular extension, nodal disease, we go for radiation or chemotherapy. And that is ideally within 6 weeks. 6 to 8 weeks is the time period we do for in our hospital, ma'am.
6 to 8 weeks.
Yes, ma'am.
Okay, that's after suture removal or...
That's all.
No more discussions.
Okay, thank you.
Thank you. I think you exceeded your time. There's no time for a second question now. Sorry.
Thank you everyone for your patient
Please.
hearing.
Specific question, specific answer.
Yes.
Okay.
Thank you, sir.
No more discussions.
I may now request Dr. Swarupa, VSP Vishakhapatnam, to present her topic, oral manifestations in diabetic patients.
A warm good morning to all. Myself, Dr. Swarupa from RINL. My topic of presentation for today is oral manifestations in diabetic patients, a case-controlled study. Diabetes is a group of metabolic diseases characterized by hyperglycemia caused by absolute or relative deficiency of insulin. This metabolic disorder has complications throughout the body, including the oral cavity. With respect to the oral complications reported in literature, diabetic patients are at a high risk of developing various orofacial neurosensory disorders, mucosal changes, and gingival and periodontal diseases, of which gingivitis and periodontitis have a reported higher prevalence. Gingivitis refers to the inflammation of the gingival tissues, while periodontitis refers to the inflammation of the supporting tissues of teeth. The oral cavity harbors the second largest microbial community in the human body. In periodontal infections, commensal oral microbes turn into opportunistic pathogens. This bacteremia, along with its inflammatory products and the immune response, affects different organs in the human body. There is substantial scientific evidence regarding the bidirectional association between oral health and diabetes. The periodontal inflammatory products adversely affect the blood sugar glucose level, and the diabetes worsens the virulence and invasiveness of pathogenic oral microflora. Despite periodontal diseases being the sixth complication in diabetes mellitus, caring for the oral cavity is often overlooked when trying to control other problems associated with diabetes. So we aim to study the prevalence of oral manifestations in diabetic patients at VSGH, to identify the high-risk group for periodontal diseases amongst diabetics, to find out the level of awareness about risk of oral health complications in diabetic patients. This is the methodology we followed. The study was conducted for a period of 2 years. 300 patients were randomly selected from the dental OPD. The study group comprised of 150 patients with diabetes mellitus, while control group comprised of 150 healthy subjects. Both males and females in the age group of 20 to 80 under anti-diabetic medication for a minimum of 6 months were included, while those with pre-diabetics, known history of other systemic diseases, pregnant and lactating mothers, tobacco, betel, and alcohol users were recent study of periodontal therapy were excluded from the study. Patient history and details were recorded as per the WHO criteria. Intraoral examination was performed in a dental operatory using standard indices for changes in the oral mucosa and the periodontium. The results are as shown. The demography showed there was a male preponderance in the study group and female preponderance in the control group. The age distribution showed that majority of the diabetics were in the age group of 51 to 60, while non-diabetics were predominant in the 30 to 40 years age group. The oral hygiene status revealed that majority of the diabetics had fair oral hygiene status, while non-diabetics had good oral hygiene status. These are the various clinical observations we have found in our study. Most of them were predominant in the study group compared to the control group, except for dental caries, which was highly prevalent in the control group. Amongst diabetics, gingivitis had a higher percentage prevalence, followed by periodontitis and tooth mobility. Further data analysis regarding diabetics with periodontitis showed that 69% of the diabetic males and 57% of diabetic females had periodontal diseases, of 46% with mild periodontitis, 38% with moderate, and 16% had severe periodontal diseases. The association between age distribution and oral hygiene status with that of prevalence of periodontitis among diabetics was statistically significant, suggestive of with increasing advancing age and fair and poor oral hygiene status are at high risk of developing periodontal diseases. The association between duration of the disease and prevalence of periodontitis was also statistically significant, suggestive of higher risk of developing periodontal diseases with increased history of disease duration. The awareness quotient showed that 28% of our sample were aware of the risk of oral health disorders in diabetes mellitus, and 29% denied the statement, and 43% had no clue, suggestive of a paucity in the level of awareness. Discussion: diabetes is associated with an increased risk of macro and microvascular complications. The relationship between diabetes and oral complications have been extensively studied. However, the literature pertaining to the risk factors amongst diabetics is sparse. Corroborative evidence with other Indian studies showed that we have a lesser prevalence of burning nose syndrome reported and a higher prevalence of lichen planus reported in our study. The reported prevalence of gingivitis in other studies is in the range of 16.9 to 60%, while we had a 71% prevalence. The periodontitis reported prevalence is in the range of 13.8 to 100%, while we had a 64% prevalence. Our study highlights the following as the high-risk group amongst diabetics: patients with fair and poor oral hygiene, prolonged history of disease duration, and advancing age. In conclusion, diabetic patients are a high-risk group for developing various oral complications, particularly periodontal diseases. Being the diabetic capital of the world, there is a dire need to bring public awareness regarding the importance of oral hygiene maintenance in prevention and management of diabetes. The American Diabetic Association Oral Health Advisory that emphasizes on good oral hygiene practice and regular dental checkups besides blood sugar control should be practiced on a routine basis. So our study highlights the need for periodic oral health checkups in the multidisciplinary management of diabetes and thereby contribute to the overall well-being and better quality of life in diabetic patients. These are my references. Thank you.
Any question? Please keep the question short and brief.
I am Dr. K.L. Amran, Ramkala, additional CMO. Is there any correlation between the control and control type of diabetes and this oral problem?
Sir, I had not kept that criteria, sir, for evaluation, but yes, most of the patients who presented with severe diabetes, severe periodontitis, when we checked their blood sugar profile, they were on the higher side only, sir.
Any more? If there's none, then thank you very much. We can move on. The last speaker.
I may now request Dr. Manish Kumar, ISCO Banpur, to present his topic, Fine Needle Aspiration Cytology Profile of Palpable Head and Neck Region.
Good morning, respected chairpersons, judges, and delegates. I am Dr. Manish Kumar, and I am going to present on fine needle aspiration.
Please bring the mic to your level.
Fine needle aspiration cytology profile of palpable head and neck lesions. Fine needle aspiration cytology is a diagnostic procedure used to investigate lumps or masses. We also call it FNAB or FNA or simply cytopathology. In this procedure, a thin hollow needle is inserted into a lump or mass for sampling of cells, smeared and prepared from the aspirates, which are stained and examined under light microscope. It is very safe, minor surgical procedure, can be done in OPD setting. It is simple, rapid, having good accuracy, cost effective, and complications are infrequent. However, results may be inconclusive or false negative. Head and neck swellings are common presenting complaints in OPD, affects all the age group in both male and females. Its common causes include congenital, developmental, skin and subcutaneous soft tissue tumor, lymph node involvement, salivary gland tumors, and tumors of parapharyngeal space. Head and neck cancer comprises of 23% of all cancers in male worldwide. Aim and objective of our study was to assess the frequency of incidences of head and neck swellings at different sites of head and neck region amongst different age groups in both male and female, and to assess distribution amongst different types of head and neck swelling in various head and neck regions. Ours was a retrospective study done at Banpur Hospital between April 2019 to October 2024. FNAC was performed in both OPD and APD patients following standard procedures. FNA findings from head and neck swellings were studied and correlated. We got 149 patients, out of which 71 were male and 78 were female. We included all the patients who underwent FNAC of head and neck region during the study period and excluded and considered only the first FNAC finding for repeat patients from the same site and same finding. Out of 149 cases, we got 52.34% cases female and 47.66% male. And so lesions in neck region were predominant than head region. In our study, we found most commonly lymph node was involved, followed by thyroid gland and salivary glands. This is the distribution of cases as per the tissue involved in both male and female. And we can see here the lymph node was most common in both male and female, and least common was other soft tissue lesions in neck. This pie chart shows the same. This is age group by distribution of lymph node lesions in male and female. And we can see in our study, we found granulomatous lymphadenitis as the most common finding in both male and female. This is the distribution of different types of lymph node lesion combining all the age groups. This pie chart shows the same in both male and female, and we can see granulomatous as the most common finding. These are reactive hyperplasia of lymph node and granulomatous lymphadenitis. This is age group by distribution of various thyroid lesions in male and female, and we found colloid goiter as most commonest in both male and female. And this pie chart shows combining all the age groups in both male and female, and colloid goiter was predominant. This is colloid goiter and papillary carcinoma of thyroid. This is age group by distribution of salivary gland lesions in both male and female, and here benign neoplasm was the most common. This pie chart represents the same when we combined all the age groups. This is pleomorphic adenoma. This is age group by distribution of other soft tissue lesions in male and female. We could not infer more because of paucity of samples. And this is the epidermal cyst. We broadly divided all lesions in 4 major categories: inflammatory, benign, malignant, and inclusive. And we found inflammatory being the commonest among all lesions. This pie chart represents the same in both and male and female. Inflammatory was the commonest. This is combining both male and female. So coming to the discussion, Martin Ellis was first to introduce FNSC in 1930, and he stressed on 2 fundamental things: representative sample and high quality of preparation. In our study, we found female preponderance and predominant involvement was of lymph node, which is comparable to other Indian studies. Among the lymph node, granulomatous lymphadenitis was most common. In thyroid, female was predominant and benign colloid goiter was most common. In salivary gland, again benign neoplasm were more common. So overall, inflammatory and benign lesions were commonest in our study, which is comparable with various lesser studies. However, international study says malignant lesion as common. To conclude, granulomatous lymphadenitis was the commonest head and neck lesions in our study, followed by reactive lymphoid hyperplasia. We also concluded majority of the head and neck lesion can be managed by opting for FNSC itself without undergoing surgical intervention, as FNSC could differentiate the inflammatory process from the neoplastic one. So my take-home message is head and neck swellings are of great clinical significance. The underlying disease may range from a treatable infectious etiology to malignant one. FNSC should be privileged for all palpable head and neck lesions because of its various advantages. Major surgical biopsies excision can be avoided by doing FNSC itself. And there is no proven evidence of spread of tumor by FNSC, and tuberculosis must be excluded in all cases of lymph node swellings. These are my references. Thank you.
Questions?
Good afternoon, sir. I'm Dr. Mayabos from IJ Shorkila, Chief Consultant. I would just like to know, all your references studies are comparable.
Not all comparable. There are
So I would like to know what your study adds. What is new in your study?
I just wanted to focus on the various head and neck lesions.
Compared to the literature, existing literature, references, whatever you have given.
I was not trying to prove anything in my study. I just focused on the importance of FNSC of head and neck regions.
Oh, there is
My
nothing
focus
more
was-
added in the study.
I
It's
have
just
not
comparable with all other
no, I have not made anything statistically significant. I am not trying to prove anything. I am just focusing on the importance of head and neck swellings and
Okay, second
FNSC.
question.
Okay, thanks.
And since tuberculosis is very common in our setup, it will help a lot.
Any more question? Okay, thank you.
Thank you.
So we can now draw the session to a close. Thank you very much, all the speakers.
Thank you, sir. I may now request our esteemed judges, Dr. P.N. Ratha, sir, Dr. Suchitra Mishra, and Dr. P.K. Mahapatra, sir, to please come on the dais. I may now request Dr. Ashok Sundar Sir, HOD Medicine, Tata Steel, to present a token of appreciation to Dr. P.N. Ratha Sir and Dr. Suchitra Mishra. I may now request Dr. Rashmi Ranjan Mohanty Sir, CMO.RSP, to kindly present a token of gratitude to Dr. Suchitra Mishra. I may now request Dr. Rashmi Ranjan Mohanty Sir, CMO.RSP, Rourkela, to kindly present a token of gratitude to Dr. Ashok Sundar Sir. I may now request Dr. Ashok Sundar Sir to present a token of appreciation to Dr. Rashmi Ranjan Mohanty Sir. Thank you, sir. Now we will move on to our next session, which is guest lecture 5. I may now request Dr. Snehal to take over the session.
I may now request Dr. P.K. Mahapatra, ex-CMO RSP Rourkela, and Dr. Ashish Hota, Consultant Cardiology, Apollo Hospital, Rourkela, to kindly chair the session and grace the dais. There is one announcement. There is a HOM meeting at VIP Lounge going on there.
I request all the HOMs to please proceed for the HOM meeting going on at the VIP Lounge. Thank you.
In this guest lecture, our time duration is 30 minutes, 25 minutes for presentation, out of which after 20 minutes one buzzer, then after again 5 minutes, there will be a second buzzer to mark the end of presentation. 5 minutes is for interactive discussion. Our speaker, Dr. Soumya Rai, consultant gastrointestinal hepatopancreatobiliary surgery, laparoscopic and robotic and liver transplant, Apollo Hospital, Bhubaneswar. Dr. Soumya Rai is a highly accomplished expert in his field and practicing in Bhubaneswar. I welcome Dr. Soumya Rai to present his topic, Liver, a Pandora's Box.
Good morning. So, respected chairpersons, dear seniors and my dear colleagues, I will thank the organizers for inviting me to speak on this topic. Actually, basically, I am a gastrosurgeon. My main forte is liver and pancreas, but I will not talk regarding surgery here. I will discuss basic on the liver and its science, more on the metabolic syndrome and its fatty liver, small regarding liver transplant. So, I will discuss regarding the fatty liver disease and how it is predictive of the atherosclerosis. There are mainly chronic metabolic diseases are mainly like fatty liver, non-alcoholic fatty liver disease and chronic pancreatitis. They are metabolic dysfunction, atherosclerosis and obesity, diabetes. They are all linked. So in our this decades, diabetes and obesity are rising. In our transplant sector or in our liver, NFLD are rising as an epidemic rather than alcoholic and hepatitis B. So the main, the causative thing is not because of the fat, it is because of the insulin resistance. The main signs, insulin resistance, it causes the hepatic steatosis, beta cell dysfunction, then chronic inflammation, fibrosis, cirrhosis, and pancreatic dysfunction. The main cause is the main sugar, not fat. So the shared risk factors are the same. Whether it causes the liver, whether it causes the pancreatic dysfunction, whether it causes atherosclerosis, whether it causes chronic disease, autoimmune, whatever the main pathogenesis is same. So it has been hypothesized that 10 years down the line, the persons who have atherosclerosis, high risk factors, they have fatty liver disease or chronic pancreatitis indolent. So NFLD has been investigated right now since 5 years down the line. Those patients, those have grade 1, grade 2 fatty liver disease, those patients are high risk for atherosclerosis or high risk for strokes, like chronic CKD, metabolic syndrome, type 2 diabetes, these are the things. So mainly those patients in the OPD sectors, those have grade 1 or grade 2 fatty liver. The initial investigation we do as ultrasound. If they are suspected, then we go for CT or MRI if there are high risk factors. And in the blood investigations, if there are LFT derangements like OTPT or alphas or GGT, then we go for fibroscan or mainly for CT scan or MRI if there are high risk factors on fibroscan. Lipid profile and glucose are the first line investigations if there are derangements in LFT. Endoscopy and CT scan if there are high risk FLI scores. So if we diagnose on like there are in ultrasound, endoscopy or CT scan, a patient has a grade 2 or grade 3 fatty liver, then we treat them as a non-alcoholic fatty liver disease depending on the risk factors. So the basic things to be noted on liver function test are OT and PT, not bilirubin. total bilirubin, sometimes certain cases are high bilirubin. In this Western belt, they are unconjugated hyperbilirubin, very common because of sickle cell, sickle trait. Those are different category. Second thing are Gilbert syndrome and Dubin-Johnson syndrome are very common. Those are not to be treated. The third category are like NFLD or alcoholic, those to be correlated with alphos and high GGT. And those patients along with clinical correlations with NFLD, along with high lipid and high GGT, along with diabetes, in those cases, if there is OTPT is high, we tend to categorize them as non-alcoholic steatohepatitis, NASH. NFLD is non-alcoholic fatty liver disease. If they progress to raised OTPT, they are termed as non-alcoholic steatohepatitis. They are NASH. If they progress to cirrhosis, they are cirrhotic liver disease. So GGT also rises in alcoholic and these cases also. So in general, diabetes, obesity, cardiac, fatty liver, chronic pancreatitis, these are all in the same group of metabolic syndromes. So other biomarker risk factors are there, biomarkers, these are all investigational, not in the OPD or in general routinely done. And this is a basic things I want to tell the audience. The insulin resistance, these are all on research things, like how in general in family, like annual health checkup, you can detect that down the 5 years down the line or 10 years down the line, about 40 years of age, you are in the high risk category. Like you have family risk factors, you have abdominal obesity, hyperglycemia, high lipid profile. In the lipid profile, excluding the cardiologist, every general people, they tend to point out the total cholesterol and LDL level. That is not an actual parameter. Triglyceride level and VLDL level and total cholesterol by HDL ratio, this 3 parameter is the direct correlation to the insulin resistance. What I am pointing out is evidence based on the PubMed based studies, okay, and hypertensions. These are the evidence based studies to indicate insulin resistance, to detect inflammation. And if these risk factors continues over the down the line, this kind of patients have high risk factors to develop cirrhosis, atherosclerosis, CAD or cardiovasculars or brain strokes, different, all same things. Preventive measures, everybody knows, physical activity, dietary modifications, regular checkups. What I pointed out is the stress reduction. This is the very important things. This is the conference among the doctors, which is the very vital thing, that this particular third point, stress, nobody takes care, especially among the doctors. Physical activity, diet, everybody takes care. And the last point I want to emphasize is that in the 21st century, fat is not the killer, carbohydrates are the killer. The reason is that as a liver specialist and what I am been studying over the PubMed and the articles, in our Asia, hepatitis B was the most common risk factor for liver cirrhosis. 10 years back, alcohol was the most common risk factor for liver cirrhosis. Since last 5 years, non-alcoholic fatty liver disease is rising as the most common risk factor as the liver cirrhosis. And in the next decade, fatty liver disease will be the most common risk factor, is the most common killer of the liver disease and will be the most common indication of liver transplant. It is very scary for the people. And not for the adults, for the children, it is the most common cause of obesity. It is rising. So pharmacological management, diabetes, so any fatty liver disease, no drug is in the market currently, no drug. Ursodeoxycholic, whatever drug, these are all placebo. There is no evidence is there. Unless and until there is NASH or OTPT is high, there is no drug, there is no indication, evidence is not there. So there is fatty liver or there is high LFT, You treat cholesterol, you treat diabetes, automatically liver will be treated. So you correct the diabetes, metformin, endocrinologist or medicine specialist take care. NASH, you give antioxidants, other medications are there. You take care of your pancreas, and mainly the main crux is diet. Main crux is dietary. Everything, liver, pancreas, cholesterol, main crux is sugar, especially the sugar part. In our belt, in Indian belt and in our belt, various newer modifications, GLP-1 agonists have come over from Europe and in America. In India also it is coming up, but it is still experimental. Injectable versions, oral version is coming up. It is very costly. Semaglutide has come up now, but it is not, in India it is now over the world. So there are stages of NFLD. It is initially asymptomatic. It is very frequently, anybody goes to ultrasound screening, grade 1, grade 2 fatty liver will be there. So it is inflammation, fibrosis, cirrhosis is there. Just I will be completing 5-10 minutes. So the indication of last stage, end stage liver disease is cirrhosis, and the treatment is transplant. Otherwise, you just maintain the cirrhosis part, conservative management. So what are the indications of treatment? Like viral hepatitis, hepatitis B and hepatitis C. In the last 10 years, it is now treatable and it's still curable, hepatitis B and hepatitis C. Alcohol is decreasing, and non-alcoholic fatty liver disease is now common. Autoimmune disease is also treatable. So in India, it's still cadaveric transplant is very few. Tamil Nadu, Maharashtra second, Karnataka. In our state, since last 1-2 years, transplantation has been rising. Around 10 odd transplants has been done. Utkal 5, in our Apollo Bhubaneswar 3 odd transplants. So SOTO is the organ donation from government support. It has increased. Donation has been very proactive. Government support is there. So allocation policy has been very proactive as compared to the south. So technical improvement has been done, living donor, advancements, ICU care, preservation techniques. Over the decades, advancement has been improved. Initially, over 10 years back, it was only limited to Tier 1 cities. Now it has been given to Tier 2 cities because of the MOUs, agreements, financials, breakups. A lot of improvements has been done. The quality has been transferred to the cities. The trainings, all the trainees have gone to the different cities. So a lot of things has changed. Evaluation process for a transplant has transferred. Initially, medical history and physical examination is done. Testing, imaging, scan. The softwares have improved. Vaccination, psychological, social caring, not just only clinical. The society, the family care has to be taken care of. And very important, financial counseling, which is very important in our setup, India and Odisha also. The procedure, I will take only few minutes. Liver has to be taken out from one body, recipient. Donor preparation has to be done. Blood vessels are joined, recovery and monitoring. This is just a basic live donor transplant. One donor, one part of liver is given to the recipient, and in cadaver, whole liver is given to the recipient. Post-transplant immunosuppression are given for monitoring, sepsis, risk, regular monitoring, follow-up. Rejections are the issues, lifestyle changes, dietary. Patient can go into alcohol. Patient, there is recurrence of malignancies, there is recurrence of hepatitis B. Care is to be taken. It is not about only doing, it is about follow-up. Lot of things has to be taken care of. Complications or risk are there. Initially, 10 years back, it was a list of 30-40%. Now it has reduced to around 10 to 20%. So 5 years outcome and survival rate is around success of more than 90%. This photo was taken last month. We did our first liver transplant. We had our MOU with Delhi team. Initially, I was there in Apollo, Dr. Nirav Goyal. He had experience of Dr. Subhash Gupta 20 years back, long experience of 20 years. So it is because of the good team, our 10 years experience, good setup, good immunocare. That's why I could, it was my dream. I was a native of Cuttack to take that quality care to transfer to the Odisha people. They should not travel back there to that setup, because that team can go any place with finances. But after transplant, after 1 month, they have to stay there for 1-2 months and regular follow-up. That keeps a burden for them. So a lot of things have been refining, and it takes time. This was the first LDLT we did last year, 2 months back. It was successful. We did our press conference. It was published in multiple bulletins. This was in last month. This was the third LDLT, this patient. And we hope for the future best. Let's see, with your all blessings. Thank you very much.
Dr. Roy, thank you for your very nice presentation.
Thank you, sir.
I have one question. As you are a gastrosurgeon, what is the role of bariatric surgery in NAFLD?
Hello, sir. Bariatric surgery
In NAFLD.
NFLD. NFLD, bariatric surgery, sir, it is very experimental. Non-alcoholic fatty liver disease, first line is dietary. Unless and until it is morbid obesity. In morbid obesity, we go for bariatric surgery. It is like if there is osteoarthritis, if there is obstetric sleep apnea, if there is hypertension, those things are there, we go for bariatric surgery. Not strictly non-alcoholic fatty liver disease, we go for bariatric surgery. It may be additive factor. Only NFLD bariatric surgery is found also. Never.
Do you advocate bariatric surgery in any of the stage of NFLD?
No, sir. I have experience of bariatric surgery. I have done my fellowship with Pradeep Chaudhary in Max, but after 1-2 surgery. In this academic conference forum, I have done bariatric surgery, but it is my opinion, it is still cosmetic. Only evidence-based indication is obstetric sleep apnea, patient not movable, like extensive hypertension, morbid obesity, bariatric surgery indicated. Simple obesity, 6 months weight loss should be given, patient should be given for diet counseling, then only see. Or else sleep gastrectomy. In bariatric surgery, there are 2 types of surgery. Either go for sleep gastrectomy, simple, or Roux-en-Y bypass, that is complicated. In Roux-en bypass, that is complicated, that gives a good help, long-term help, follow-up. In sleep gastrectomy, that is a simple cosmetic. I have done bariatric surgery, then after 6 months, patient will recover. There is no help. So there is no point of doing help that patient will recover again, regain weight after 6 months. So Roux-en-Y bypass, that is the actual indication of bariatric surgery. That should be done in selected center, high risk center, high volume center, there will be high risk of pulmonary embolism, very high risk. There I have seen those centers, I have worked in centers. Their OT table is different, their leg rest is different, laparoscopy instruments are long. We cannot just do in routine in our Odisha all those laparoscopic set. Sleep gastrectomy is okay. I have done myself, I know that thing. Sleep gastrectomy, the stomach expand after 6 months. After you do CA stomach, after gastrectomy, the stomach usually expand after 1-2 months. The same fundamental applies in sleep gastrectomy. You remove the part of the stomach, the patient, the urge of the eating, it reduces. So the patient takes less food. He loses weight after a few months. But the urge to take food regains after 6 months. But Roux-en-Y bypass, we remove the part of the intestine. That is malabsorption. That actual is the indication of bariatric surgery. So there is loss of vitamin, minerals, complicated. That is different. So for non-alcoholic fatty liver disease, there is no indication of bariatric surgery.
Liver transplant, do you go for a robotic or laparoscopic?
Sir, we have no experience of robotic laparoscopic in Odisha. We go for open surgery. We have done only 3 transplants successful, patient in discharge from OPD and in follow-up within span of 2 months only. Dr. Nirav, she is my teacher. I have the experience of 2 years in Delhi Apollo. So they have started robotic surgery and laparoscopy right now. In India, robotic surgery is being done, Dr. Ella and Dr. Soy Medanta, only 2 centers, and Amrita Institute, 3 centers only. Not.
Sir, thank you, sir,
Can I
for
ask?
highlighting.
Can I?
Yeah.
Dr. Somen,
Yeah.
I'm a physician with Tata Steel.
Yes, ma'am.
Your account of rising NFLD, we are also witnessing. Do you think, I mean, it's very scary, and do you think we should, change our criteria of starting pharmacological treatment, or should we do fibroscan regularly to prevent all these advances? And what do you think might be the reason that this incidence is rising so much? So has the lifestyle changed so much? I mean, we adults, we are eating the same thing, doing the same activity. I mean, there is no such drastic change in lifestyle. But why the sudden rise in the incidence? And do you think we have to be more stricter in starting pharmacological treatment?
Well, first one thing, first point is that I am myself is an example of this thing. I am myself. Yes, ma'am. I had fatty liver, but I had metabolic syndrome. Like I had family history. One thing, hypercholesterolemia, diabetes. I had hypertension, diastolic more than 110, 3 years back, and 3 risk factors. But I reversed it. Initially, 5 years back, I used to, as a medical knowledge, everybody knows these are the medications you should take. Nothing more than that, diet control and exercise. But it could not be reversed by that. Then it took me 3-4 years to reverse. It takes time. In the medical textbooks, madam, it is not written particularly. Only 4 points in the box, everywhere it will be written. Lifestyle modification, like that. What lifestyle modification? What diet? Not everywhere it is written. In the medical textbook, it is not written. So the lifestyle changes means, madam, more or less, physical activity has reduced. And the food quality has reduced, madam. I have done researches. Actually, truly speaking, I have done researches into the science of the food, multiple articles into the nutritional research articles. The quality of the rice you are taking, the quality of the food you are taking, that have reduced. The intake of carbs have increased. The intake of protein have reduced. So the generation of the more than 40s and the 50s people, they are okay. The generation of the middle-aged people, like 20s and 30s, the incidence of prevalence and the incidence of fatty liver disease among them are rising. The reason is that the food they are eating outside, the processed foods have risen among them more. So the incidence and prevalence of NFLD among the parents and the grandparents is very less. The incidence and prevalence of non-alcoholic fatty liver is among the children is very high. The reason of the outside food.
I think it is the packaged food or the trans oils being sold.
More common is trans oil. Second is the sugar, refined sugar. Not the starch, refined sugar, carbs, plain carbs, not complex carbs. Like I will separate it. Millets are complex carbs, complex starch. They have a less glycemic index. If you take, you have a less chance of diabetes, or the insulin spikes will be less. If you take plain rice, like jemte odiyare konti arua chalo khaibe, white polished rice खाइले आपनकर ग्लूकोज चेक कले सुगर स्पाइक बढ़ी जीवो आपण ब्राउन राइस आजिकली काई फैशन रे आछि पुराना काल रे ब्राउन राइस माने एक्चुअली सोडा पॉलिश थाए ना तार सुगर स्पाइक गुडा कम थाए सेही फाइन डिफरेंस टा सेटाई तो सेगुडा बेसी प्रेवलेंस बढ़ी अछि दैट इज द रीजन मोर और लेस स्मॉल थिंग्स द ऑयल रे होछि जेंता सिंपल एग्जांपल if you cook your things like ghee and cold pressed or wood pressed oil, those are like the oxygenated. जेतबेले से गुडा को pressed हे जाय, the heat generated, they cause toxins to the oil. So they remove the antioxidants. So they cause inflammation in the body.
Which oil do you recommend from your extensive
It
research?
doesn't matter, madam. ମୁଁ ସେଇ କହୁଛି କି ଯୋଉ ଫ୍ୟାସନ୍ ରେ ଆସୁଛି ଆଜିକାଲି oils ଗୁଡ଼ା, whatever you take, refined oil is bad for health. Refination. The reason is that ki once you, the refined oil, the term is that ki once you do refination means hydrogenation. Mane you put heat on that seed. The heat degenerates the antioxidants. That heat is toxic. But the ghee and the mustard, once it is cold pressed or wood oil, it is good for the Indian cooking system. It is not toxic. That is the reason now the American Heart Association, jota ki 10 years back, they used to study it, that oil was good. Now they are telling ki ghee and mustard oil is good for oil. In their publication, now they are telling, not me.
Thank you.
Nothing. Hello. No evidence is there. Evidence is not there. Only vitamin E has only very minimal evidence. Those are all only case-based studies, not RCDs or not level 1 evidence is there.
But in your presentation, you recommended methionine as a supplement for fatty liver.
Methionine, those I just put just tabloid. It's not only fuel. S-adenyl methionine, those are only case pits, case series, not level 1 or RCDs. Simple things.
So what is your personal experience regarding
Only
this?
diet.
Only diet.
Grade 1 fatty liver, first thing lipid profile or diabetes, those are metabolic things you have to be taken care of. 3 months they have to be seen. UTPT. If LFT is normal, you just treat metabolic things. Diet control, exercise, these things. They automatically, they reverse back. LFT improves after 3 months. Automatically, you don't have to do so costly medications, glutathione, Medinin, all those unnecessary 1000 costly medicines you don't have to prescribe because they don't have any role.
You said in the diet, the quality of the diet, I mean.
Only just
nutrients-
cut down on sugars and the excess oil, fast food automatically.
What about protein powders, the marketing protein powders?
That too much of discussion will go on. Protein powder extra, everything is boils down to your calories. Your plate should have a balanced diet, like colored fruits. Your vegetables should be a variety of colors, different. Carbs, protein, every basic in a school, everybody knows as a doctor. Your carbs should be 60%, protein should be like 30%, fat should be like 10 to 20%. This is common, normal. It should not be so much of so specific. We take around like extra protein powder you should take. You should add more and more calories. It is not that like some kind of gym going, they will take, I will so much of protein powder, I will add so much of gym. No, if you take too much of protein, it will not absorb in your protein. It will go to your gut, it will take up as a cholesterol. It will deposit in your liver as a fat. Whatever you take, carbohydrate, protein or fat as a diet, it will get converted in the liver in the lipid profiles. LDL, VLDLs. That is the fundamental mechanism. Then it comes out in the blood. That is LDL, VLDL pathway. Okay. Once you do exercises, muscle absorb it. Once you exercises, then the role comes of protein supplement or whatever you want to. Once you exercises, you eat rice, na? You don't need supplements. That is the point. Hello?
Excuse me. So one question is this.
Yes, sir.
And this is the extension of madam's question, sir. Yes, sir.
Oh, yeah, sorry.
Sir, in your case, you have followed this weight reduction because book says if you reduce 30% weight, there is a reversal of NFLDs. So have you tried for this weight reduction also, sir?
Yes, sir. I am a
how much
standing
did you
I am a standing example. My friends will vouch for it because I had lost weight actually. Everybody will tell me in my whoever sees me, you have become unhealthy, do your checkup, you have become unhealthy, do your checkup. But my medical reports are doing fine. I had changed my 3 BP medications to now 5 mg amlong since 3 years.
Oh, you were hypertensive?
I was hypertensive on Telma AM 40. Now only Amlong 5 mg.
Oh, good, sir.
And I used to take Rosuvas 10F 2 years. Now since 2 years, no medications.
Okay.
And this was my thing. Fatty liver, my OTPT was around 90, 100. OTPT. It was too dangerous. OTPT was 90, 100 2 years back.
And one more question, sir. Did you try that vitamin E? Because book mention it is very effective.
3-4 years back, I tried a lot of everybody give the jargon of knowledge there. Nothing. Just simple eat, do exercise. Nothing is needed.
Harrison still mentioned that it is very effective therapy for
it's okay, sir.
stage 1 and 2.
See, vitamin E is okay because, see, if you look into articles, if you check the evidence, the level of evidence categorized into level 3. Okay, level 3 means it is case series. It is not also like prospective study. Some prospective study is there. It's okay. It is not level 1 also. Na? Randomized trial is not there.
Yeah, but it is mentioned in the Harrison books that way.
There is no, that's why we are also giving some medication. If somebody has, okay, vitamin E, there is no harm, is not avoiding also. You can give. If somebody debates also, if you debate, sir, why not we give? Okay, you can give also. If you can debate, I will not give. There is no harm.
Thank you.
Some skin dermatologist also, there is skin infection. Vitamin E prescribed. Okay, you can give also.
Thank you, Dr. Somen. Due to lack of time, my last question from chairperson side is, so because first of all, congratulations for being a flag bearer and establishing a hepatic or liver transplant team in Orissa.
Thank you.
And because as we all know, liver transplant is requires a team effort, and also the person has to be lucky enough to get a donor.
Yeah.
So, in your experience or in your expertise, which person you will prefer? Suppose a person with autoimmune hepatitis, and second person with NAS-related cirrhosis, and third is a person with alcoholic liver disease. 3 persons are there in your queue, and which patient you will prefer for transplantation? Suppose a rare donor comes to you.
You told autoimmune, alcoholic, and NASH, non-alcoholic. Yeah. So autoimmune I will keep down the line, because autoimmune depend on if there are 3 persons they developed cirrhotic already, and they are into indication of liver transplant already into different criteria fitting into liver failure, so then it's okay. But autoimmune, sometimes if they need prednisolone or visolone in liver failure, they sometimes come out. I've seen. So they can be, if 3 person in line up and only 1 cadaver is there, so I will prefer alcohol, non-alcoholic rather than alcoholic. Depending on it is made. It is very difficult to decide, but a lot of things is there. Cadaver, finance, logistics, how much the patient family can support post-transplant also. It is very important. No sir, amaro ochi, ame nei asilu, kordobu. Bhai ta pore, 2 months pore, tame ready acho ki nahi. That is very important. Rejection, immunosuppression, that is important. Tame ette support kolo, then you should be prepared to support for 1 year follow-up. That is very important for counseling. Seita hi mane important.
Okay. Thank you, sir.
Okay. Thank you very much, sir.
Thank you. Thank you, sir. I may now request Dr. P.K. Mahapatra, ex-CMO.RSP Rourkela, to present a token of appreciation to Dr. Saumin Roy. Thank you, sir. I may now request Dr. Ashish Hota, Consultant Cardiology, Apollo Hospital, Rourkela, to kindly present a token of gratitude to Dr. P.K. Mahapatra ex-CMO RSP Rourkela. Thank you, sir. I may now request Dr. P.K. Mahapatra, ex-CMO RSP, to present token of appreciation to Dr. Ashish Hota, Consultant Cardiology, Apollo Hospital, Rourkela. Thank you, sir. Thank you so much to everyone.
The most awaited ceremony of the AISMOC 2025 is the steel oration. Now we come to the most awaited session of this AISMOC 2025 is a steel oration. I may now request Dr. Hota sir to kindly grace the dais. I may request our organizing secretary to kindly escort sir to the dais. Dr. Biranchi Kumar Hota sir was born at Kuapada, Patna, near Kodapathar, Khordha district, Odisha, on 28 June 1964. He completed his MBBS from MKCG Medical College, Barampur. He completed his MD OG at VSS Medical College, Burla, and he has garnered numerous accolades. Got prestigious WHO fellowship in assisted reproductive technology in 2007. On 9th of September 1996, he joined SAIL Raw Material Division at Goa Mines. In July 2020, he returned to RSP and joined as a Director, Medical and Health Services. He became the Executive Director of Medical and Health Services in June 2022. During his tenure as Executive Director at IGH, he had carried out numerous renovation work for the development and upgradation of the hospital. The super specialty hospital construction was completed and inaugurated during his tenure. HMIS service was started during his tenure. MOU was signed with state government authorities for providing the treatment to BSKY beneficiaries at IGH on credit basis was happened during his tenure. Sir superannuated on 30th of June 2024. A prolific scholar, he has enriched medical literature with numerous publications in esteemed Indian journals and in renowned international journals, leaving an indelible mark on the global research. He is presently working as a specialist in ONG at Capital Hospital, BBSR. I may now request Dr. Hota sir to kindly present his topic on fetal onset of adult diseases.
Good afternoon, all of you, ladies and gentlemen. Respected head of the medicals of different steel hospitals, steel fraternity hospitals, doctors from all the steel plant hospitals, and all doctors present over here. At the outset, I must thank Dr. Acharya and his organized team to invite me to be here with you. I am really express my gratitude and happiness to be here with you. And it's very difficult, to be honest, just after retirement, during transition period, to prepare for oration, even to read few words. But I tried my best to present before you some extracts of few journals and slide extracted from some PPTs and make it in a sequence to make it bit palatable. You know that India is the capital of the diabetic capital of India, of world. Day by day, metabolic diseases are increasing, competing with the rising population. The fetal onset of adult disease the concept is not new. I will try to refresh your memories by showing you few slides. Dr. David Barker is the pioneer of this concept. He is the British physician epidemiologist, and he noted something odd in some poor states of United Kingdom and Wales. He noticed that the metabolic disease should be the disease of the affluence, but he found something odd. He also got the diseases being present in the poor state of poor people in adulthood. So there comes the this concept. This is Barker hypothesis. He found that the risk of coronary heart disease are more in people who took bath with low birth weight, and they suffer in adulthood. This is an extract for Lancet Journal, 1989. Dr. Barker and his epidemiologist team do some research, do the study taking 5,654 men born during 1911 and 30. They found the same thing, like highest mortality from heart disease in the people who were born with low birth weight. This is the research done in New England Journal of Medicine, taken from New England Journal of Medicine. Here they found out that the suffering during the first 2 trimesters of the pregnancy, these people, when they reach the adulthood, they suffer from heart disease, diabetes, and hypertension. So this is about dose famine. The famine, during the famine, the people who were pregnant, whose mothers were pregnant by that time, when exposed to famine during first 2 trimesters, they suffered, and suffering after the famine or before the famine, no impact about the health standard in comparison to others in their adulthood. So this is all about blood pressure is shown to be rising. There is more, the lipid profile more atherogenic. Coronary heart disease 9% exposed in 3% unexposed. Post-glucose tolerance test after 2 years seems to be rising. You know, Biafra, something to talk about Biafra famine. Biafra is a state of Nigeria who started war with mainland to be independent. So during that war, 1967 and 97, these people, the areas who fought the war, suffered from starvation. So naturally, by that time, their women folks who were pregnant suffered like anything. Their babies got undernutrited. So they studied their adulthood, who were born during that time, they suffered the same things, like hypertension, impaired tolerance, and diabetes were more whose mothers were pregnant by that time, and who were born with low birth weight during the famine time. So this is just nothing but the repetition. Impaired glucose tolerance and diabetes are more who were born during famine. And this is something to reinforce the Barker hypothesis. During COVID, most of the death from SARS-CoV-2, where people studied their birth weight status. So again, the people who were born with low birth weight, the death from COVID SARS are more in this group. And this is also one topic published in Journal of Psychology and Mental Health. So again, the people with who are born with low birth weight, they developed mental diseases and cardiac diseases and all the sorts of metabolic diseases. Here comes the history of early hypothesis, early programming. So Bard-Parker hypothesis 1980 reveals high correlation between infant adult mortality, association between low birth weight and adult ischemic heart disease. This led to fetal origin of adult disease, that is FOD, and to the early started early programming of hypothesis. Early programming hypothesis. So there is ample of evidence that many risks which lead to chronic adulthood diseases originate in the early stage of life. Genetic and epigenetic pathway of the development are affected by nutrition and pollution. Let me say something epigenetic pathway. What is epigenetic pathway? How it is the study how cells control the DNA without modifying sequences. Here in early programming or fetal origination of the disease, both genetic and epigenetic pathway, they act, both act. So environmental result not only affect the individual but also affect the future generation. Development origin of diabetes, cancer, and hypertension, coronary disease, and obesity widely studied. And here it is shown that naturally what the people will be in future, how healthy will be, the first 9 months of the pregnancy decides. So this development origin of health and diseases, they affect the fetal life, infancy, and early childhood. And the effect of programming may be in cell increasing or decreasing the cell numbers, modifying the cell structure, modifying the receptor numbers and modifying the receptor sites, the imbalanced distribution of different cell types of the organ, and altered blood supply. This is photomaterial exchange, what I saw, for the non-gynecologist friends. The lower one, the maternal circulation, then comes the placental bed, then comes placenta, then fetal circulation. These are the nutrients go from placenta, mothers to fetus. This is something about science of programming, how the genomic and epigenetic system of the body, with the help of changing of the maternal environment, fetal environment, physiology, and with the accelerated maturation due to increase in glucocorticoids like dexamethasone and beta-methasone, so ultimately we get alternating fetal growth, or IUGR or low birth weight we get. This is something complex interaction between IgG, TS2, and fetal interferon. The motto is to prevent rejection of fetus and to have a healthy baby. So what is TS2? TS2 and TH1 are some cytokines in the placental bed. The role of TH1 is to reject the fetus. TH2 negates the effect of TH1, so prevents the rejection of the fetus. So any resentment, any derangement of this action leads to a malnourished baby or a dead baby. So this is something, the interaction between when there is a uterine environment, we get some preeclampsia, maternal preeclampsia, and placental dysfunction. That is the target. That is the target to the that is the strike to the fetus. That leads to altered fetal growth, and ultimately we get cardiovascular disease. The ways like how cardiovascular disease is manifested in the adult, there is renal dysfunction, vascular dysfunction, and neuromuscular dysfunctions, and that is the epigenetic pathways. This is how different organs are affected by reduced micronutrients of the mother, and through DNA methylation, histone modification, regulation of non-coding RNAs. And here fatty tissues are affected, fatty tissues are increased, the muscle mass will be, lean muscle mass will be reduced. In the pancreas, there will be reduced beta cells mass and increased alpha cell mass. Ultimately, insulin is increased, insulin decreased, and insulin resistance will increase, glucagon will decrease. Ultimately, we will get type 2 diabetes mellitus. And here in liver, there will be increased due to oxidative stress and infections, there will be release cytokinins and damage to the liver. So overall, you will get a low birth weight baby, and in the future life, you will get the obese person, and with diabetic mellitus, with dyslipidemia, and as you said, reduced density lipoprotein and systolic purpose will be raised. So ultimately, obesity, pre-diabetes, and diabetes, metabolic syndrome, and cardiovascular disease will be more in adults. This is how fetal response fetal response for the adult disease happens. And here, because of the bad internal environment, and there will be irreversible change to the fetus, and abnormal insulin secretion leads to diabetic mellitus, reduced vascularity, and reduced nephron number will lead to hypertension, cardiovascular disease. Here, some interrelated things like reduced nutrition to the mother, lead to reduced fetal nutrition, reduced growth, then the birth size, altered birth size and body composition, then childhood environment. In addition to childhood and changing childhood environment and growth, you will get risk factors like different morbidities in adulthood. This is something repetition, let me skip. Now, how maternal diet and macronutrients status affect fetal development. We know that as you require protein, fat, and carbohydrate and others, we require minerals like magnesium, zinc, iron, and different vitamins like folic acid, vitamin B12 are required. When there is reduced iron, zinc, vitamin A, and folic acid, we get problems with the different in organogenesis of the kidney, like reduced nephron. What is the now nephron? Nephron is the numbers of nephron a person is born with. So nephron will be reduced. So ultimately, you will get here hypertension, and when cardiovascular functions are affected by reduced supply of the iron, zinc, vitamin, and folic acid, you will get all the like cardiovascular anomalies and cardiac hypertrophy. And in pancreas, same thing as I said earlier, beta cell functions will be reduced, alpha cell function will be increased because of the reduced supply of the iron, zinc, folate, and vitamin B12. Then come to the effect on muscle, little body mass will be reduced, and ultimately you get fat person. And like in kidney, vitamin A and vitamin D, lungs, vitamin D and vitamin A supply required for the function of lungs. So that is reduced vascular endothelium growth factor. Ultimately, there will be poor lung of a baby, and there will be reduced lung capacity and all sorts of problems in lung. So here, the role of vitamin beta folic acid in metabolism of the methionine. You know, methionine is required for synthesis of the protein due to DNA synthesis, and DNA synthesis is required for protein and others. Simultaneously, when homocysteine is not will not be converted to methionine, methylamalonine will be increased. So there will be lipogenesis of increase of fatty tissue. Here is something related first, second, third. How one mistake derives series of mistakes. First, in pregnancy, if the baby is having low birth weight, then there will be bad adulthood. Then same lady, fully pregnant in second generation, will have a low birth weight baby, and the second generation will affect it. So this is something first, second, third, and series will continue. This is something about birth weight less than 2.5 kg and risk of diabetes 2. Almost all the study groups, the risk of diabetes 2 is increased when the birth weight is less than 2.5 kg. Here some extract from one journal, relative frequency, related to birth weight, correlated with hypertension, type 2 diabetes, and coronary disease. Almost all, when the birth weight is below optimal level, and the risk hypertension, type 2 diabetes mellitus, coronary disease, and stroke are increased. This is more elaborating how the different organs are affected. When there is problem in the mother, baby affected, there is gestational hypertension and diabetes mellitus, and because of the increased glucose supply and development of programming of fetal agitation, you get deranged adiposity genesis, lipogenesis, deranged liver function, deranged pancreas function, deranged cardiovascular function, deranged cellular function, deranged brain function, and deranged lymphatic system. So ultimately, cardiovascular disease development in the offspring will be more. So this is something repetition that we skip. Now, nutritional programming of brain. Okay, where nutrition supply is below optimum, not adequate for the baby, the brain sparing effect. Because brain is the most important of the person, the supply will be going to the brain, compromising the blood circulation, nutrient circulation to the different parts. So, but when the nutrition supply is beyond optimum, you will get brain damage in the fetus. So, leading to structural changes in neuron and cognitive changes and motor changes. This is something about brain mapping, how brain is mapped by MRI during pregnancy. And something continuation from the previous slide, the educational performance is hampered, motor skill will be hampered, and one study there for 1 kilo reduction in birth weight compared to other twin, there was loss of 13 verbal IQ. And same thing, maternal cytokinins are, when there is oxidative stress or infection to the mother's womb, cytokines will be released. These cytokinins will affect the brain tissue. So thereby they will damage the brain. So 14 to 20% of schizophrenia cases are assumed to have been caused by maternal infection. And one study says birth in the winter or spring is a risk factor for schizophrenia, mostly associated with influenza virus. So viral infection during pregnancy leads to schizophrenic. The baby will be baby or adult will be schizophrenic. So the psychiatrist friends can say the persons with schizophrenia, if you study, there must be maternal infection up to some 14-21 cases, 21% cases. So same thing, antenatal period prior to full term is very sensitive to nutritional programming of brain. Low birth weight and risk of depressive disorder in later life is due to programming of the hypothalamic axis and growth hormone axis, and high anxiety during mid-gestation. As you say, take good care of mother. She must be mentally, physically, psychologically balanced during pregnancy. High anxiety of the mother during mid-gestation is associated with decreased gray matter density in prefrontal cortex of the baby in 6 to 9 years old children after delivery. So this is about outer exposure to pollution. So how the pollution exposure to polycyclic aromatic hydrocarbon from coal industry and the mothers who cook by burning coal. There, the cord blood of the infant shows 40% softer brain damage and 20% in childhood asthma, and it shows cognitive deranged delay cognitive function. Smoking also affects the same thing. Smoking and one MRI of the brain of the showed here that the frontal lobe, the volume of the frontal lobe and cerebellum reduced. That is out of 127, 118, and out of 24 point, the cerebellum 24.5 to 20.1. And there is more irritability, oppositional defiant behavior, conduct disorder, attention deficit hyperactivity disorder. You will have. Nothing more to say. This is recommended weight during pregnancy. This is of course foreign standards, not Indian standards. This is current the scenario in India. 18% of pregnant women consume less than how our pregnant ladies are undernutrited. So 18% of pregnant women consume less than 50% of calories. 35% of pregnant women consumed less than 50% of protein. 88% of pregnant women consumed less than 50% of iron, and 50% of the pregnant women consumed less than 50% beta carotene. Okay, here it is shown how we choose the diet for a pregnant woman. For the first of all, we take care of the baby. Second, we take care of the physical and mental standard of the mother. For baby, we need food for brain development. we need food for nutrients for growth of the fetus, and to improve the immunization standard, immunity standard, and healthy diet of the mother. So we choose diet accordingly. And here, while choosing the diet, the okay, other part is okay, but something about affordability. In India, especially in Orissa, some poor states, doctors write protein left and right. I know that a daily wage laborer was spending 50% of his salary towards the medicine and protein powder and calcium supply, calcium purchase during the pregnancy. Now, government of Orissa is doing nice thing, supplying the fortified chatua and everything to the poor pregnant lady to take. So these are all about the how to choose the nutrition diet. This is a balanced diet. Nothing much to say. You are all doctors. You know balanced diet, like protein, carbohydrate, and fat in proportion, like 67% carbohydrate, fat 10 to 15%, and protein 12 to 15%, along with the fiber, water, mineral, and essential fatty acids and vitamins. Also, calcium and vitamin are equally important. As I said earlier, it helps in better function of the better development of the lungs. And here, to the last, I shared the best slide. This is the concept. Though the before sequences concept is not new, I love it to repeat it again and again. In my view, a young girl, when he is not mentally, physically, psychologically, financially not fit, she should not get married or should conceive. Because during their, before marriage, she might have thyroid disease, might have hypertension, might have heart disease, might have some obesity, might have hypertension, many things. So proper counseling must be done. Nowadays many clinics are opened, pre-pregnancy counseling, madam is a pre-pregnancy counseling, and the concept of before she conceives. So proper counseling, proper treatment will prepare a healthy mother for a healthy child. This is nothing but repetition, and so thank you. And now the way the population of India is rising, and I think today the birth rate of India, daily birth rate of India is highest in world. And with this type of uneducated baby, after many of us today, how many cardiac metabolic diseases will be there, we do not know. And how much the burden these people will be over government of India is known to everybody. Thank you.
I may now request our CMO in charge, Dr. Jayant Acharya sir, to kindly felicitate Dr. Hota sir for his unparalleled knowledge, expertise, and outstanding contribution in the field of gynecology. Thank you, sir. There's a video on painless labor. There's a presentation is there. That's a video on painless labor by the use of intoxicant by Linda India. I request Kamalji Burman to present it. This video will be followed by lunch break.
Yeah. Good afternoon. So this is regarding a painless delivery in today's scenario, where more and more cesarean babies are happening. So we have a gas which is Internox. It's a homogeneous mixture of oxygen and nitrous oxide. So it's a 50% and 50% homogeneous mixture of oxygen and nitrous oxide, and it will be used as analgesic effect during the pregnancy. It's on a product overview, pain management during the labor, dosage and method of administration, proven safety, and side effect and contraindication. History: 1961, nitrous oxide being was developed by BOC Healthcare, and later on it is being used in every surgery throughout the world, oxygen and nitrous oxide. So it is on a colorless and slight sweet on an order, charismatic, non-flammable, but strongly support the combustion. Application has a different application. It's on a child labor, in a labor pain management, or dentistry, or emergency, during the emergency patient services, and colonoscopy. So how it is, as in India, most of the labor pain where the women come, they are not aware of that they can go for the pain relief during the labor. So we have a pain management option during the labor. These are the options we had, but we have also option for Internox also. It's a effective and controllable analgesia, safety to the mother and fetus, both, no effect on the labor and movability. What is the Internox? It's again compressed homogeneous gas mixture of 50% nitrous and 50% of oxygen, and with the analgesic, because 50%, less than 50% of nitrous oxide has a very good analgesic effect, but after 50%, it's an anesthetic effect. So it is a good sedation, and second, due to oxygen, it will support the hemoglobin oxygen saturation also. So the physiological effects are diffuse quickly into bloodstream, does not combine with the hemoglobin, low solubility leading the minimal accumulation of the fat and issue. It is not metabolized by the body, diffuse into the gas-filled spaces, rapidly eliminated via lungs. Means it goes, it's suit for immediately and rapidly it goes off also. So its effect is immediately it gives the pain relief, but within a minute or 1 to 2 minutes, it goes off from the body. So as long as the patient requires the analgesic effect or pain relief, they will inhale, and after that, as soon as the inhalation stops, the effect goes off very rapidly. It's have a very safety method because it's a very old product, and and it is being used throughout the world also. So safe for mothers and baby also, safe for the and easy to patient for safety also. So both the side, this Antonox covers very effectively. The inhalation is through the demand valve. Patient can take the Antonox gas through the demand valve, and it exhaled also through the demand valve, same demand valve. So it's a rapid shoot and rapid off also. In normal birth in UK it's a maximum the normal birth is happening with the Antonox gases. Common side effect is dizziness, light headache, euphoria, nausea, vomiting, and dry mouth. Contraindication is with this product are air embolism, severe and having a cardiac abdominal decentration and other echocardiographically problem. So these are contraindication for the patient where Antonox cannot be administered. Thank you.
Did you know there's a way to make labor more manageable for expectant mothers? If you're wondering about Antonox and its safety during pregnancy, stay tuned for a reassuring guide. Antonox is a blend of nitrous oxide and oxygen, commonly known as laughing gas, used to ease tension and anxiety during labor. It doesn't eliminate pain, but helps you relax without harming the fetus. It is administered through a mask or mouthpiece and requires deep, even breaths. The gas works swiftly, usually within 2 minutes of inhalation, and provides quick relief. Advantages of Antonox: easy to use, requiring no specialized personnel. Quick response time. Mother-friendly, providing pain relief. No lingering effects after use. Pocket-friendly and safe for the fetus. Disadvantages of Antonox: may cause drowsiness and dryness. May not eliminate pain entirely. Potential side effects like nausea and tingling. Advisable to inform about pre-existing conditions. Generally safe, may cause temporary dizziness, nausea, or vomiting, but effects cease promptly after inhalation stops. Embrace the possibilities of a more comfortable labor with Antonox. Always consult with your healthcare provider for personalized guidance. Here's to a smoother journey into motherhood.
Thank you. May I please request all of you to please proceed for lunch. And the next session is OHS paper starting at 2 o'clock. Thank you.
Zydus is an innovative scientific global pharmaceutical company. Involved in various clinical research leading to discovery, development, Zydus. Zydus is an innovative scientific global pharmaceutical company. Involved in various clinical research leading to discovery, development, manufacturing, and marketing of a broad range of healthcare therapies, including small molecule drugs, biologic therapeutics, and vaccines. Zydus has introduced desidustat, an oral ATF inhibitor, therapeutic approach to treat anemia secondary to CKD. Desidustat inhibits PhD-mediated hydroxylation of HIF-alpha. The accumulated HIF-alpha diagonalizes with HIF-beta, upregulating erythropoietin production, increasing iron availability, and regulates oxygen levels, and stimulates erythropoiesis. The promises shown by desidustat were translated from bench to bedside through studies. The preclinical studies evaluated the carcinogenicity of desidustat in viscerals for a duration of 2 years, showing no evidence of genotoxic or carcinogenic activity. The phase 1 clinical study evaluated the safety, tolerability, and pharmacokinetics of desidustat in healthy volunteers. Desidustat was found to be safe and well tolerated to the highest dosage of 300 milligrams. The phase 3 clinical study evaluated the safety, tolerability, and efficacy of desidustat in treatment of anemia in pre-dialysis CKD patients. Desidustat was found to be effective and well tolerated. GMD and DMD are phase 3 clinical studies conducted for evaluating the efficacy and safety of desidustat for the treatment of anemia in CKD patients. The GMD trial compared desidustat with darbepoetin in patients not on dialysis. While GMD compared desidustat with poison alpha in patients on dialysis to establish non-inferiority. Primary endpoints in both GMD and GD showed that desidustat was non-inferior to the comparators raising hemoglobin levels from baseline in CKD anemia patients, irrespective of their dialysis status. Among secondary endpoints, for time to achieve target hemoglobin and for percentage responders, desidustat was superior compared to epoetin alpha in dialysis patients, however comparable versus darbepoetin in non-dialysis patients. Desidustat produced significant reduction in LDL cholesterol in both trials. Although great reduction in hepcidin levels was seen with desidustat in both trials, however, the difference was statistically significant only in the GMD trial. No major safety concerns were found with desidustat in either study. The started as a research idea, it's now a reality as an outcome of 10 years of a rigorous drug development process, used to change the lives of CKD anemia patients for the better. Desidustat, truly a breakthrough in CKD anemia. This is an innovative scientific global pharmaceutical company. Involved in various clinical research leading to discovery, development, manufacturing, and marketing of a broad range of healthcare therapies, including small molecule drugs, biologic therapeutics, and vaccines. And now, Zydus has introduced Desidustat, an oral HIF-PH inhibitor, a therapeutic approach to treat anemia secondary to CKD. Desidustat inhibits PHD-mediated hydroxylation of HIF-alpha. The accumulated HIF-alpha diagonalizes with HIF-beta, upregulating erythropoietin production, increasing iron availability, and regulates oxygen levels. It stimulates erythropoiesis. The promises shown by Desidustat were translated from bench to bedside through studies. The three clinical studies evaluated the carcinogenicity of Desidustat in Vista rats for a duration of 3 years, showing no evidence of genotoxic or carcinogenic activity. The phase 1 clinical study evaluated the safety, tolerability, and pharmacokinetics of Desidustat in healthy volunteers. Desidustat was found to be safe and well tolerated to the highest dosage of 300 milligrams. The phase 3 clinical study evaluated the safety, tolerability, and efficacy of Desidustat in treatment of anemia in pre-dialysis CKD patients. Desidustat was found to be effective and well tolerated. DREAM-ND and DREAM-D, the first 3 clinical studies conducted for evaluating the efficacy and safety of Desidustat for the treatment of anemia in CKD patients. The DREAM-ND trial compared Desidustat with darbepoetin in patients not on dialysis. DREAM-D compared Desidustat with encouragement alpha in patients on dialysis to establish non-inferiority. Primary endpoints in both DREAM-ND and DREAM-D showed that Desidustat was non-inferior to the comparators raising hemoglobin levels from baseline in CKD anemia patients, irrespective of their dialysis status. Among secondary endpoints, for time to achieve target hemoglobin and for percentage responders, Desidustat was superior compared to epoetin alpha in dialysis patients, however comparable versus darbepoetin in non-dialysis patients. Desidustat produced significant reduction in LDL cholesterol in both trials. Although great reduction in hepcidin levels was seen with Desidustat in both trials, however, the difference was statistically significant only in the DREAM-ND trial. No major safety concerns were found with Desidustat in either study. The starting of the research idea is now a reality as an outcome of 10 years of a rigorous drug development process. We have to change the lives of CKD anemia patients for the better. Desidustat, truly a breakthrough in CKD anemia. This is an innovative scientific global pharmaceutical company. Involved in various clinical research leading to discovery, development, manufacturing, and marketing of a broad range of healthcare therapies, including small molecule drugs, biologic therapeutics, and vaccines. Zydus has introduced Desidustat, an oral AIF-PH inhibitor, a novel therapeutic approach to treat anemia secondary to CKD. Desidustat inhibits PhD-mediated hydroxylation of HIF-alpha. The accumulated HIF-alpha diagonalizes with HIF-beta, upregulating erythropoietin production, increasing iron availability, and regulates oxygen levels, that stimulates erythropoiesis. The promises shown by Desidustat were translated from bench to bedside through studies. The preclinical studies evaluated the carcinogenicity of Desidustat in Vista rats for a duration of 2 years, showing no evidence of genotoxic or carcinogenic activity. The phase 1 clinical study evaluated the safety, tolerability, and pharmacokinetics of Desidustat in healthy volunteers. Desidustat was found to be safe and well tolerated to the highest dosage of 300 milligrams. The phase 3 clinical study evaluated the safety, tolerability, and efficacy of Desidustat in treatment of anemia in pre-dialysis CKD patients. Desidustat was found to be effective and well tolerated. GMD and DMD are first 3 clinical studies conducted for evaluating the efficacy and safety of Desidustat for the treatment of anemia in CKD patients. The GMD trial compared Desidustat with darbepoetin in patients not on dialysis. While GMD compared Desidustat with epoetin alpha in patients on dialysis to establish non-inferiority. Primary endpoints in both GMD and GMD showed that Desidustat was non-inferior to the comparators in raising hemoglobin levels from baseline in CKD anemia patients, irrespective of their dialysis status. Among secondary endpoints, for time to achieve target hemoglobin and for percentage responders, Desidustat was superior compared to epoetin alpha in dialysis patients, however comparable versus darbepoetin in non-dialysis patients. Desidustat produced significant reduction in LDL cholesterol in both trials. Although great reduction in hepcidin levels was seen with Desidustat in both trials, however, the difference was statistically significant only in the green DMD trial. No major safety concerns were found with Desidustat in either study. It started as a research idea, with now a reality as an outcome of 10 years of a rigorous drug development process. Plans to change the lives of CKD anemia patients for the better. desidustat, truly a breakthrough in CKD anemia. Zydus is an innovative scientific global pharmaceutical company. Involved in various clinical research leading to discovery, development, manufacturing, and marketing of a broad range of healthcare therapies, including small molecule drugs, biologic therapeutics, and vaccines. Zydus has introduced desidustat, an oral HIF-PH inhibitor, a novel therapeutic approach to treat anemia secondary to CKD. Desidustat inhibits PHD-mediated hydroxylation of HIF-alpha. The accumulated HIF-alpha polymerizes with HIF-beta, upregulating erythropoietin production, increasing iron availability, and regulates oxygen levels. That stimulates erythropoiesis. The promise shown by desidustat is translated from bench to bedside through studies. The three clinical studies evaluated the carcinogenicity of desidustat in Vista rats for a duration of 2 years, showing no evidence of genotoxic or carcinogenic activity. The phase 1 clinical study evaluated the safety, tolerability, and pharmacokinetics of desidustat in healthy volunteers. Desidustat was found to be safe and well tolerated to the highest dosage of 300 milligrams. The phase 3 clinical study evaluated the safety, tolerability, and efficacy of desidustat in treatment of anemia in pre-dialysis CKD patients. Desidustat was found to be effective and well tolerated. GMD and DMD, the first 3 clinical studies conducted for evaluating the efficacy and safety of desidustat for the treatment of anemia in CKD patients. The GMD trial compared desidustat with darbepoetin in patients not on dialysis. GMD compared desidustat with epoetin alpha in patients on dialysis to establish non-inferiority. Primary endpoints in both GMD and GMD showed that desidustat was non-inferior to the comparators in raising hemoglobin levels from baseline in CKD anemia patients, irrespective of their dialysis status. Among secondary endpoints, for time to achieve target hemoglobin and for percentage responders, desidustat was superior compared to epoetin alpha in dialysis patients, however comparable versus darbepoetin in non-dialysis patients. Desidustat produced significant reduction in LDL cholesterol in both trials. Although great reduction in hepcidin levels was seen with desidustat in both trials, however, the difference was statistically significant only in the GMD trial. No major safety concerns were found with desidustat in either study. The study is a research idea. Its name and reality is an outcome of 10 years of a rigorous drug development process. It is to change the lives of CKD anemia patients for the better. Desidustat, proving a breakthrough in CKD anemia. This is an innovative scientific global pharmaceutical company. Involved in various clinical research leading to discovery, development, manufacturing, and marketing of a broad range of healthcare therapies, including small molecule drugs, biologic therapeutics, and vaccines. Zydus has introduced Desidustat, an oral anti-pH inhibitor, a novel therapeutic approach to treat anemia secondary to CKD. Desidustat inhibits pH-mediated hydroxylation of HIF-alpha. The accumulated HIF-alpha diagonalizes with HIF-beta, upregulating erythropoietin production, increasing iron availability, and regulates oxygen levels. That stimulates erythropoiesis. The promises shown by Desidustat were translated from bench to bedside through studies. The preclinical studies evaluated the carcinogenicity of Desidustat in Vista rats for a duration of 2 years, showing no evidence of genotoxic or carcinogenic activity. The phase 1 clinical study evaluated the safety, tolerability, and pharmacokinetics of Desidustat in healthy volunteers. Desidustat was found to be safe and well tolerated to the highest dosage of 300 milligrams. The phase 3 clinical study evaluated the safety, tolerability, and efficacy of Desidustat in treatment of anemia in pre-dialysis CKD patients. Desidustat was found to be effective and well tolerated. GMD and DMD, the first 3 clinical studies conducted for evaluating the efficacy and safety of Desidustat for the treatment of anemia in CKD patients. The GMD trial compared Desidustat with darbepoetin in patients not on dialysis. GMD compared Desidustat with epoetin alpha in patients on dialysis to establish non-inferiority. Primary endpoints in both GMD and GD showed that Desidustat was non-inferior to the comparators in raising hemoglobin levels from baseline in CKD anemia patients, irrespective of their dialysis status. Among secondary endpoints, for time to achieve target hemoglobin and for percentage responders, Desidustat was superior compared to epoetin alpha in dialysis patients, however comparable versus darbepoetin in non-dialysis patients. Desidustat produced significant reduction in LDL cholesterol in both trials. Although great reduction in hepcidin levels was seen with Desidustat in both trials, however, the difference was statistically significant only in the GMD trial. No major safety concerns were found with Desidustat in either study. It started as a research idea, with now a reality as an outcome of 10 years of a rigorous drug development process. Plans to change the lives of CKD anemia patients for the better. Guessing you stand, dreaming a breakthrough in CQB
डाउनलोड करिए ओरिजिनल
blood pressure.
A very good afternoon, everyone, and I hope you all had a wonderful lunch break. Now, we are ready to begin our afternoon paper session, which promises to be an exciting and informative series of presentations. May I call upon Dr. F.S. Patil, Additional CMO DSP Durgapur, and Dr. Surendra Kumar, Deputy CMO RSP Rourkela, to chair the session and to kindly grace the dais. Thank you so much, sir. Let us start this long papers with a total time duration of 75 minutes, in which 6 minutes is allotted to the speaker for the presentation, out of which after 5 minutes, 1 buzzer, then again after 1 minute, 1 buzzer to mark to end the presentation, and 2 minutes for the interactive session. I may now request Dr. Anandita Devata, RSP Rourkela, to present her topic, the prevalence of raised IOP in industrial setup.
देखिए
Good afternoon, respected judges, ladies and gentlemen. As we all work in industrial setups, my topic will be beneficial for all of us. From where do we got the motivation to conduct this study? During the annual health checkup of our employees, few of our employees had shown raised intraocular pressure without any symptoms. So, to investigate it, the prevalence of raised intraocular pressure in workers of industrial setups is an important aspect of public health and environmental science. What is intraocular pressure? It is the pressure exerted by the fluids inside the eyeball. In millimeter of mercury,
restart it.
Respected judges, ladies and gentlemen, as we all work in an industrial setup, my topic will be beneficial for all of us. From where we got the motivation to conduct this study? During the annual health checkup of our employees, few of our employees had shown raised intraocular pressure without any symptoms. So, to investigate a knowledge gap and improve the quality of life of our patients, we have decided to conduct this study. The prevalence of raised intraocular pressure in workers of industrial setups is an important aspect of public health and environmental science. What is intraocular pressure? It is the pressure exerted by the fluids inside the eyeball, measured in millimeter of mercury. The normal ranges between 10 to 21 millimeter of mercury. Elevated intraocular pressure is a critical factor in the development and progression of a disease known as glaucoma, which is a leading cause of irreversible blindness worldwide. So, what happens to our vision in glaucoma? As you can see in this picture, a normal individual will see, as you can see in the upper left picture, a normal individual will see the kids like this. But when glaucoma progresses from early to advanced stage, gradually the peripheral visual field constricts and patient develops tubular vision. Finally, there is complete loss of vision. So, I want to emphasize here that elevated intraocular pressure is the only modifiable risk factor among many to prevent such a vision-threatening disease. According to Occupational Safety and Health Administration, industrial workers are exposed to various occupational health hazards like exposure to high-intensity light, exposure to dust, pollutants, toxic substances, exposure to low ventilation and dim illumination, exposure to heavy physical labor conditions, which all can lead to change in intraocular pressure. So, we have aimed our study to determine the prevalence of raised intraocular pressure among various industrial workers, with the objectives being, number one, to assess the percentage of industrial workers developing raised IOP among the exposed and the non-exposed and in different departments of Rourkela Steel Plant. Secondly, to assess the effect of duration of exposure on intraocular pressure. After taking approval from the Ethical Committee of AISMOC General Hospital, data of 200 patients, 100 exposed and 100 non-exposed were collected and analyzed after taking their informed consent. Study was conducted in ophthalmology department between May to July 2024. This is a cross-sectional observational study. Patients were examined as per the standard pro forma by noting their visual acuity, intraocular pressure, gonioscopy, slit lamp examination, fundoscopy, central corneal thickness measurement, etc. The statistical analysis was done using SAS 9.2 and p-value less than 0.05 is considered to be significant. We have included in workers having work experience between 10 to 30 years and refractive error less than equal to -3 diopter in our study, and exempted all the individuals having any previous history of ocular surgery or any other disease which can cause raised intraocular pressure. Coming to the results, 30% of the individuals who are directly exposed to the occupational health hazards had shown raised intraocular pressure as compared to only 4% who are not directly exposed, with a significant p-value of 0.048. Among the to know the effect of duration of exposure on the intraocular pressure, we have categorized the sample size into two groups. One having 10 to 20 years work experience, another having 20 to 30 years work experience. Out of them, 60.71% of 20 to 30 years group had shown raised intraocular pressure as compared to 31.81% in 10 to 20 years work experience group, with a non-significant p-value. Among the non-exposed group, 4.83% had shown raised IOP as compared to 2.63% among the 10 to 20 years group. We have included 20 blast furnace, 25 OBBP, 20 coke oven, 20 hot strip mill, and 15 sintering plant workers in our study. As you can see in this graph, 5 out of 20 blast furnace, that is 25%, 6 out of 25 OBBP, that is 24%, 4 out of 20 coke oven, that is 20%, had shown raised intraocular pressure as compared to 2 out of 20 hot strip mill, that is 10%, and 1 out of 15 sintering plant workers, that is 6.66%, had shown raised intraocular pressure with a non-significant p-value. A number of studies are being conducted regarding the association of working environment and dry eye disease, relation between the working environment and ocular surface disorders, different types of injuries associated with industrial setups. But there is no concrete study on the effect of industrial work environment on intraocular pressure. So my study enlightens us about this aspect and highlights the need for further study and appropriate strategies to be taken. We have concluded that industrial workers who are directly exposed to the occupational health hazards are at an increased risk of developing raised IOP. Workers with prolonged duration of exposure had a greater risk. Blast furnace, OPPP and coke oven workers are at a greater risk. So we want to suggest a few recommendations. Among the engineering controls, lighting condition can be improved by using diffuse LED lights. Glare can be reduced by using anti-glare coatings on the surfaces. Canopies should be installed for the outdoor workers. Among the administrative control, regular eye examination along with intraocular pressure measurement should be done. Awareness programs should be conducted regularly. Personal protective equipment should be provided to the workers. Not only provided, it should be enforced to use. These are my references. Thank you.
House is open for questions. Only 2 questions are allowed.
Doctor? It was a very nice paper.
Thank you, ma'am.
Symptoms of eye problems or just like that you took the patients?
No, ma'am. We have included only those who came for very regular annual health checkup, which is done regularly in our plant. So during that, they don't have any symptoms. They just came for regular health checkup, and we incidentally found that their intraocular pressure was raised.
When we are doing this health examination before coming to the industry, are we including this examination before coming fitness for the industrial worker?
Yes, ma'am.
So then you are making the follow-up in different intervals.
Yes, ma'am.
So you advising the re-checkup, seeing the intraocular pressure range, how you are getting, or the same duration you are repeating the test?
No, ma'am. There is a regular schedule for this. When the normal range is 10 to 21 millimeter of mercury, and if it is above 21, then it is considered to be elevated. So if the pressure is between 22 to 25 millimeter of mercury, the intraocular pressure is rechecked after 2 to 3 months. Then if it comes within 3 millimeters of reading of the initial one, then the patient is again rechecked after 6 months. But if the intraocular pressure is between 26 to 27, then the intraocular pressure is rechecked after 2 to 3 weeks, not months. If it comes within 3 millimeter of the initial reading, then again it is rechecked after 3 months. We are not waiting for 6 months. And if it is more than 28 millimeter of mercury, then the patient is started with medication, and it is rechecked after 1 month. And if the patient is responding to the medicine, then we are continuing with the medicine, and the recheck is done after 3 months. No, ma'am, we are not advising because they have not developed the disease yet. So we can control their intraocular pressure. They are in the ocular hypertension stage now, and they have not developed the disease yet. So they can work in that environment, but they should have their intraocular pressure monitoring regularly.
Please precise in your answer.
One more question.
Thank you very much.
What are the main causes of IOP?
Sir?
What are the main causes of IOP among the industrial workers, like environmental or stress factor?
Yes, sir. Stress is definitely a factor. Age is also a factor. Having family history in the first degree relatives is a risk factor. Having high refractive errors is a risk factor for having raised intraocular pressure. But in the industrial areas, sir, exposure to dust may cause ocular surface disruption, which can lead to angle disruption and then raised intraocular pressure. Like this intensity of light and poor ventilation, everything has a mechanism to raise the intraocular pressure, sir. So for prolonged exposure, they can get raised intraocular pressure.
And what about hypertensive patient? Whether you have done any study? Because
time is over, ma'am. Please next speaker. Thank you.
Thank you, everyone.
Thank you so much, ma'am. I may now request Dr. Soumik Ranjan Sahu, ISCO Burnpur, to present his topic, a study of oral cavity lesions in industrial employees.
यही रखिए, ये दवा ना ये ना, हाँ, ठीक है, नहीं जरूरत नहीं। Good afternoon, Mr. Chairperson, judges, delegates, and the city of Rourkela, the cradle of Indian hockey and our national pride. My topic for presentation is the study of oral cavity lesions in industrial employees. Oral cavity lesions can be briefly classified as non-malignant, pre-malignant, malignant. The important risk factors are tobacco and pre-malignant lesions for oral cancer. But cancer, despite being a very high burden disease, very few studies done in industrial setup. Hence, I have decided to do this study. The few studies published in occupational health journals are prioritized on a workplace tobacco cessation program, as it has been observed that the high tobacco consumption in industrial workers contributes to a high burden of oral cancer. The aim of my study was to report the value of non-malignant, pre-malignant, and malignant lesions, and to find out the association of tobacco habits with the occurrence of pre-malignant and malignant lesions. It was a retrospective study involving 30 patients diagnosed based on history, clinical examination, biopsy, followed by HPE. We excluded pregnant and lactating females and patients already taking treatment. Among the 30 patients, 18 patients were non-malignant, 8 patients were pre-malignant, and 4 patients were malignant. These are my lesions. The most common site was tongue. The most common gender affected was male. And the most common age group was 51 to 60 years. Now, this is an important slide. Smoking tobacco means cigarette smoking, bidi, and smokeless means khaini, gutka, etc. Out of the 8 patients of leukoplakia, 2 patients had no habits, 5 had a history of smoking and smokeless tobacco, 1 patient had a history of exclusively smokeless tobacco. In oral cancer, 3 cases had a history of smoking and smokeless tobacco, 1 patient had no habits. Now, we have followed up to 2 years and going to follow up to 5 years. Until now, 2 patients have unfortunately died and 2 patients are surviving. So now, this is important. In pre-malignant lesions, we try to change their tobacco habits so that later on they don't convert into malignancy. So out of which 4 patients reduced their use, 1 patient did not change, and 1 patient we lost to follow-up. This is a tobacco cessation clinic in our hospital. We have summarized 75% association with tobacco. Our study findings pretty much similar to other studies. One difference, in our study, most common site tongue, in others it was the buccal mucosa. Our overall survival rate was 50%, and we have a survival rates in Sloan Kettering, Tata Memorial, and PGMI Chandigarh 2 years and 5 years, and the rest of the findings are pretty much similar. This is awareness activity in oral cancer awareness month. This is how we screen the patients and teach them to screen themselves in the OHS so that we can detect the lesions early and take action. These are the limitations. I can do clinical evaluation, biopsy helps in early diagnosis and treatment, and tobacco cessation compliance improves through behavioral counseling. In future, we try to take up more such awareness programs. See, the Honorable Prime Minister of India, in different forums, he has always focused on cancer, including Mann Ki Baat. His one important focus is treat the lesions early and screen early. I also say the same mantra, you have to screen and detect early so that you can take actions early. And tobacco cessation program should be a priority at the workplace. These are my references. At the end, I would like to say that the industry has always played an important role in the fight against cancer. The most important and the most respected, the House of Tatas. I take this occasion to respect and pay my tribute to Sri Dorabji Tata, Ratan Tata sir, Sri Noel Tata sir, and J.R.D. Tata sir. Even they have done immensely. Even in the state of Odisha, Mr. Shubhata Bakchi, a prominent industrialist from Mindtree, he has built an excellent cancer hospital in Bhubaneswar and providing treatment. I would like to say that it is the vision of the people of the country, the youth of the country, the Honorable Prime Minister of India, to have a Viksit Bharat. and I believe I can make a contribution to it by focusing on the new subspecialty of oncology, that is preventive oncology. This is Valentine's Week, and I would like that ये occasion में हम लोग जो प्यार करने वालों को मिलाते हैं, let cancer not be a cause for their breakup. Thank you.
Okay, thank you, doctor. House is open for questionnaires. 2 questions are allowed.
So can you speak a little louder? I can't hear. So those are. No, sir, that's not what exactly we're trying to tell. What I'm not trying to tell, my main focus is like so my focus is not that my main important thing is that it is a policy of the National Medical Commission. They have told that in all medical colleges you should have a tobacco cessation. What I am trying to say that this must also be established in an industrial sector. We have people in the National Medical Commission who are people who are from the field of oncology. If we take action now, maybe we can share our feedback to the policymakers. And as far as your question that occupational cancer, that I think I cannot prove myself. The limitations of my study, I require the help of the head and neck surgeons, the cancer
Actually, I already request you have to be precise in your answering also. Okay, next question, please.
Doctor, I just wanted to ask the same question because it is a OHS paper, okay? So you are telling it is a public awareness, okay? It is not only limited to your office.
So, but
Another thing, did you take any history of tobacco smoke with the people whom you have screened?
I didn't understand.
Because when you have taken the study, you have generally seen all the patients' oral checkup and all. But did you ask the question that whether they were already taking tobacco or not? I think most of the people they take.
So
It is not actually what I feel that a OHS paper.
I understood that, but I have done it retrospectively. So my focus was more on this one, the oral cancer and the pre-cancerous lesions. Actually, my first publication was on field of oral oncology. So I'm just continuing the work, and I am trying to implement that in an occupational setup. Maybe I could have spoken in the head and neck oncology forum, but I think this conference is an opportunity to bring this tobacco cessation and head and neck in the occupational sector. That's why
Thank you, doctor. Next speaker, please.
Thank you so much, sir. I may now request Dr. Tapas Mandal, DSP Durgapur, to present his topic, is promoting oral health habits during employees' periodical health checkup can encourage to implement positive lifestyle changes that will reduce the likelihood or chronic health problems of employees?
I'll change this or that one. Okay. Can I start?
Okay. Good afternoon, everyone. Oral health is the gateway of better health and satisfactory quality of life. There is evidence of a link between oral health and systemic health. Studies suggest that harmful bacteria can enter the bloodstream through gums, causing localized and systemic inflammation, resulting in localized and systemic diseases. The World Health Assembly passed a resolution on oral health in 2021, which includes promotion of oral health within the family, in the school, and in the workplaces. Respected chairpersons and honorable judges, the subject of my study, oral health promotion, can encourage employees to implement positive lifestyle changes that will reduce the likelihood of chronic problems. The aims and objective of the study was to ascertain the prevalence of oral health issues amongst our employees and finding the relationship between tooth decay and blood sugar values as well as finding the cause of oral health issues.
Analysis of health checkup data of 2396 employees were done. A prospective analysis of dental caries cases with blood sugar values were carried out. A questionnaire survey was conducted to get an idea about the mouth care habits of our study population. 71% of study population presented with compromised oral health, out of which 92% are tooth-related disorders. Dental caries and staining of tooth are the two most common findings. Other significant findings are geographic tongue, glossitis, periodontitis, and lesion in the mouth cavity. Habits of smoking and chewing tobacco are very common among the study population, and it is more than 80%. May be major factor playing for the development of various oral diseases. This is the result of prospective analysis of dental caries cases. There is increase in fasting blood sugar level was found among 33% of study population. The study revealed that caries is associated with an increased level of fasting blood sugar. Other study reported that patients with diabetes have a high rate of dental caries and they are at higher risk of developing dental caries. In spite of following few recommended good practices by the study population, dental caries developed in their teeth. No flossing, no gum massaging, no rinsing of mouth with water after snacking and sugary food may be the reason for developing dental caries among the study population. Oral disease is one of the most common diseases found in human, but it receives little attention from the individual. In many cases, and these are few examples, they are reluctant to seek advice for their conditions. In spite of difficulty in opening his mouth, the gutka user has not reported to anyone. Few different types of dental caries cases. Again, the individual has not taken proper care to prevent caries development in multiple teeth. Some tongue disorders, they did not seek professional advice for their condition in spite of their difficulties. So, dental caries is a complex issue with multiple contributor factors. So we did why analysis to uncover different reasons, and we found out few root causes like misunderstanding the procedure of brushing technique, importance of dental flossing, misunderstanding the benefits of quitting tobacco habits, benefits of avoiding sugary drinks, frequent snacking, and importance of rinsing a mouth with water after every snacking. And the countermeasure we adopted are compulsory oral examination as a part of periodical medical examination during employees' health checkup, and professional advice to the employees with the problems and awareness campaign. And our strategy to mitigate oral health issues were to addressing the risk factors and motivating employees for professional intervention. And this is one such result of motivation. We have already started our classroom awareness program on promotion of oral health and benefits of quitting tobacco habits. These slides are displayed in the electronic display board around the plant to spread the awareness on oral health issues among the employees. To summarize, untreated dental caries remains the most prevalent oral condition. Staining of teeth is the second most common findings among the study population. Smoking and other form of tobacco use increase the risk of developing oral diseases. Quitting tobacco habits may improve oral health as well as overall health. Fasting sugar level was found to be high in employees with dental caries. And it is usually the result of plaque building up on teeth due to improper brushing technique and flossing as well as frequent snacking without rinsing a mouth with water leads to development of caries. To conclude, dental caries is one of the most common preventable diseases, but oral diseases are a neglected area of our health. And it shares many risk factors with other major non-communicable diseases and can significantly impact our overall health. Improving oral health may have systemic implications and may facilitate individual life quality. Thank you.
Thank you, Dr. Tapas. Now, house is open for questionnaires. Only 2 questions are allowed.
Dr. Tapas.
This is what you want to say.
Yes, sir. I tried to generate awareness among our employees. So that, yes, sir.
So before intervention, there is a problem. You intervene with awareness and you expect a good result. So this comes as a TQM. But as OHS, where is the data?
Sir, in OHS, all work is basically TQM. Basically now, oral health problem is a hidden epidemic. We are not, but our workers are affected by oral health issues and they are unaware of their problems. Now, it is duty of public health officer like occupational health physician to find out the reason for their ill health and find out the solution. That's why I am presenting the paper in this forum, this occupational health paper, because our workers in all steel plant, they are heavily addicted to tobacco and nobody is taking care of that. Again, they are not aware of their own health problem of oral health. So it is our duty as a occupational physician to...
Agreed.
Yes, sir.
The thing is, where is that data to justify this? That's what I'm saying.
The data is there. That data has come out because of our health checkup. Because we have...
No, we have to show...
No.
Any statistical...
Yes, statistical data is there. Statistical data, statistical data is there.
So just one thing, sir. Dental caries is associated with working in industrial condition, or it is prevalent even in non-industrial areas?
It is prevalent.
How is it increasing in an industrial setup?
I am not talking about increasing. It is there.
There awareness.
And this issue is not taken care of by anyone. Not even dental surgeons. They are not doing any awareness campaign. But it is our duty as an occupational physician to take care of our employees, to make them fit to work. And this is a hidden epidemic. Nobody is basically focusing on this issue.
Suppose one thing actually, what Director Sahib asked, before doing the study, whether you have examined all the employees, and after intervention, whether you have again re-examined this year, and what is the difference, what is the time gap, and what is the prevalence rate? What is the prevalence rate among the occupational workers, and what is the prevalence rate among the general population? Whether you have...
So general population I have not checked up. I have only I have done check up only to my employees, and it is that 71% are affected by these oral health issues.
No, among the industrial employees...
In our steel industry...
50%. It is 20%.
Outside, sir, as per data.
Outside
global data is 34%. Indian data shows 58%.
Thank you, Dr. Tapas.
Indian data shows 58%. In our industry, it is 71% among the workers.
Okay.
Thank you,
Thank
Dr.
you very
Tapas. Next speaker, please.
Thank you so much, sir. I may now request Dr. Pankaj Kumar, BSL Bokaro, to present his topic, Prevalence of Hearing Impairment among Mobile Equipment Operators.
यहाँ से करेंगे, किससे कर सकते हैं, इससे करेंगे, ये अपने आप जा रहा है, थोड़ा दीजिए फिर कर देंगे, ठीक है। Honorable judges, respected chairperson sir, seniors and dear colleague, I am Dr. Pankaj Kumar from SAIL Vocational Plant. My topic is focused on prevalence of the hearing impairment among the mobile equipment operators. Let us know about the noise. Noise is nothing but unwanted sound, having adverse health effect. Meaning of noise can be subjective. One person enjoys the listening the heavy metal music at one volume, but same music at the same volume may be noise to another person. Decibel is the commonest way to represent the sound pressure. Normal weightage are here. Mobile equipment operators are the core component of workforce and play important role in production. MEOs operate different heavy equipment starting from overhead crane to bulldozers
and they perform tasks that support production and different service units. MEOs also do loading and unloading of the material from one place to another inside the steel plant. They also involved in inspection and maintenance of the heavy equipment. It is their duty to keep the equipment in proper working condition. During periodical health checkup, it was found that many of MEOs had some kind of hearing impairment. Hence, we decided to evaluate the cause of such study. We have conducted a study to find out noise level produced by different mobile equipment and that of ambient environment. Secondly, to compare the hearing status of MEOs and other working in the same environment and to find out prevalence rate of hearing impairment among the MEOs. A study was carried out at different shop floor of the steel plant where operation garage department deployed their workers in shifts. Total sample size was 160. After application of the exclusion criteria, sample size became 136, out of which 58 were MEOs and 78 were other employees. For better understanding the phenomenon of the hearing impairment, previous data of targeted employees were also involved. Sound level noise were measured by the sound level meter by our senior audiologist and periodical health checkup done as per the SOP. Those who had history of ear infection, oral malformation, head injury, family history of hearing loss, Meniere's disease, otosclerosis, and long-standing diabetes were excluded from the criteria. Data were analyzed on the basis of type of mobile equipment, year of exposure, and environmental component. This is a picture of our audiometry room. The slide clearly shows that heavy machines are very noisy, especially dumper, dozer, and crane. Those who are working away from the vehicle expose less to noise. After data analysis, it was found that about 52% of MEOs, that is 30 in number, have been found with the hearing impairment. In compared to other, only 16 people have been found. Here, p-value is less than 0.001, signifies the result that high hearing impairment rate had direct causal relationship with the high noise level at the cabin of the mobile equipments. Majority of cases, 18 out of 30, so deep at 4,000 kilohertz. Here, p-value is again 0.05, again significant. The slides show the severity of hearing impairment. It is more in mobile equipment and year of exposure, it is increased with the year of exposure. Out of 5 types of vehicle, excavator and tiller are less harmful. Sir, to conclude the prevalence of the hearing impairment, it is more in mobile equipment operators than the control group, and morbidity increased with the length of service. Mobile equipments are more noisy and it is generate noise more than the threshold limit value. Contributory factors are lack of safety awareness among the mobile equipment operators and poor equipment maintenance. This is the picture of our mobile equipment station. We recommended after the study, old vehicle must be phase off. Driver cabins must be air conditioned and properly insulated. Periodical health checkup of all the mobile equipment operators must be done at 6 monthly. Job rotation policy must be in place. Vehicle to be maintained properly. SOP for safe operations should be in place and followed meticulously. Thank you, sir.
Thank you, Dr. Pankaj. Now, house is open for questionnaires.
Sir, I'm Dr. Shweta from Bhilai Steel Plant. I just wanted to ask the number of cases having the severe sensory neural hearing loss because the noise exposure causes derangement of the outer hair cells. So the degree and the severity of the sensory neural loss is there seen in your study in maximum number of cases. So what are the precautions you are giving in an OPD basis for those patients so that it will delay the progression of the disease?
if the patients are in moderate or mild level, what prevention you are taking to reduce the conversion of moderate level to the severe level?
Madam, firstly, we have to aware our workers to, we have clearly showed that is the job rotation policy. The person should be replaced from the job, and properly mobile, protective equipment should be bears.
So what other measures you have taken to reduce that noise-induced hearing loss? Because that is one major concern, and the occupational health services also have a rule that you have to displace those employees who are having a even moderate form of hearing loss. So you do not believe in that?
Yes, ma'am, we have referred the person.
Or you give some equipments to them like ear mufflers or something like that, so that they can keep working in that place and their noise.
Even this protective equipment they don't wear.
That is for us to see. See, a small child also will like to jump here and there, then we tell them, this is how you have to tell them. That is where our counseling comes into the picture.
Yes, ma'am.
You have to reduce this kind of thing so that you do not have that dip of 4K.
Yes, ma'am. Yes, ma'am.
Because I was the chairman of NOHL, so I know that we have given some recommendations and we have told people that you have to put these mufflers, and the shift in charge has to look into that so that they follow those rules. And so that you can, less people will be aware, because comorbidities patients,
Thank
should
you,
not
ma'am.
place them in those.
Yes, ma'am.
Thank you, ma'am, for your
Thank you, ma'am.
valuable inputs.
Thank
Thank you, Dr. Pankaj.
Thank you, sir.
Next speaker, please.
Thank you so much, sir. May I now request Dr. A. Madhavi, VSP Visakhapatnam, to present her topic, Morbidity Pattern in Crime and Heavy Equipment Operators of RINL.
Like this, huh? This one. No. Yeah, can you start?
Good afternoon. My topic is morbidity pattern in crane and heavy equipment operators of RINL. Crane and heavy equipment operators play an important role in steel making. This is the periodical medical examination procedure we follow. Along with that, eye examination of crane operators, which is a statutory requirement. Aims and objectives to evaluate non-ophthalmic morbidity patterns in crane and heavy equipment operators, to assess the improvement after taking certain specific measures. Study details, it is a prospective interventional study. 480 crane operators less than 58 years of age group are included. Period of the study period is October 2020 to September 2024. Evaluated hypertension, diabetes, BMI, MSDs, 4K notch in audiometry, smoking and alcohol habits. Control strategies, awareness sessions, group discussions, individual counseling, treatment and referral and follow. Analysis, evaluation of risk factor reduction after the interventions. Exclusion criteria, history of trauma, neurological disorders, degenerative inflammatory musculoskeletal disorder, spinal surgery, total knee replacement, post-PTCA and post-mastoidectomy. Action plan, situational assessment, identifying the common causal factors and other factors, strategic plan and risk reduction evaluation. Age distribution of the study population, 47% of the study population belong to 51 to 58 years age group. Morbidity assessment is done by detailed history, general examination, BP monitoring, BMI, fundus examination, audiometry, blood tests, required ECG, and questionnaire used are standard Nordic questionnaire to evaluate MSDs, audit questionnaire for alcohol. Morbidity patterns, smoking 2.6%, alcohol 4.4%, MSDs in 11%, 4K notch in 7.6%. Diabetes 21%, hypertension 32%, and obesity in 10.2%. In detail morbidity description, 40% of the people said that out of 2.6%, they have more than 5 cigarettes per day. Alcohol, 45% that they take alcohol once in a week. Obesity 10.2%. Musculoskeletal disorders,
25% have neck issues, 21% have lower limb issues. In diabetes, the age distribution is 5% belong to 21 to 30 years age group, 65% in 51 to 58 age group. Hypertension, 3% belong to 21 to 30 years age group. Morbidity analysis in detail, causative analysis. 54% said that they do smoking for socializing, and 40% of alcoholics said that they take alcohol for time pass. Overweight and obese, 44% are taking junk food. MSDs, 40% have given a history of not taking rest break in their working hours. 4K knots, 62% are not using earplugs. Hypertension, around 20% are not having, they are under poor control even with medication. Diabetes, 12% are under poor control with medication. So the important points identified for discussion in counseling sessions are: smoking is to avoid sleep during the working hours, junk food or snacks in night shift to avoid sleep, alcohol habit for time pass, alcohol is good for health, not exercise to prevent of joints, earplugs obstruct hearing. Coming to the strategic plan, individual counseling session conducted for all the employees, followed by shop floor group discussions and small group counseling, followed by full day health education sessions, and followed by individual sessions for the follow-up. Under shop floor group discussions, engineering measure discussed were chair cabin repair and maintenance, staircase repair and maintenance, vibration control, all these aspects were discussed. Ergonomics, cabin chair standards, positions and movements, importance of rest breaks, posture corrections and spinal exercises. Coming to full day sessions, the topics covered are mind management, NCD control and habit control. Next, coming to individual counselings, we focused on ergonomics and PPE usage, exercise and food, alcohol and smoking, healthy hobbies for time pass, and sleep hygiene. Review and follow-up was done. This is the risk reduction analysis. Hypertension, 1%, we could reduce medicine withdrawal for 1%, medicine withdrawal for 1% of diabetics with lifestyle controls. There is reduction in 13% reduction in obesity, 27% reduction in musculoskeletal symptoms, 27% reduction in smoking, 57% reduction in alcohol, 25% reduction in 4K knots findings. Employees with healthy BMI increased from 12.7% to 18.2% after interventions, 23% reduction in low backache and 12% reduction in neck pain symptoms, 11% reduction in smokers with habit of more than 5 per day, 27% reduction in smokers with habit of less than 5 per day, 53% reduction in alcohol habit of 1 per week, 50% reduction in alcohol of 2 to 3 per week. This is the summary. Conclusion, integrated approach is the key for prevention and control of occupational diseases. Group counselings and regular follow-ups along with individual counseling leads to better and sustained results. Good counseling gives good results. Thank you.
Thank you, ma'am. Only short questions are allowed. 2 questions, please, only.
Madam, in a study, both hypertension and diabetes percentage are more, and your study population is also above 50 age group.
Yes, sir.
So it is natural that these people will have morbidity.
Yes, sir.
And how do you establish this occupational work-related?
So they are crane and heavy equipment operators. So mostly they do working in shifts. So that may be also the reason.
Yeah. You have to establish whether they are working for long hours, whether they are working in night shifts, duration of work. All this has to be established, and that has to be correlated.
Sir, actually my idea is to do the study, and still I am continuing the study. The reversible conditions I wanted to focus more, and I wanted to check the drug compliance for the hypertensives and diabetics. All those factors I considered, sir. Madam. Yes, ma'am. Okay, ma'am. Thank
Madam,
you.
regarding smoking, I have a question that, did you do the spirometry examination? Because smoking is a very important thing. And
Ma'am, only 2 questions are allowed, please, ma'am.
Okay, thank you.
Thank you, thank you.
Spirometry should have been added, how you have taken and help of taking this.
Sir, ma'am,
cigarette smoking.
spirometry we are doing, ma'am, but in this study, I have not included, but we are doing and we are taking care of that for everyone.
Thank you,
Thank
ma'am.
you.
Thank you.
Thank
Next speaker, please.
Thank you so much, ma'am. I may now request Dr. Sandeep Saha, Tata Steel Plant, to present his topic, Awareness of Uses of Ear Protective Devices at Workplace by Employee and the Hearing Assessment by Pure Tone Audiometry, a prospective observational study.
Good afternoon, respected panelists, judges, and the audience. Today, I'll be presenting a cross-sectional study on uses of ear protection device at workplace by employees and their hearing assessment by pure tone audiometry, a cross-sectional study. The occupational noise exposure causes hearing loss in 7 to 21% of workers, while noise-induced hearing loss is an irreversible form of hearing loss. Sound pressure level, there was a drastic decrease in the exposure time by half. The objective of the study was to assess the hearing impairment of the employees, to assess the correlation between the uses of ear protection device and severity of hearing loss, and awareness of the noise-induced hearing loss and use of ear protective devices. All employees working in high noise area visiting ENT OPD for any ENT complaints with a normal tympanic membrane on auto. Sometimes used were the employees who used ear protection device but not regularly. This was the questionnaire used in this study. On the right, you can see there is a high degree of hearing loss at 4,000 Hz, which is the earliest sign of noise-induced hearing loss. After analysis of the result, more than 75% of the employees were less than 40 years. 70% of the employees had less than 10 years of high noise exposure. 47% had all the time. 35% had most of the time exposure. 18% were occasionally exposed to high noise, like welders and data of frequency of use of ear protection devices were volunteered by the employees, of which 38% always used, 50% sometimes used, and 12% never used ear protection device. 24% of the employees had mild to moderate hearing loss. The comparison between the working of high noise with severity of hearing loss, there was 79% of moderate SNHL had more than 20 years of exposure, and 80% of mild SNHL at 11 to 20 years of exposure. There was a positive correlation between the all the time group which had higher number of hearing. The significant finding on use of ear protection device with hearing severity of hearing loss, where 100% of the employees who did not use ear protection device fell between mild to moderate SNHL. Regarding awareness on use of EPD, more than 80% of the employees were aware of the hearing damage on not using EPDs. And 65% of the employees were aware of about noise-induced hearing loss being a part of, can affect the quality of life after in old age. There were two similar studies. Hamid et al. Did a study on construction workers in South India. Zoa et al. Did a study on textile workers in Myanmar. They had a similar finding, but in our study was lower. Due to the paucity of study on use of earplugs and awareness, we had a finding of 88% use of earplugs and awareness of 65%. To conclude, noise-induced hearing loss increased with duration of exposure and number of years of exposure. Lower incidence of NIHL was seen in employees who always use ear protection device. A majority were awareness on the detrimental effect of NIHL and the benefit of use of EPD. Limitation of the study was age assessment of hearing loss was not done. Response bias could not be ruled out. These are my references. Thank you.
Thank you, doctor. Please introduce yourself before asking the questions.
Whether
Good afternoon, sir. I am
Good afternoon,
Tapas Mandal from Durgapur Steel Plant. Sir, you have conducted a study in your OPD.
Yes, sir.
Actually, generally, noise-induced hear loss, actually, it is done before the shift started and after the shift started, finished.
Yes, sir.
Then only you will come to know whether the hearing loss is due to noise induced in the workplaces or not. Secondly,
Yes,
have you taken into consideration of using mobile phones? Nowadays, everybody is having smartphone, using earphones. That is also affecting our ear. So have you taken that thing into account?
Yes, sir.
Because we have not seen that is not reflected in your
Thank you, sir,
presentation.
for the question. First, to answer the first part of the question, I've done the study in the ENT OPDs so that to generalize the population. And the patient and the employees tested before the start of the shift and after the start of the shift does not differentiate between the transient loss of hearing due to sudden high noise exposure. So I was focused on the permanent damage that is done. And regarding the second part of the question, the mobile use was not included into the questionnaire.
Because nowadays it is affecting our
Yeah.
ear, and that we have seen in our employees who is basically posted in office, but he is listening to music all the time. His ear is affected.
Yes, sir. But again, those are not the high noise area people. These are the desk people, I mean, clerical work people.
Still it is affected.
Yes, sir. Thank you, sir.
Your study is a cross-sectional study.
Yes, sir.
Yeah. How can you can give message to your management that you have done this study and what is the compliance rate?
Yes, sir. This study is more or less is acting as a platform to understand the prevalence and the awareness regarding the EPDs. So we are planning to go a step forward and emphasize on the compliance of use of EPD and the awareness regarding NIHL.
But the study population is very less, and you did the study in ENT OPD, which you have done in OHSC.
Yes, sir. The OPD in OHS, the issue we were facing was it was secluded to only one area of the high noise people. In OPD, we had that generality of even taking welders and carpenters who were working outside the plant into the study for the exposure. Thank you, sir.
Thank you, doctor. Next speaker, please.
Thank you so much, sir. I may now request Dr. Seal Kumar Thakur, BSP Bhilai, to present his topic, Occupational Stress Among Employees of Bhilai Steel Plant, Prevalence and Associated Factors.
Good afternoon to all, respected judges and delegates. I am Dr. Seal Thakur from Bhilai Steel Plant and OHSC. My topic for OHS paper presentation is occupational stress among employees of Bhilai Steel Plant, prevalence and associated factors. These are my main contents. Coming to the introduction part, occupational stress is defined as the physical, mental and emotional strain experienced due to demanding nature of work environment. It impacts health and productivity of employees and affects their physical and mental health as well as organizational outcomes. Coming to problem statement and need of this study, in India 55% while globally 43% employees reported feeling stressed, which has economic impact also. In context of Bhilai Steel Plant, challenging working conditions affect their physical and mental health, and due to limited research in this field, we took up this study. Coming to aims and objectives of this study, main aims and objectives were to measure prevalence of occupational stress, to identify demographic factors, to assess impact of workplace factors, to evaluate stress levels, and to provide actionable recommendations. Coming to material and methods, this was a quantitative cross-sectional prospective study where stratified random sampling was done, covering a population of 200 employees, including 100 regular and 100 contractual. Data collection was done using a structured job stress questionnaire and were then classified as cases of no stress, mild stress, moderate stress, or severe stress. Study duration was from August to October 2024. This was the structured job stress questionnaire used for this study by me. These were more inclusion and exclusion criteria. Full-time, regular and contractual employees were included, both male and female, and high-level management employees like GM and above were excluded from this study. Coming to data analysis part, SPSS software was used for data analysis, and anonymity and confidentiality was maintained, while voluntary participation was ensured with informed consent. Coming to the results part, first result introduces us to the participants' demographics. Second result, which was education based, showed that ITI level employees were more stressed than others. Third result, which was age based, showed that those around 35 years of age and between 58 to 59 years were more stressed than others. Fourth result, which was gender based, showed that overall males were getting more stressed than females. Fifth result showed that non-executives were more stressed than executives. Sixth result showed that hazardous area employees were more stressed than non-hazardous area employees. Seventh result showed that high salary scale employees were less stressed than low salary scale. Eighth result showed that those with less year of service were more stressed. Ninth result showed that fewer facilities among contractual employees were making them more stressed. 10th result showed that physical stress demand is making contractual employees more stressed. 11th result showed that more than 46% employees were feeling more stressed due to high job controlling positions. 12th result showed that regular employees had more sure chance in job decision making. 13th result showed that regular employees reported slightly higher personal growth than contractual employees. 14th result showed that senior staff faced higher stress linked to accountability. To summarize, of 200 employees, 82% cases were having no stress, 17.5% were cases of mild stress, 0.5% were moderate stress, while overall there was no case of severe stress. Among regular employees, 75% had no stress, and among contractual, 89% had no stress. Overall, ITR employees, those aged 35 and from 58 to 59, overall male gender, non-executives, hazardous area employees, and those on low pay scale and new pay organization perceived more stress than their counterpart. There was no significant association between variables like marital status, history of alcoholism, or smoking. To conclude, stress in today's world is an unavoidable factor, but stress in the Bhilai steel plant is very low when compared to its prevalence in India or globally. Due to these factors, the company has good interpersonal communication between management and the employees and runs stress management programs and campaign. It has full-fledged department of psychiatry and an occupational psychologist for counseling and treatment of employees in need, and also a redeployment committee to address cases of high stress. These are my recommendations: to implement targeted stress management programs, to promote flexible work arrangement, counseling and stress management programs for female contractual employees to elevate their stress levels, job control for selected contractual employees, and finally yoga and meditation classes for campaign for employees, especially those facing high stress. To end, I would say a healthy employee is a productive employee. Thank you.
Thank you, Dr. Thakur. Now, house is open for questions.
Is it stress in a working condition of steel plants or as a whole?
Yeah, working condition of steel plant, because we have, I have already said, from 25 year to 60 year. Before retirement, employees were considered both contractual and regular employees.
Because family problems are a very big stress.
Yes, yes. But
the prevalence already it is there.
But what I can say that when an employee is there, whether contractual or regular, he is financially stable, and we do regular health checkup. And if it's presentism is there, mainly if he is coming to duty, it means his mental health is good. So from general population, he is better in a financial condition or health condition, both way.
Financially, it's okay that non-executives are more.
No, non-executives had different other stressor factors, and executives have other stressor factors. Non-executive were more facing front line workers like.
So when you combine both of them, stress is same in both the.
Yes, somewhat non-executives were more.
Your study is on occupational stress. Right, please.
I am Dr. Sinha from ISP.
Good afternoon, sir.
Good afternoon. Sir, how did you assess the stress to be mild, moderate, and severe?
Sir, yeah.
Let me complete it, because it is subjective. A stress level may appear to be mild to me and moderate to the other. And it is hard to believe that 82% of your population had no stress at all. A person working in a steel sector or in any sector having no stress, it is difficult to digest.
I am coming to that, sir. I have made a questionnaire. We have 7 sections covering all parts, and we have 33 questions. Maximum marks were 24 from 19 to 24. Those getting 19 to 24 were considered a case of no stress. And below that, we have mild, moderate, and severe stress. Those scoring less marks were cases of high stress. There was no case of high stress.
Yours is occupational stress. That means noise-related stress also will occur.
Yeah, related to working conditions of plant.
You have not mentioned anywhere in your study.
Yes, sir.
In the study, you have not mentioned whether it is due to the work-related stress. That means due to noise, high noise level.
Yes, sir. Yes, sir.
Dusty environment. Maybe if you
plant is not free from hazard. Any area of plant is having hazards. So actually we have correlated those factors which are more relevant to plant, Bhilai steel plant.
Thank you, Dr. Thakur.
Thank you, sir.
Thank you so much. Now, this was an informative end to our OHS paper session. I may now request our judges, Dr. Radha Satpathy, Dr. Uma Devi, and Dr. Tarunaditya Mishra to grace the dais. I may now request Dr. S.S. Patil, Additional CMO DSP Durgapur, to present token of appreciation to our judge, Dr. Radha Satpathy and Dr. Uma Devi. I may now request Dr. Surendra Kumar, Deputy CMO RSP Rourkela, to kindly present a token of gratitude to our judge, Dr. Tarunaditya. May I now request to Dr. Surendra Kumar, Deputy CMO RSP Rourkela, to kindly present a token of gratitude to Dr. S.S. Patil, Additional CMO DSP Durgapur. I may now request Dr. S.S. Patil, Additional CMO DSP Durgapur, to present token of appreciation to Dr. Surendra Kumar, Deputy CMO RSP Rourkela. Thank you so much, everyone. I may now request Dr. Anil Datta, ex-CMO RSP Rourkela, and Dr. Maharaj Majhi, Additional CMO RSP Rourkela, to chair the session and grace the dais. Now request Dr. Anil Datta, ex-CMO RSP Rourkela, and Dr. Uday Kumar Das, ISCO Burnpur, to chair the session and grace the dais. Moving on ahead with our guest lecture. In this guest lecture, our time duration is 30 minutes, 25 minutes for presentation, after 20 minutes, one buzzer, then again after 5 minutes, one buzzer to mark to end the presentation, and 5 minutes for the interactive discussion. I may now request our speaker, Dr. Manjori Mitra, Institute of Child Health, Kolkata, to present her topic, Unlocking the Code of Genetics. Dr. Manjori Mitra, at present, she is a professor in pediatrics in Institute of Child Health, Kolkata. She is also working as a research director, MedClean Research, Kolkata. She is an integral part of numerous national and international advisory boards and working group committees on immunization practice guidelines. She is an expertise in pediatric infectious disease, vaccinology, and pediatric care. She is a pioneer researcher with more than 50 publications and clinical research projects in the field of vaccines and infectious disease. Also, and reviewer of Indian Pediatrics and Indian Pediatrics IJPP. Ma'am.
A very good afternoon and thank you all. And it is a wonderful, I think it's a pleasure for me to come to a totally different platform where I see a whole lot of dedicated, and I would see that barring our professional commitment, the commitment in this forum is much beyond the responsibility, accountability, whatever I was seeing through the paper presentations. I think it's a huge lot of responsibility, accountability you all take. So today I will be discussing about a rare disease which we do think we have read in our undergrad days. But this rare disease, what we have called as rare disease, is really no more rare, and that is the reason we are here today, to create an awareness the way you have taken care of the entire society who are working in the industry of the steel plants. I'm sure with that huge population, if you consider the incidences, it will not be so rare. And I don't know whether we have patients on rare disease which has been diagnosed in the steel plant, the total population or not. So we will be discussing, basically there are 4 or 5 rare diseases which has a treatment. And today, considering the central government interest and providing the treatments for these patients, it has become very important that we don't miss out the diagnosis. And as I said, we need to have an awareness, otherwise we will miss the diagnosis because it has a protean manifestation with many of our common diseases. Of them, we have the Gaucher disease, which is one of the commonest, the MPS 1 and the MPS 2 treatment available in India, Pompe, Fabry's, and the ASMD diseases, which we have in India treatment. So the genetic disorders, where is the timer? The genetic disorders of the metabolism, we have all the panels. I'm not going into those details. Now, what are the lysosomal storage disease? It's a subcellular organelles referred to as the cells recycling centers. And I said there are more than 50 genetic disorders, mostly autosomal, recessive, and X-linked diseases. And it's a progressive disease, and henceforth it's very important to diagnose as early as possible. It is basically because of a specific gene mutation which creates an enzyme deficiency, and because of the enzyme deficiency, the defective lysosomal acid hydrolysis of the endogenous macromolecules, there's a substrate reduction in the entire process, and all this substrate goes into various organisms and gets stored in various organisms. And if we cannot take care through the treatment which is available, then automatically they will go into the irreversible organ damage. Now, the lysosomal storage disease, as we have said, just to have an inheritance pattern recapitulation, I'm sure all of you know the X-linked inheritance. Mostly parents are the carrier and one can be affected, and we know the ratio of Mendel's either 1 in 25, 1 in 50 is the affection, and this is more important for your prenatal counseling for a subsequent sibling. Similarly, the autosomal dominant, we again have the same ratio of either 25% or 50% affected. So one affected, we need to, when we do a prenatal counseling for the next pregnancy, we need to know the parents' inheritance, and based on that, the counseling. So that is another chapter which we can start doing once we make ourselves aware of the diagnosis of the diseases. So signs and symptoms vary within and between the diseases. So most important is the clinical suspicion. And clinical suspicion only will come if you have an awareness. And this awareness only will come if you have a passion for diagnosing the disease. Unless the way you have a passionate for controlling and preventing the patient for hazards, similarly, there should be a passion in every individual to make a diagnosis, because we know the treatment is there, and the treatment, if given timely or even a little late, has a reversibility, and the patient absolutely has a normal life. So the lysosomal storage disease, as I said, it is a multidisciplinary team support, symptom-based and the disease-specific therapies. The history of lysosomal storage way back from 1881, it has been there. It was in our books, textbooks. At least we in our generation, and many of you sitting here, we never bothered because we didn't have a treatment. But today, since the treatment is there, we need to be bothered. Otherwise, we'll deprive the patient who is suffering from this disease. So target will be obviously early diagnosis, so that we diagnose in the reversible stage, but problem maybe the reversibility will be a little less, but we have a long time. If you see the chart, the reversible stage is for a long time, and if really delayed, then the treatment gets not that effective, and it is an evidence-based treatment. So let us go to the first most common disease, the Gaucher's disease with treatment series, which is available in the market. To make you understand how we miss diagnosis and what is the trouble we give to the patients over the time period. This was a male child from Murshidabad, West Bengal, student of 3rd standard, weighing 19 kgs, visited a local pediatrician there with the complaints of intermittent pain abdomen for last 2 years. There was no history of jaundice, bleeding, and blood transfusion was not there. He was advised pain-relieving medication along with ultrasound. The ultrasound revealed a huge splenomegaly with mild hepatomegaly. He went to SSKM Hospital OPD and he was investigated for splenomegaly and all the routine blood tests. The HPLC showed negative, iron was all within the normal limits or slightly raised, and the other parameters showed only thrombocytopenia, otherwise the report was normal. So now it was referred to a pediatric gastroenterologist. So the gastroenterologist was looking through her window and obviously looked into the gastroenterological part. LFT and Doppler and upper GI scopy was done. So look at the reports. The only finding we have the organomegaly, splenomegaly, hepatomegaly, and the thrombocytopenia persisting. Others are more or less okay. So under this, obviously the patient was repeatedly undergoing gastroenterology again from Kolkata. As you know it, they have to go to the south to make a diagnosis. Even in AIG Hyderabad, they did a repeat investigation of the similar repeated diagnosis with ultrasound or endoscopy, but when they didn't find anything, they went for a bone marrow when they got the Gaucher cells, and finally enzyme assay proved to be Gaucher. So what this study shows, what this patient shows, when they came back to West Bengal, they came back to our institute, we suffered from seizures, and then the patient was advised for bone marrow transplantation and ERT. Now bone marrow transplantation is another story. I'll touch upon one word if I have the time. Sorry, I can't see. So the main message will be from this is that if you have to suspect Gaucher disease, then the first and three most important thing I would like to harp upon, if you have a splenomegaly, splenohepatomegaly, and you don't find your first common diseases, which is hemoglobinopathies, and if you don't have any, please do a GBS, that is a Gaucher's enzyme, which is easily available. I'm sure you know about the dried blood spot. You have to take one blood and then you send it across and you get an enzyme assay. If the enzyme assay is positive, then the entire thing takes care, as it is done through the mutation, and you can have the therapy. But if you delay, we may have other diagnoses, but the way I'm trying to focus, if you have an awareness, please keep the rare diseases also in your second line diagnosis. Don't delay too much. If you are doing endoscopy, for this particular case, you may do endoscopy, you may rule out other causes, but don't forget to send a simple dried blood spot in a blotting paper. You have to send only one drop of blood and your enzyme assays are there. So that prevents the patient from having other diagnoses. And if the incidence is 1 in 40,000, I'm sure in Raulkela and in the steel plant, there should be by now many cases which has not been diagnosed. So it's the most common lysosomal, it is multisystem, we have seen, it's a recessive, and the enzyme deficiency is acid beta glucosidase, which gets engorged in the macrophages, and ultimately the different organs get affected. So this is the various organs, the bone marrow, so that is the reason one of the common finding is the thrombocytopenia, other is the spleen and the liver, and even the bone organs get affected. So subsequently, the more aggressive diseases, you see that nearly 87% is hepatomegaly and 95% is splenomegaly. So splenohepatomegaly, you are not finding your first line of causes of thalassemia or the hemoglobinopathies. Please send a dried blood spot for the Gaucher enzyme. That should be the summary of this entire Gaucher disease. And we know there are 3 types. Type 2 is the neuronopathic, which is a severe, this child does not survive beyond 2 years, but the other 2 still has a anytime presentation, and even we have seen adult patients with Gaucher disease, a different mutation. They are surviving because probably the enzyme activity is little better, but this is the process where you need to make your process of diagnosis. 1 second. So your differentials, the common differentials are acute lymphoblastic leukemia. The common differentials, acute lymphoblastic leukemia, yes, multiple myeloma for the adult patients, Hodgkin's lymphoma. So when are you thinking of all those? Because they are manifest in the same way. Again, my message will be, don't forget Gaucher's disease. Keep it at your top of your mind. If you don't keep at top of your mind, you'll never diagnose. You'll miss the diagnosis, and today people are diagnosing, but they have to root the same example which I showed in our Kolkata. It went through various hospitals in Kolkata, then to AIG Hyderabad, and then underwent so much of differential diagnosis and all the diagnosis, but a simple blood test could have diagnosed at the very beginning. So 3 pointers for Gaucher's disease: hepatosplenomegaly, thrombocytopenia, unexplained in your first setting. Think of Gaucher's disease. It has to be as simple as that, otherwise we will miss out, go on missing diagnosis. So I'm not going into the algorithm because the first and foremost thing is the same thing which I said. And regarding the treatment which we have said, the imiglycerase which is available and the valaglycerase, these are the 2 treatment available. We have to give every week, lifelong, and the treatment remains around 4 lakhs per month. So it's a very costly, but the government is giving us support and we have to help the patient. So let us go into the next one, is the polymucosaccharide is with the treatment of the laronidase. Again, a similar thing. We have this lot of mucopolysaccharide which is available internationally, but in our country it is only MPS 1 and 2. Again, a similar incidence is there, 1 in 8,000 if you consider total lysosomal, and MPS is 1 in 1 lakh. And the pathophysiology remains same for all the lysosomal storage disease. If the enzyme is missing, the substrate goes on accumulation in various organs. And the most important thing is the lysosomal enzymes, if missed, the glycosamine glycans are deposited, the GAG, which you may get in the urine. But the amount deposit depends on the activity. If the activity is less than 1%, you get severe, but many at times the activity of the enzyme is little more, so you go on having delayed manifestations. So this is the spectrum of the disease. So you have a very severe disease and you have a very attenuated disease. Even in the adulthood you may find, and we may miss the diagnosis, but it's still there. But our early diagnosis is very important. From 1 year to 7 years, if you can make a diagnosis, it helps in the reversibility of the disease. So again, the organ involvement as the substrate gets, the corneal clouding is one important thing. So you have a coarse facies, and the other important suggestions will be umbilical and inguinal hernia. So if you have a coarse facies, a little bit of thatched hair, bushy eyes, thatched hair, prominent forehead, umbilical hernia, unexplained beyond 1 year, please do a MPS enzyme assay. So the manifestations, as we said, the corneal post features, bushy earlids, I am bushy hair, thatched hair. If you think of not getting any other cause and organomegaly, some mentation, do a enzyme assay. So again, we have a treatment for that, which is bi-weekly, and it is a lifelong treatment. Any of you have diagnosed any of those lysosomal storage disease in your institutes, in your industry? As of now? We have some diagnosis? Not yet.
Good afternoon, ma'am. I'm Dr. Preeti Srivastava from Tata Main Hospital, Jamshedpur. I have been looking after pediatric neurology.
Lifelong, and we have nearly 150 patients amongst all the lysosomal storage disease who are getting treatment, and they are really perfectly normal and living a normal livelihood, career, even getting married. So it is a little trouble, but it is an effort which everybody has to make to get the treatment. Now, one is a government setup. Now, when we are talking of Gaucher, have some time, but when you're talking of Pompe, yes, particularly infantile, you don't have much time. Unless and until the treatment is initially and initiated very early, the patient will succumb. But if you have a Pompe with a late onset, you have some time for the treatment. So whenever you are diagnosing, I have a belief that probably the steel plant can support the treatment. That is what I was coming from. But if it is not so, you are sending to some COEs like in Kolkata, SGPGI.
The child was a non-entitled, was not from Tata Steel.
Okay.
Yeah,
So then the patient has to go in the COE areas, and in the eastern region it is Kolkata, SSKM hospital. slowly and slowly the awareness is growing and people are looking into the diagnosis. So this is where I come in Pompe. Typically, a Pompe disease, as we heard, it will have an infantile onset, it will have a late onset. And typically you have a floppy child. In infants, floppy, you think of SMA, but you should also think of Pompe. Send the blood. Cardiomegaly may or may not be present, but if it is a Pompe, please rule out with a DBS for the enzyme assay. And late onset will have a time which will go mostly to the neurologist and then adolescent group. So that is where area, but the whole enzyme exercise is the weakness of the muscle not explained and unexplained within a few days of getting the therapy. That is important. And I would suggest that when you are sending, referring to anyone, if you can send it to SSKM and you are sending SSKM, they keep a tab of the data. So with that data, I was thinking that we should start building up data across East and start publishing the data so that we have a robust data of the rare diseases, treatable lysosomal storages disease in the eastern sector. So again, any hypotonia with a weakness, even I'll tell you one, when I went to Taiwan for a conference for 3 days on Pompe disease. And after 3 days of Pompe, whatever I was seeing, I felt that it is probably a Pompe, and I used to send a DBS, and unlikely atypical things came positive. Patient was admitted in ICU, PICU with a sudden respiratory distress, very high PCO2, no extra changes, nothing. So I just sent a CPK and it was very high and the DBS became positive. So something like a unexplained respiratory distress with a very high retention, unexplained swallowing difficulty in a very young patients, less than 1 year, you should think of Pompe. That type of suspicion should be there. And the last disease is the sphingomyelinase deficiency. And the Fabry's is another common thing. I'll just brush through Fabry's because that is in the little elderly population we see any patients with, this is a very classical finding of Fabry's, the angiokeratomas, which you should suspect. If there is an unexplained angiokeratoma, send for a DBS for Fabry's enzyme. And if you have unexplained proteinuria in your urine and don't find any cause, send for Fabry's. These are the two things about Fabry's, I would say. Again, the same things, the GL3 tissue gets deposited in various areas to create the symptoms. Now, so enzymes, as I said, and the last will be the ASMD deficiency. This is the classical Niemann-Pick disease which we have. It classically follows Gaucher disease, same hepatosplenomegaly, same thrombocytopenia. The only difference is you may get a dyslipidemia. If you have a hepatosplenomegaly with dyslipidemia, other things unexplained, you can keep a suspicion of probably a Niemann-Pick I'm dealing with, and you send your DBS dried blood spot to get the enzyme, and then subsequently a treatment parameters comes into the place. So these are the hallmarks just to show you in DBS, between the DBS and the Niemann-Pick, the difference is the liver fibrosis you have, the interstitial lung disease, the dyslipidemia, and the transaminase elevated, not significantly elevated like a liver failure, but marginally elevated, unexplained transaminase, and hepatosplenomegaly, think of a Niemann-Pick. So we have 3 types. So mostly we have the enzymes is also very recently in the market. Very few patients has been getting that. And I would request that we go into the entire perception and entire objective of this year is not delve deep into the lysosomal storage diseases, but create an awareness and understand that DBS is freely available. I'm sure Sanofi is distributing the DBS blood spot. Just one prick, send it to, they are tied up with Gangaram and other hospitals in Jaipur and all. So just start making a habit of sending the dried blood spot for enzyme assay. If you don't have the habit, today I'll tell you there's another Indian company, tomorrow there'll be another Indian company, the total cost will come down, and the patients who are not diagnosed, they will live for another 10, 15 years, but by that time they will land into irreversible damage, and we have led them to the pathway but not diagnosing by not creating the awareness in our mind. So that is all about mine.
Thank you, ma'am. Thank you very much for a nice deliberation. since we are running short of time and next speaker has to catch a flight. So no more question, please.
Yeah.
We can discuss in detail. Thank you, ma'am. Thank you for a nice deliberation.
Thank you so much, ma'am. I may now request Dr. Anil Datta, ex-CMO RSP Rourkela, to present a token of appreciation to Dr. Manjori Mitra. I may now request Dr. Uday Kumar Das, ISCO Burnpur, to kindly present a token of gratitude to Dr. Anil Datta, ex-CMO RSP Rourkela. I may now request Dr. Anil Datta, ex-CMO RSP Rourkela, to present a token of appreciation to Dr. Uday Kumar Das, ISCO Burnpur. Thank you so much, everyone. Moving on ahead with another guest lecture, I may now request Dr. Manoj Kumar Pradhan, Additional CMO RSP, and Dr. Manoj Kumar Deo, Senior Consultant RSP, to chair the session and to grace the dais. In this guest lecture, our time duration is 30 minutes, 25 minutes for the presentation, out of which 20 minutes, one buzzer, then again after 5 minutes, one buzzer to mark to end the presentation, and 5 minutes for the interactive session. I may now request our speaker, Dr. Amit Jaiswal, to present his topic, Minimally Invasive Neurosurgery. Dr. Amit Jaiswal, Director and Senior Consultant Neurosurgeon at Manipal Hospitals, Bhubaneswar, is a highly accomplished expert with over 26 years of experience, including 15 years of neurosurgery. He holds an MBBS, MS General Surgery, and MCH Neurosurgery from prestigious institutions, along with a fellowship in minimal invasive spine surgery from Germany. Dr. Jaiswal specializes in advanced neurosurgical procedures, including brain and spine surgeries, pediatric and vascular neurosurgery, and minimally invasive techniques. A recipient of the Times Health Icon Award, he is an esteemed member of multiple neurosurgical societies and has contributed significantly to research and education in his field. I request Dr. Amit Jaiswal to present his topic, Minimally Invasive Neurosurgery. Please, sir.
Thank you for that introduction. Big thanks to the organizers, respected chairman, and everybody here. I would like for next half an hour to give you a sneak peek in the advances in neurosurgery that has happened over last decade. Minimally invasive neurosurgery, like in any form of surgical fraternity, we have seen the technological advancement that has happened. This is my hospital, and as we work, we evolve, we make our team, and that is how we grow. Without a good team, scrub nurse, technicians, anesthetists, it is impossible to give good results. So when we talk about minimal invasion in neurosurgery, it by and large means interventions by which applications of modern technology is used enlarged surgical opening in the body cavities can be avoided. It is more efficient, it's more safer, it's now over a period of time has cut down on the cost of, in terms of to the patient. It's less aggressive as a surgical approach, thereby having a better tolerance without compromising the outcome. It is much more broader than only the surgical approach, where when we approach a patient, minimal invasion is not only the surgical approach, but the mindset. So the philosophy attribute actually makes this surgical technique beautiful, starts from the pre-op time. In the pre-operative time, we see that earlier days, when we used to ask the girls to shave their head for a new surgical procedure, it used to be a taboo that how can you remove our head? So that is where this whole thought of not removing hair is also a minimal invasive thought process. So nowadays we don't shave the head when we operate on brain tumors or any other procedures for brain. So similarly, loco-regional anesthetic advancement as it has happened, we have these beautiful blocks which has come up. We can do awake craniotomies by these blocks. Accurate access localization, minimal access, minimal CNS aggression, and ultimately giving the patient a beautiful cosmetic outcome as well. Post-operatively, these procedures tend to have lesser ICU stays, lesser intravenous drugs which are used. They can be started on early oral medication and lesser hospital stay, thereby paying lesser amount for the cost goes down. One of the important concepts in minimal invasive neurosurgery over last decade has been evolution of neuroendoscopy. And neuroendoscopy has been now come into forefront into various pathological areas, be it brain or spine. And what it is, it's basically a technique. It consists of navigating through the intracranial cavities using visual control, using optical devices that allow us to perform these maneuvers. These are certain instruments that we use. And as I said, the applications are in brain and spine. I will just give you some examples which are commonly done and also which are now become a gold standard in some of these cases. Earlier, this is a scan which you can see. Most of us who work in emergency, in ICU area, we keep seeing these strokes. This is a hemorrhagic stroke. It's an ICH. And earlier we used to do bigger craniotomies to remove this. Now this can be dealt beautifully with a use of endoscope. We drill holes, do a burr hole and put an endoscope inside and remove the clot. And this is how we do. We have to do a burr hole. Earlier we used to do bigger craniotomies. So now we can use, there are specific instruments which are used with this endoscope to remove this clot. It's a very, very safe procedure and the outcome is beautiful. So you can see how these post-op scan is seen once you remove this. This has a learning curve. It's a very blind area that we put the scope in. We have to be very sure how much and till what extent we have to remove this clot. These are certain other examples here. Thalamic hemorrhage, lobar hemorrhage, all these cases can be beautifully dealt with this procedure. Some are the examples. Similarly, there are other approaches. I don't want to go into details of this, how this happens. This is one more video where there is a rigid endoscope being used and there is a sheath. So you drill a hole, do a burr hole, put this sheath inside the cavity where the clot is, and there is a suction aspirator which is used to remove these clots. Once you remove the clot, you can see the brain pulsations, and that is where we know that we are through. Another beautiful example of using this endoscopic procedure in neurosurgery is removal of cellular lesions. Pituitary tumors are very, very commonly seen in our daily practice. So the advancement in this area has led us to give fantastic result and outcomes in terms of when it comes to pituitary surgery. And it all started in early 1900 when Cushing started to find out a way to reach these cellular lesions through the nose. And earlier he used microscope, and later this advancement gave us this instrument, endoscope, where ENT surgeons were using this for the nose. And later on, we took their help and went ahead to reach the cellular lesion. Just to give an idea, I don't want to go into details, the anatomy of the cellular area where the pituitary gland is. This is the gland. Again, this is a very common picture that everybody has read in their medical schools. So pituitary tumors are varied types. I don't want to go into details. They present in myriad forms, primarily hyperfunctioning, or can present as mass effect, giving the picture of headache or vision loss. Majorly, they come with headache or visual loss, and bitemporal hemianopia is a classic perimetrical picture. In radiology, we see how these tumors look like. This is a classic MRI where this is the tumor, and this is sitting exactly in the cellular area with a supracellular extension. So this is how these endoscopic procedures for these tumors are done. The position is like this. The patient is supine with head turned, fixed on a clamp, and this is an intra-op image of the patient being positioned. The nose is clean, prepped. We have an ENT surgeon to give us assistance while we are maneuvering the nose. And once we are inside the nose, we keep ourselves navigated and checked by using X-rays and taking X-rays. And nowadays we have neuronavigation at hand, so that really is another helpful tool when you do these surgeries. So this is where you can see it's just the nostril. The scope goes inside the nostril, removes the vomer bone. We reach the cellular floor, and the cellular floor is removed. It's a very thin structure, so we have to drill it carefully. The dura is open. As we open the dura, you can see the tumor bulging out right onto us. Curates are used to pluck out these tumors piecemeal. And slowly you can see behind this arachnoid membrane. This is the membrane which now you can see will start pulsating. That is where you know that yes, you have removed the entire tumor. Earlier, this was not at all possible using microscope. So endoscope has made this surgery gold standard now. Post-op, this is how we just put some packs, keep it for 24 hours. After 48 hours, patient is good to go. This is a beautiful procedure if done carefully, although it again has a learning curve, but this has now become a gold standard when it comes to removal of these tumors. Similarly, there are giant non-functioning pituitary adenomas which can be dealt with this. Again, there are cases where we see, this is a classic example of this hyperfunctioning pituitary adenoma, and this lady has acromegaly. So you can see how acromegalic patients they look like. Similar approach. Here, the more important is to remove each and every bit of the tumor where this endoscope helps. If we leave a small bit of tumor also, the growth hormone doesn't come down, and they don't go, the symptoms and the facial features, they don't come down. So we have seen beautiful results with this. As I said, a team is very important. An ENT surgeon assisting you makes your life much easier. There are other areas where endoscope is used, specifically when it assists you in microneurosurgery. And we sometimes do a combined open and endoscopic procedure together for these cases. This was a case where there is an ACOM aneurysm, which was very oddly positioned neck. So we had to take an endoscope to visualize the neck and clip the aneurysm. Similarly, there are examples of certain tumors which are huge and giant, where you cannot remove in one go, like these ones. These are giant pituitary adenomas where you cannot remove from below. I mean, only endoscopic procedure won't help. So you take you use both combined open as well as these minimally invasive procedure together. And this is how we do. This is a procedure where we have combined both craniotomic, the approach is open procedure, as well as endoscopic. This is where the craniotomy is done. We can see the tumor coming into visual, and this is how we open up the tumor. The tumor is sucked. As we see the video, we can see all these major circle of Willis, the arteries are around this tumor. We have to be very careful at that time. This is how the endoscopic vision looks. And the surgeon is operating from down. The assistant surgeon is on top. And now you can see both the instruments kissing each other. So that is where we know that we have removed completely the tumor. These are certain cases where we need to use these fantastic tools to our usage. Post-op. Another example where endoscope has really changed the scenario is hydrocephalus. This again is a very commonly seen in pediatric age group as well as in adults. So this is a classic MRI showing a picture of hydrocephalus. The ventricles are enlarged. This is a normal scan. This is a hydrocephalic brain. Endoscopic third ventriculostomy. This procedure has changed the entire treatment options in terms of hydrocephalus. Earlier, we used to do shunt procedures, VP shunt, as we all know. This was, again, an implant which was used. So now they have after these procedures have come, it has really changed the outcome. Endoscopic third ventriculostomy, or ETV, is a procedure for treatment of hydrocephalus where we create an internal opening in the floor of third ventricle using an endoscope through a burr hole. A very classic picture in all the medical books we have seen, hydrocephalic child with sunset sign of the eyes. This is an image where how the scope is positioned through a burr hole. It goes straight into the foramen of Monro and into the third ventricle. This is a cadaveric picture showing the anatomy of the ventricles. This, I would like to just show you a small clip of here we see the MRI, and so this anatomy is as you enter the ventricles. This is a classic anatomy when we visualize, and we have to see the anatomical structures. We know the orientation. It's very important to keep ourselves oriented. And as we go inside, this is how it looks. The foramen of Monro is right ahead. The scope is seeing the foramen of Monro. Now, as we enter the foramen of Monro, we are straight into the third ventricle. So the third ventricle is the area which is where we are going to work. And as we go in, we can see the floor. That is, the floor is the floor of third ventricle, and that is where we have to make an internal opening. The red spot ahead up in this video is the basilar top. So this is a very dangerous area. We have to keep away. Any problem here can lead to devastating hemorrhage intra-op. So this membrane which you can see pulsating, is the floor of third ventricle, and we have to use very specific instruments here to make an internal opening. So we have to coagulate, like this is a coagulator. We have to coagulate the membrane and use a Fogarty catheter to enlarge this internal opening. Now, MRI is there, like I'm just going fast. This is how the hole is being made, and a Fogarty catheter goes in and enlarges this internal opening. So there is no shunt, nothing. Post-op, patient can be discharged second day. And these were certain procedures in brain. Similarly, in spine, this endoscope or the minimally invasive concept has revolutionized how we look or how the spine surgery was a decade back. Open procedures made huge incisions, lot of bone loss, patient lying in bed for days, lot of pain, But after microscope coming in, microdiscectomy started being gold standard for removing these discs, lumbar discs. And subsequently, even now, microscope is being used, but through a smaller opening. So this is a classic example, a huge lumbar disc at L4-5, and this can be removed beautifully through now a small incision using tubular retractors. Either you use an endoscope or microscope, doesn't make a difference, but the opening is the same. There is beautiful retractor systems now, tubular retractors which is available. You can see the conventional surgery gives a very bad scar, huge, big surgical incisions and poor outcomes. And this is how these fancy tubular retractors which are available with us. And this is a very, very small opening. We can go in, use endoscope or a microscope to remove these discs. This again is a video. And similarly, apart from the regular discectomies, minimal invasive surgery is nowadays used for fixation, stabilization procedure. You don't need to open big, see the pedicles, put screws. You can put in screws through small openings. This is again a case. She was a female, 51-year-old, having severe low backache and pain in her limbs, claudication pain. And the MRI, as you can see, there is this listhesis at L4-5 and canal stenosis. The facets are hypertrophied. So these are the cases which can beautifully be handled nowadays by MIS TLIF. TLIF is a procedure where there is transforaminal lumbar interbody fusion is done. And this can be done through small holes using this procedure. You can see we have to just use these guide wires where you can put in screws, and the particular screws are positioned, and then you can remove the disc and put in the cage to fuse the spine. This is the intra-op image, how it looks. The cage is inside, the particular screws are in position. So it's again is a very, very fantastic procedure. There is no pain. The patient starts walking 3 hours post-surgery and can be discharged in 24 to 48 hours. And as I conclude, as in all the other surgical branches, minimal invasive neurosurgery also has similar concepts of it gives less trauma to the structures, better tolerated, although it has a learning curve, but yes, this is how we all learn, and this is what is best for our patient. We should learn and give it to them. And it has to be optimally tailored. It doesn't mean that I have an endoscope, so I use it in all the cases. No, I have to tailor it. I have to optimally use my instruments to give the best outcome. And yes, future is still more to offer. There are amazing things going on in our subject, robotic surgery coming in, navigation, so many things, and future is really here for us. And as this slide says, a hospital bed is a park taxi with a meter running. And we being in a corporate hospital, we know how important it is to discharge the patient as early as possible with best outcome. Thank you so much, everybody, for patient listening. Thank you.
Hello. Thank you, Dr. Jaiswal, for your nice, excellent presentation. The latest technology in minimal invasive neurosurgery and all endoscopy procedure. So now, any questions from audience, we can ask.
Yes, we regularly do, but it depends, how the mantle is. If the mantle is very thin, we avoid endoscopic third because there is post-op chances of leaks and all is high. Those are the cases where we use shunts. It's not that shunt is out or abolished. It is, this procedure is hand in glove with the conventional shunt procedure.
That's great because shunt block is a havoc for.
Is an havoc. And shunt-related complications are very difficult to manage. Thank you.
Thank you so much, sir. I may now request Dr. Manoj Kumar Pradhan, Additional CMO RSP, to present token of appreciation to Dr. Amit Jaiswal. I may now request Dr. Manoj Kumar Deo, Senior Consultant RSP, to kindly present a token of gratitude to Dr. Manoj Kumar Pradhan, Additional CMO RSP. I may now request Dr. Manoj Kumar Pradhan, Additional CMO RSP, to present token of appreciation to Dr. Manoj Kumar Deo, Senior Consultant RSP. Thank you so much, everyone. I request Dr. Poonam to conduct the further sessions. Good afternoon. The poster session is going on in the parallel session in Hall 2. So now we'll have a short break and then we'll start the second symposium after a few minutes. Please kindly wait.
Hello. The speakers for the symposium, are they present in the hall right now? Dr. Sukhdev Shankar? Okay. And Dr. S. Rajshekhar? Dr. S. Rajshekhar? Not there. Dr. Prabhadeep Kaur? Okay. Okay, ma'am. And Dr. Rohit Chakravarti? Yes, ma'am. Only Dr. S. Rajshekhar is not that present, no? Okay. We'll wait for some few minutes before we start the symposium.
हम कॉल करते हैं सर, एक मिनट कंफर्म करेंगे.
That intentions to unite healthcare professionals.
and driven by innovation, the conference reflects our shared thank you for patiently waiting. And I welcome everyone for this symposium on the topic fatty liver disease, an emerging threat. Now I invite our eminent chairpersons, Dr. Rabindranath M., ED, MNHS, DSP Bhulai, and Dr. Manoranjan Samantramantray, Deputy CMO, RSP Raukala, to kindly chair the session and grace the dais. Time duration is 60 minutes, 8 minutes for each speaker, out of which after 7 minutes, 1 buzzer, then after again 1 minute, 1 buzzer to mark to end the presentation, and 2 minutes for discussion. Now I request all the speakers to kindly grace the dais. First, I invite Dr. Sukhdev Shankar Patil, DSP Durgapur, Dr. S. Rajshekhar, PSP Vishakhapatnam, Dr. Prahadeep Kaur, DSP Bhulai, and Dr. Rohit Chakravarti, Tata Steel Plant. Dr. Rohit Chakravarti, Tata Steel Plant. He was there, I think, when I asked previously. Yeah, please come to the dais. Okay. Sir, kindly come to the dais, sir. So you're calling him? Okay, sure. Okay. Then first, I may now request Dr. S.S. Patil, sir, the DSP Durgapur, to present on physician's overview.
Hello, what is the protocol? All speak, then you go in for discussion, or each speaker will go in for discussion? Then it will be taken up for discussion.
Good evening, respected chairperson and my dear delegates. Today I am going to scare you people with fatty liver disease because all you people are having, I think, grade 1 or grade 2 fatty liver disease. I am Dr. S.S. Patil from Durgapur Steel Plant Hospital. So by definition, fatty liver disease is the excessive accumulation of triglyceride in the liver cells. By classification, fatty liver disease was earlier classified into non-alcoholic liver disease and alcoholic liver disease. In 2023, a new nomenclature was chosen and fatty liver disease was classified as metabolic dysfunction associated liver disease, then metabolic and alcohol associated liver disease, alcohol associated liver disease, and others. So global burden of non-alcoholic fatty liver disease is very high. It is estimated to be as high as 1 billion. It affects 30% people in Western countries and 10% people in Asia. These are the prevalence projection of different countries. US is having highest prevalence of NFLDs. In USA itself, NFLD is estimated to affect between 80 to 100 million individuals. And rate is around 35%. In that, 7% is having severe form of NASH. It affects 10% children in United States. FLD is more prevalent in Hispanic people than white, and last is the black people. FLT is observed in 80% of obese people and 20% in normal weight people, despite of no history of alcohol consumption. 35% of obese FLT progress to NASH. COVID affected those fatty liver disease also. After the lockdown COVID-19 pandemic, 48% of patients with FLT gained weight, while 16% has worsened steatotic grade. And weight gain was associated with poor adherence to the suggested diet and reduced physical activity during COVID-19. The presence of type 2 diabetes is associated with higher likelihood of progression of NFLD to fibrosis, liver transplant, and death. Cardiovascular disease is the main cause of mortality among people with NFLD and type 2 diabetes. These are the global NFLD prevalence in type 2 diabetes. Europe is having highest prevalence, followed by West Asia, East Asia, and then our country, India, South Asia. At any given point of time, NASH is present in about 25% of NFLD patients. 10% people with cirrhotic alcoholic liver disease develop hepatocellular carcinoma. NFLD-related cirrhosis develop, the annual incidence of primary liver cancer is as high as 3%. Alcoholic fatty liver disease develop in those who consume more than 60 grams of alcohol daily for men and 20 grams daily for women. And more than 90% of all heavy drinkers develop fatty liver. Alcoholic liver disease was the third leading cause of death in 2003 in United States. Worldwide mortality is estimated to be around 150,000 per year. International body already realized this threat and they have started celebrating Global Fatty Liver Days on every 13 June to enhance awareness and emphasize the pressing nature of fatty liver disease. The highlight of 2024 Global Fatty Liver Days was FLD is more advanced form. FLD and its more advanced form remain a concealed global epidemic. 357 million people will be affected by 2030. And FLD is a major risk factor for conditions like obesity, diabetes mellitus, and hyperlipidemia. India is not behind with this awareness program, and in January 2021, Ministry of Health and Family Welfare, India included NFLD in National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke. In September 2024, Union Health Ministry released revised operational guidelines and training manual for NFLD. And they declare NFLD is rapidly emerging as a major public health concern closely linked with metabolic disorder such as obesity, diabetes, and cardiovascular disease. Union Health Secretary declared NFLD is a major non-communicable disease. NFLD prevalence is in India surpassed global prevalence and it is around 38.6%. The prevalence of adult NFLD in India is between 6.7 to 55.1%. And prevalence is high among diabetes, overweight patient, and metabolic syndrome patient. And it is 3 to 10% in normal weight children and 10 to 60% in overweight children. A recent study conducted by AIMS New Delhi in June 2024 declared that 38% of Indian population is afflicted with NFLD and nearly 35% FLD children have MSLD. Economic burden of NFLD is enormous. Direct medical cost is around 103 billion per year dollar in the United States and 35 billion euro in European country per year. And it is predicted to increase tenfold by the year of 2025. Diagnosis challenges are also there with fatty liver disease. Development of alcoholic associated steatohepatitis, steatosis, cirrhosis is most often clinically silent. Symptoms arise only when patient decompensate or develop alcoholic hepatitis. Simple hepatic steatosis can present with normal LFT. Abdominal imaging is not able to determine which individual with NFLD have associated NASH, and specific blood tests to diagnose NASH are not yet available. Lifestyle modification is a key approach to NFLD management. Even with 10% weight loss, they can 48% Patient shows fibrosis regression and NES resolution in 64 to 95% patient. Decreasing caloric intake by at least 30% or by approximately 750 to 100 kilocalories per day result in improvement of fatty liver. The best modality of exercise is 150 to 40 minutes moderate intensity aerobic training or resistance training per week. Treatment challenges are there. Unfortunately, most FLD patients cannot sustain long-term compliance with diet and lifestyle modification and thus fail to maintain a healthier weight. All drugs which are used for this NFLD are having off-label indications. Means they cannot be used primarily for the fatty liver disease, including metformin, vitamin E, pioglitazone, or also deoxyribonucleic acid. Vitamin E in 400 to 800 milligram dose is considered first-line pharmacotherapy for non-diabetic, non-cirrhotic, and NASH patient. But recent population-based study shows it may increase the risk of CV mortality, hemorrhagic stroke, and CA prostate. Pioglitazone may be safer than rosiglitazone, but it may again cause weight gain, increased risk of bladder cancer and bone fracture in women. Also, deoxyribonucleics offer no histological benefit over placebo in patients with NASH. Experimental evidence support that use of omega-3 fatty acid in FLD, but controlled study failed to demonstrate a histological benefit. It is same with this GLP-1 SGLT2 inhibitor also. These are some promising agents, but sufficient data do not yet exist to justify their use as a NASH treatment in clinical practice. Thank you very much.
Thank you, Dr. Shukdev Shankar Patil, for your lucid presentation. We will discuss the topic later and we can call the next speaker.
Thank you, sir. Thank you.
I will now request Dr. S. Rajshekhar, VSL Visakhapatnam, to present on the pediatric aspect.
Jai Jagannath. Good afternoon, everybody. Respected chairpersons, dignitaries, delegates, my seniors, juniors, and friends. Today I am going to talk about the pediatric aspect. Dr. Patil has made my topic a little easier. So I am Dr. Rajshekhar from RNL. So what I'm going to cover in the next 8 minutes. These are the topics. So why it is important, why it is a growing problem? I think in the morning itself, the morning session, Dr. Roy has, the gastrosurgeon has clearly elaborated the importance of FLD or the non-alcoholic FLD in children, why it is such a big threat in the coming days. See just now Dr. Patil has also said, what is the prevalence? In and around the world, it is 35.4, and just see that in India, it is almost similar. It is 35.4%. The chance of obesity, if one parent is obese, is 40%, and if both the parents are obese, it is around 80%. Both low birth weights and the large birth weights are also risk factors for the future obesity. This is particularly high among the obese and the overweight children. You can see the percentage as compared to the normal children. The prevalence is similar in both boys and girls. And the metabolic syndrome, that is, it includes all obesities because of hyperglycemia, the type 2 diabetes, the hyperlipidemia, all these diseases are interrelated and interlinked. And you see that the UNICEF World Obesity has said that by 2030, what will be the ratio? 1 in every 10 children from India will be obese, and the prevalence may be around See the age group between 5 to 9, it will be around 11%, and between 10 to 9 years, it will be around 6 to 7%. It is a tickling time bomb. If we don't intervene, then half of the world will be overweight by 2035, as suggested by World Obesity Atlas in 2023. And the children below the 5 years of age, by WHO 2021, they said that already there are 39 million children are overweight and obese. And India will become the next capital after this diabetes. It will be the #1 capital in overweight and obesity at a rocket speed. Earlier it was thought it is a problem of developed and higher income countries, but now it is also seen in poor socioeconomic, rural and developing countries. So what is this steatosis, or what is this accumulation of fat? As Dr. Roy also pointed out in the morning session, it is because of only sugar, excess of sugar. And this leads to excess of fat in the liver. And it is not that it is same as in adults. The disease, the non-alcoholic is, that fatty liver disease manifests in adults, but it starts in the childhood itself. All the metabolic derangements typical of this occurs particularly during the period of active growth. That is particularly during the period of infancy, the mid-childhood and the puberty. So we can reduce this prevalence if we see that if by restricting the sugar in the first 1,000 days of life, that is from conception to 2 years of life, will reduce the risk of diabetes and hypertension by 35 to 20%. And it also delays the onset of all these metabolic diseases. The National Institute of Nutrition and ICMR and WHO have said that presently in India, between the age of 5 to 90 years, the pre-diabetics are around 10%. And the most, what I feel is the culprit, it starts in the cradle itself when we start introducing this artificial milk substitutes. The types of fatty liver disease, see the most common in adults, it was alcohol because they thought, but the non-alcoholic has become more and more prominent and it has become dominant and is the most common type in children. It is all because of insulin resistance. And there are certain other diseases, maybe because of some hypothalamic or because of some genetic disease also. So the spectrum, it starts with simple steatosis, means only accumulation of fat. Then gradually there is an inflammation that is called a steatohepatitis, that is a NASH, or the MASH, now what we said. And then this NASH will further lead to fibrosis, and then fibrosis leads to cirrhosis, and the cirrhosis can also lead to the hepatocellular carcinoma. So the first stage is because of insulin resistance, because of hyperinsulinemia. And then the multiple it's because of oxidative stress, because of other genetic susceptibility, regeneration, lipid peroxidation, all leads to cirrhosis. So the causes and the risk factors is because of poor diet, because of excess of visceral fat, the poor sedentary lifestyle, the genetics, and the associated conditions like the type 2 diabetes, insulin resistance, hypertension, hyperlipidemia, all. The symptoms, most often we don't see any symptoms, but by the time I think it presents with symptoms, it is already in the stage of NASH. So the early biomarkers we don't have, but the early markers I would say is the anthropometric measurements. So we should do every 6 months the height, weight, the BMI, and presently we do the waist circumference, the waist is to hip circumference, and there are some other also like the body composition analysis and the BRI, the body roundness index. So in children we have this red flag signs like the acanthosis nigrans, obstructive sleep apnea, and all these parameters, the anthropometric. So by this we can know that growth charts will help us to know whether it is a pathologic or is it a physiological. Usually the child will be normal or tall for his age, whereas in a pathological, usually the child tends to be short. So the IAP of the Indian Academy of Pediatrics have given different charts for weights, for the waist circumference, for the height, for the they are also given the percentile by which we can know what is the risk factor and what are the, so more than 70th% is the risk factor, whereas 90th percentile is the metabolic complications. In adults, we see the waist circumference by the height circumference more than 1, we say that there is a increased risk. But in children, we take the waist circumference is to height. More than 0.5 definitely is a marker for central obesity. Then we do the routine blood test, the CBCs, and then the liver function test, as morning already has told, the ratios, particularly the EST to L ratio, if it is more than 1, definitely it is going into the steatohepatitis. That is the NASH. And then we see the sugar levels and the insulin levels. The insulin levels nowadays can be measured and can know the type of and the degree of resistance by HOMA-IR. The lipid profile. And there are 2 hormones that presently what we do is the adiponectin and the leptin. These are very interrelated. They both are hormones from the fat cells and they are inversely related. And if it is associated with some autoimmune disease, then we can get the autoantibodies. Just to highlight this HOMA-IR, this is a homeostatic model assessment of insulin resistance. If it is more than 2.9, then we say there is insulin resistance. As the risk increases, the number also increases. And it can easily be measured by fasting insulin instead of fasting glucose by 405. The adiponectin and the leptin, as I said, the leptin levels also gradually increase, and this causes the leptin resistance similar to insulin resistance. Whereas the adiponectin levels, gradually they fall down, and once the risk is more, one is less than this. So then we do the different type of imaging. I think it will be covered in the next chapter. So what is important in child, let me tell you. So the FibroScan is the best method. It is a very safe, it is a non-invasive ultrasound which measures the liver stiffness and the fat content. And you can know the stiffness by just doing with the probe. The higher the KPA, that is the kilopascals, the greater is the stiffness. So there is a lot of difference. Unlike in insulin, what we say in diabetes, we say type 1 NASH and the type 2. Type 2 we say in children. We see it is predominantly a periportal of the zone 1 fibrosis. It is mainly mononuclear lymphocytes. Mainly it is a portal inflammation. The ballooning is less and the progression is always slow, and it is always linked to some or other genetic predisposition, and the best diagnostic is by the FibroScan or the MRE, that is a magnetic resonance elastography. See the liver difference, the periportals and the perivenular in case of adults. So these are the complications which are reversible or not reversible. So the most important is the preventive aspect. As we all know that lifestyle changes, the healthy diet, the reducing the sugar and the fat, the medical management has very little role, and the most important but not the least is the monitoring and follow-up. So let us follow this traffic light diet plan. The stop eating the fatty meals, the sweetened beverages, the fried foods. Think before you eat, these are the products, and go on eating the fruits and vegetables, the different colors, the different types of fruit. And
thank you, Dr.
The IRP has given this 5210, that is the 5210 rule. So avoid junks to avoid obesity, the CCBs, the SSBs, the HS, all these ultra processed. These are the, by this we can know what type of food. These are the guidelines. Hardly they have any benefit. What already has been said. The most important is the preventive aspect. We can do the screening by liver ultrasound and the newer therapies. So to conclude, early intervention is very, very crucial. The parents, the doctors and the pediatrician, particularly the mother, I would say, has a very big role. The parent should become the role model for the children. We should have awareness both in the school level and at the community level, and the early educators, particularly the teachers. And the government should have a very good policy decisions also, but recently our Prime Minister has requested to cut 10% of oil in our consumption in our day-to-day life for a fit India movement. So healthy children, then we'll have a healthy country.
Thank you, Dr. Rajshekar. You gave a very elaborate pediatrician's view on this topic. You have covered, shown it how it is a ticking time bomb, and we'll go to the next speaker. I think it is Dr. Prabdeep Kaur. She will be giving a gynecological perspective of this disease.
Good evening, respected chairpersons, dignitaries, seniors, and colleagues. A warm greetings from Bhilai Steel Plant. My topic for symposium is fatty liver, a gynecological perspective, and I'll be covering this topic under the following headings. Globally, the prevalence of NFLD is 30%, as we already, the previous speakers has told. It is projected to rise to 56%, paralleling to the increasing incidence of obesity and type 2 diabetes. The prevalence is more in men as compared to premenopausal women. However, as the menopause is approached, the rising trend is found, and it is more in more than 50 years, and which peaks at 60 to 69 years, and later it decreases at more than 70 years. Women aged more than 50 years with NFLD are 1.2 times more likely to develop NASH compared to age-matched men, and are more likely to progress to advanced fibrosis. There are studies in India that say that prevalence of NAFLD is same in male and females in India, and overall pool prevalence being 38.6%. The contributing factors in females for NAFLD is the age of menarche, reproductive hormones, body fat distribution, Turner syndrome if it presents, and sarcopenia. The specific causes being metabolic syndrome, polycystic ovarian syndrome, menopause, and acute fatty liver of pregnancy. Menarchal age is found to be very much associated with NAFLD, and early the menarche, that is age less than 12 years, more the risk of cardiometabolic disease in postmenopausal women. In the cardiac study, early menarche by 1 year conferred a 10% increased risk of NAFLD in adulthood, independent of socioeconomic factors and baseline BMI. Early menarche is preceded by rapid accumulation of fat during childhood, a physically less active lifestyle, and or behavioral factors that increases the risk of metabolic syndrome. Factors such as obesity, insulin resistance, or a hyperandrogenic phenotype may interact with early menarche to confer an added risk of developing NAFLD. Sex hormones are very much associated with NAFLD in a way that estrogen has a protective role against hepatic fat accumulation. It increases lipolysis, decreases lipogenesis, increases the acetyl-CoA carboxylase, and improves the mitochondrial function, while its deficiency causes the opposite. Increased androgens in women is deleterious, but decreased androgen in men results in NAFLD. Now, metabolic syndrome is composed of 3 or more of the following, that is low HDL cholesterol, high fasting blood sugar, large waist circumference, high triglycerides, and high blood pressure. Different health authorities used slightly different criteria for diagnosis, but most of the definitions are very close to each other. And what this metabolic syndrome do is that when it is associated with intestinal dysbiosis, which results in increased inflammatory factors, and obesity results in decreased adiponectin, increased leptin, increased free fatty acids, increased inflammation. All this results in insulin resistance, and ultimately this results in increased gluconeogenesis, increased de novo lipogenesis, and decreased free fatty acid beta oxidations. This results in NAFLD, and NAFLD in turn results in development of type 2 diabetes, and a vicious cycle is formed. The treatment for metabolic syndrome aims at the reduction of the weight to 7 to 15%, which helps in reduction of the fibrosis in the liver and reverses the NAFLD. Also, it is aimed to control the blood sugar, the blood pressure, and the LDL and HDL cholesterol. The next in line is the PCOS, that is polycystic ovarian syndrome, which affects 1 in 10 women and has a prevalence rate of 10 to 15%, with common signs and symptoms of excess facial and body hair, severe acne, anxiety, depression, weight gain, etc. The 4 links between PCOS and fatty liver is the insulin resistance, higher weight, poor gut health, and high male hormones. All this, that is insulin resistance, hyperandrogenemia, the genetic predisposition, altered microbiome, all this results in increased free fatty acid, decreased adiponectin, and increased de novo lipogenesis and fatty acid deposition into the liver. The physical activity, behavioral therapy, surgical procedures, dietary interventions, all these goal to be achieved, all these are results in decrease in oxidative stress, pro-inflammatory state, and decrease the pro-lipogenic state in the liver, and the goal of reversal of fibrosis and NAFLD is achieved by this. The next culprit is the menopause, which is associated with the estrogen deficiency, and this estrogen deficiency causes decreased antioxidant effect, decreased hepatic export of the VLDL from liver, increased ectopic fat accumulation, increased visceral fat accumulation, increased hepatic stellate cell activation, decreased choline biosynthesis, and ultimately what results is the NAFLD. Also, the relative hyperandrogenemia, which is present in menopause, results in increased visceral adiposity and increased insulin resistance, resulting in NAFLD. What is required is lifestyle modification, which is the initial step, and management is focused on optimizing the associated comorbidities. Not only the gynecological conditions are associated with fatty liver and NAFLD, NAFLD also affects the pregnancy, and the maternal risks associated are hyperglycemia, GDM, type 2 diabetes, PIH, preeclampsia, etc. The perinatal risks being preterm birth, large for gestational age, small for gestational age, neonatal morbidity, and mortality. Not only the newborn, but later on the child is affected with obesity, type 2 diabetes, cardiovascular disease, MAFLD, and chronic kidney disease. The other fatty liver condition which is associated with pregnancy is the acute fatty liver of pregnancy, which is rare and found in 1 in 7,000 to 1 in 20,000 pregnancies. It is potentially lethal for both mother and fetus, especially if diagnosis is delayed. It is common in primigravida, and an association with male fetus and multiple pregnancy is found. Maternal mortality being 10 to 20% and perinatal mortality being 20 to 30%. Swansea criteria is used for diagnosis of AFLP, which includes various sign symptoms, some lab features, and imaging and pathology. The pathogenesis of AFLP is unclear, but the defect in fatty acid metabolism during pregnancy appears to play a role, particularly late in gestation. Fetal long-chain 3-hydroxyacyl-CoA dehydrogenase deficiency contributes to long-chain metabolite accumulating in the maternal blood and hepatocytes, resulting in toxic effects. So, expeditious delivery improves the prognosis for mother and baby. Multidisciplinary team in an intensive care setting is required, and coagulopathy and hypoglycemia has to be taken care of. Rare but potentially fatal, the diagnosis should be considered and liver function measured, especially if there is vomiting and abdominal pain in pregnancy. Differential diagnoses include HELP syndrome, and liver dysfunction is usually marked with hypoglycemia, hyperuricemia, renal impairment, and coagulopathy. So at last, to summarize, NAFLD is a rising concern among women. Awareness among general population and healthcare workers is required. It requires appropriate screening, tailored management strategies, and lifestyle management being the key. Thank you.
Hello. Thank you, madam. Thank you. You have given a very good perspective. You said it is menopausal, postmenopausal women, early menarche, PCOS, acute fatty liver. Thank you so much. We'll go to the next speaker.
Hello. Good evening, my respected seniors. Good evening, my respected seniors and my dear friends. We'll be discussing about the fatty liver disease, its radiopathological aspects. What is the fatty liver disease? It is a benign condition. In it, there is accumulation of triglycerides within the hepatocytes. It is a major global epidemic, and the prevalence ranges from 9 to 53%. This is a schematic diagram showing a healthy liver converting into NAFLD due to various pathologies like increased lipolysis, increased free fatty acid, increased insulin resistance, adipocyte dysfunction, genetic factors, high calorie diet. Further, NAFLD gets converted into NASH due to increased fatty acid oxidation, oxidative stress, Kupffer cell activation, producing cytokines, and stellate cell causing fibrogenesis, genetic factors. So fatty liver disease is actually a spectrum in which there is steatosis, steatohepatitis. Both of these are reversible, but once cirrhosis steps in, it is irreversible. Histopathologically, there is fat vacuole formation within the hepatocytes with inflammation. Further, in later stages, which forms regenerative nodules with perisinusoidal fibrosis. And this is a 3D reconstructive image of the liver showing a nodular surface due to end-stage liver disease. So liver biopsy is the gold standard, but it has its own limitations because it is an invasive procedure, so it may cause, it may not be acceptable for all. And secondly, we take multiple cores, so you can actually miss the places where there is areas of fat sparing. So here comes the role of imaging. So in imaging, we look for three things. We detect fat in liver, we quantify fat in liver, and we detect early fibrosis. There are four modalities: ultrasound, CT, MR, and elastography. So we'll see them one by one. Ultrasound, it is the initial imaging modality for screening, and it is widely available, cheap, radiation-free, and portable. It has three grades, grade 1, 2, and 3. In grade 1, there is the echogenicity of the liver is increased in comparison to the kidney. In grade 2, it is increased to the extent that the periportal echogenicity is lost. And in grade 3, even the posterior right lobe and the diaphragm is not visible. The study conducted in the University of Cairo showed that abdominal ultrasonography has a high negative predictive value in excluding NAFLD with an accuracy of more than 80%. So conventional ultrasound is useful for qualitative assessment and excellent for screening. But it has its own pitfalls, like being subjective investigation. It is prone for inter-observer variability as well as inter-machine variability also. So assessment of liver ecotexture is also difficult in morbidly obese patients. So to overcome these pitfalls, we have to step into the next higher investigation, that is CT scan. In CT scan, we look for the attenuation of the liver. The normal liver attenuation is 50 to 65 HU, Hounsfield units. But in steatosis, the attenuation decreases. It is approximately 40 HU or even less. And other findings in CT are there is generalized enlargement of the hepatic parenchyma. There is caudate lobe enlargement, as well as there is left lateral segment of the liver also gets enlarged. These are the CT images of fatty liver. You can see in the first image that there is the liver is hypodense in comparison to the spleen. And in the next image, you can see the left lateral segment of the liver is increased in size. And in the third image, you can see that the right lobe of liver is increased, the craniocaudal dimension is increased. And in the fourth image, it is the 3D reconstruction showing multi-lobated appearance due to enlargement in various directions. So next question is, can CT quantify fat in liver? Yes, to some extent. Semi-quantitative assessment is possible with liver attenuation index, in which multiple measurements are taken from liver and spleen and the ratio is taken. If the ratio is less than 0.8, it is highly specific for fatty liver, that is more than 30%. And another index is hepatosplenic attenuation difference index. It is the difference in the attenuation of the liver and the spleen, and if it is less than 10 minus 10 HU, then it indicates severe fat content, that is more than 30%. But again, CT has got its own confounding factors like intrahepatic iron deposition, glycogen deposition, hepatitis. So all these things may differ our result. So we have to correct these confounding factors. So we now need a better investigation, which is a molecular level imaging, which is a magnetic resonance imaging, MRI. MRI can detect fatty liver more accurately and quantifies fat precisely. Earlier, ultrasound and CT were able to see that there is fat in there, but it was unable to say how much fat is there. But MRI can actually precisely say what is the exact amount of fat, and it is mainly used for post-treatment follow-up of the patients. In which in MRI we use three techniques: fat suppression technique, chemical shift imaging, and MR spectroscopy, out of which chemical shift imaging and MR spectroscopy are the best because they produce proton density fat fraction MR images, which is now considered to be, in recent literature, it is considered to be the surrogate marker for fatty liver. These are the images of chemical shift imaging of the liver. In the first, this is the in-phase image, and the second is the out-phase image. You can see the out-phase image shows the hypointensity of the liver parenchyma. Why? Because the liver and in the liver, the fat and water molecules are out of phase with each other. They are resonating in different phases, and hence they cancel each other's intensity. This is the MR spectroscopic image of normal liver, in which you can see that there is a huge water peak and a small fat peak. Now, this small fat peak is due to the normal liver. When in fatty liver, the amount of fat increases, the fat peak will also increase. And this is the MR spectroscopic protein density fat fraction image, in which you can see that there is 22% fat is there in this apparently normal liver. So MR spectroscopy is the best in detecting the exact amount of fat, and it is especially useful for post-treatment follow-up. So the next question is how to detect early fibrosis. Yes, we can detect early fibrosis with elastography, where there are two methods: ultrasound elastography and MR elastography. Under ultrasound elastography, we have the voluntary controlled transient elastography, VCTE, and the shear wave elastography. In shear wave elastography, we use ultrasound only, and we take multiple small samples from the whole of the liver parenchyma, and we get the final average, which we can compare with the standardized tables available. Similarly, MR elastography acquisition also can be done, in which there are wave images. The first image is the normal liver showing thin waves, and the second image shows thick waves. This thick wave image is seen in liver stiffness. So this is another case of liver cirrhosis, in which the third image shows the hepatic parenchyma, which is stiffened. The red areas are actually the most stiff part, and multiple samples can be taken from there, which we can again compare with the available standardized format for standardized tables. But there are pitfalls in liver stiffness measurement also, like acute inflammation, extrahepatic cholestasis, hepatic congestion, infiltrative processes. All these may cause, may mimic fibrosis. So ultimately, the clinical and biochemical correlation with imaging should always be done, and it is the key. So to conclude, fatty liver is essentially a benign condition, but it may lead to NASH and cirrhosis. However, early stages of fibrosis in the liver is reversible, and imaging of liver with various modalities correlates precisely with the pathological stage of the disease. Hence, early management and post-treatment follow-up of fatty liver disease spectrum is possible with imaging, and liver biopsy can be avoided in many of the cases, if not all. Thank you.
Thank you, Dr. Ridesh. Well spoken. You have given a very good perspective, radiological insights into the diagnosis of fatty liver. And all the four speakers were very knowledgeable, and you have given a very good ideas about the disease. Before opening up, I will start the discussion points. Dr. Patil, you have said that it is going to be a major public health problem and economic burden. Should the steel industry doctors be worried about it?
Yes, sir, it is going to be very much economic burden on public and even on, means it is going to be challenge for the doctors also. So because grade 1 and grade 2, I think everybody is having grade 1, grade 2 liver, means fatty liver disease. And second thing means our lifestyle and diet pattern is very much favorable to this fatty liver disease. So we have to restrict all these things, and definitely we can improve it. Morning itself, Dr. Somen Roy have told that diet and diet restriction and physical activity is very much helpful. Other measures are not very much helpful, sir.
How do you think it will be an economic burden for our organization?
Sir, economic burden for our country. Oh, that I am not to, sir, for our organization. Definitely, sir, it will going to increase. Like if patient is consuming alcohol every 3 months, later he will ask for the 5. Sir, you do my.
Will it be an economic burden for our organization?
So may I answer?
Liver transplantation is a methodology of treatment?
See, her liver transplant is in very late stage, sir. And yeah, liver transplant is very costly, so it may increase their economic burden. But sir, even we have seen in clinical practice, if patient is having even grade 1 fatty liver disease, every 3 months he will ask for, sir, please repeat my ultrasonography. And we have to give this ursodeoxylic acid, which is not helpful at all.
Any question to Dr. Rajshekhar from audience? Any question to the Dr. Rajshekhar? Pediatrician's perspective. Dr. Rajshekhar, when you go back and when we go back, what should we do to promote this, create awareness among children? How do you think we should go about? You have given some ideas, but how do you, 1 or 2 ideas which you think all of us should do, go back and start this as a drive?
The first is, I think, the education, sir. It starts with the mother. I think, see, a seed, how we sow a seed, how we rear a plant, a seedling, to become a flowering plant or a flowering plant bearing a fruit. So it has to be, you have to prepare the soil, then you have to prepare the seedling, then the ingredients, and then we can prevent the disease progression. That is what I want to say. So if we prepare the mother, even before pre-conception itself, during the conception, and as I said, the first 1000 days of life, that is because maximum growth occurs during that phase. It starts with that, sir. Because the disease manifests in the adult, we thought that this fatty liver disease is always in the adult. And all these things, the metabolic syndrome, what we are saying, it is all these things are interrelated, they are interlinked.
So school education and all you should.
School education, that is what, the early educators, the teachers.
Madam, 2-3 tips to the gynecologist, 1, 2, 3 regarding fatty. What do you think in a practice session, the gynecologist should remember when they read the word practice? I think Dr. Prabdeep should answer. What should a gynecologist do when she detect, especially PCOS are common problems now, and you have this pregnancy related issues, you have some amount of fatty liver there also. Apart from all these things, what do you propose that the gynecologists should do or educate?
So basically, weight management is an issue that has to be started from adolescent time. And PCOS can be taken care of in adolescent, but not only the weight management helps in reducing for that, but later in the reproductive life, these things will also help in reducing the NFLD and other things. So weight management, lifestyle intervention, that has to be educated. The patients has to be educated for that. And the thing is ki if they are educated regarding that, they will take care of their kids for the same. Because if they will eat healthy, they will make it sure that the child also, it's not like making them eating anything they like. They will make sure that the child also takes the healthy things.
Finally, Dr. Ridesh, when do you think biopsy should be as an intervention? Radiology part is okay, but when should you think biopsy should be intervened? For what stage you think will you consider biopsy?
So biopsy should be considered, especially where there is dilemma in ultrasound, CT and MRI. We are unable to actually see in MRI also. Like MRI is now considered to be the surrogate now. In recent literature also, that MR elastography is now the surrogate for fibrosis. But in some cases, it may not be suitable. So in that case, we ultimately have to go for biopsy only, sir.
So biopsy part, I think in children we hardly do, because what we say is biopsy is only done to know the type of staging and only in the later and the severe cases. That's why we always do a non-invasive investigation, that is the fibroscan or the MRE. Ultrasound is very cheap, it is very easy, and it is easily accessible also in staging and everything. That is what I want to say.
Any advice to surgeons with respect to fatty liver? It will complicate any surgery or anesthesia or something like that? Do you think so?
Regarding surgery, sir.
Are you afraid that our surgeons will send for fitness to you?
First, we have surgeons should go for the ultrasonography, either fatty liver disease there, liver function test they should do, and if liver functions are very higher side, then they have to wait for some days to get the liver function that come means SGPT, SGOT comes down, then they can operate for this. Then they can go for the surgery. Okay. In acute stage, they have to avoid this any type of surgery if liver function test is deranged.
Someone has to say a few things.
No, regarding, sir, your question regarding the anesthesia fitness. So we can anesthetize also cirrhotic patients. It's not like that. But thing is that we take care to prevent not to use few drugs. We modify our anesthesia regimen in these cases. But it's not a contraindication or a matter of concern for anesthetists, that much.
Before we conclude this session.
As with more prompt detection and early detection rather, we have more number of cases with NFLD. So what should be the treatment protocol? How frequently those adolescents require to get follow-up, or what drugs do we have? When do we intervene for the therapeutics as per?
For me, madam?
Yes.
It is a stage of the NAFLD. In the beginning, what we said is the steatosis or the steatohepatitis up to NASH. It is highly preventable, it is easily preventable. So that is what we hardly do any intervention there. There is no need.
Are there any therapeutics available?
Hello. So once we diagnose that there is an insulin resistance or there is a hyperglycemia, then we can think about metformin. That is the first drug we can start in an overweight. And we have to control the sugar levels and the other parts. And other antioxidants we can give, but not any other drug.
So I think our panelists have given, symposium panelists have given food for thought. Everybody should be motivated by their presentation, should go back and work on fatty liver. All of us, each of our profession has to contribute to drive a fatty liver. If you control fatty liver, I think we can modify lot of, so it's a very thought-provoking topic taken up by the organizers. I congratulate them. and we will conclude this session. Thank you very much.
Thank you.
I will now request Dr. Ravindranath M., ED, MNHS, BSP Bhilai, to present a token of appreciation to Dr. Sukhdev Shankar Patil, DSP Durgapur, and Dr. Prabhadeep Kaur, BSP Bhilai. I will now request Dr. Manranjan Samantray, Deputy CMO, RSP Rourkela, to present a token of gratitude to Dr. Rohit Chakravarti, Tata Steel Plant, and Dr. Raj Shekhar, VSP, Visakhapatnam. Sir. All the speakers kindly stay on the dais. I will now request Dr. Manranjan Samantray, sir, to kindly present a token of gratitude to Dr. Ravindranath M., ED, MNHS, BSP Bhilai. And I now request Dr. Ravindranath M., ED, MNHS, to present a token of appreciation to Dr. Manranjan Samantray, RSP Rourkela. Thank you, sir and ma'am. There's a small announcement. Tomorrow, I request the delegates, the guests, and all the doctors to assemble at the lawn of Mayfair Worker Village Chain at sharp 6:45 a.m. for a new event introduced into this AISMOC, that is the walkathon with the slogan, "Say No to Plastics." From Mayfair Village, we'll visit the Birsa Munda Hockey Stadium, where we'll get the opportunity to have a look and enjoy the stadium. Please ensure that you're wearing walking shoes for the event. Thank you. Now I'll hand over the mic to Dr. Mona to conduct the next session.
We move on to our last session of this program today. In this guest lecture, our time duration is 30 minutes, 25 minutes for presentation, out of which after 20 minutes, one buzzer, then after again 5 minutes, one buzzer to mark the end of the presentation. 5 minutes for the interactive discussion. I may now request Dr. K.L. Himram, Additional CMO, RSP Rourkela, and Dr. S.N. Suresha, Chief Consultant, Tata Steel, to chair the session and to kindly grace the dais. Thank you, sir. I may now request our speaker for today, Dr. Pritish Chandra Patra, Consultant Clinical Hematology and Hemato-Oncology, Apollo Hospitals, Bhubaneswar, to present his topic, Hematological Malignancy, a Physician's Perspective. Dr. Pritish, Consultant Clinical Hematology and Hemato-Oncology, Apollo Hospitals, Bhubaneswar, is a highly accomplished expert in the field of clinical hematology and hemato-oncology. A prolific scholar, he has enriched medical literature over 27 publications in esteemed Indian journals and in renowned international journals, leaving an indelible mark on global hematology research.
Thank you. Thank you for your kind introduction. Respected chairpersons and delegates, in this last session, we will discuss hematological malignancies in a physician's perspective. So before becoming a hematologist, first we have to become a physician. Not only in education, but also in our eyes, we should have a vision of a physician. So during our clinical practice, our basic knowledge comes from the part of hematology in the Harrison's textbook, which is the Gita Bhagavad of medicine, and the practical hands-on experience we get from our ward. If you work properly, we can see a lot of hematological cases and we can study them from our textbook. So when does a physician comes across a case of hematological malignancies? We usually come across them either in our routine OPDs or in case of emergency or critical care setup, and somewhere in palliative care. In the routine OPDs, patients usually come with their general complaints of fever, weakness, anorexia, weight loss, jaundice, bleeding, thrombosis, and swelling, or common symptoms like that. And apart from that, whenever the patients get any abnormalities, either in the CBCs, there is any abnormalities in the hemoglobin, high hemoglobin or low hemoglobin, high WBC or low WBC, similar in platelets, or sometimes with derangement of the LFT and RFT, patient usually come to us, and in that scenario, we usually come across these cases. And in emergency or critical setup or care setup also, patients usually we come across them either in case of sepsis or when they're in septic shock, patients having respiratory failure, uncontrolled GI bleed, in tumor lysis syndrome, superior mediastinal syndrome, CNS salts, and apart from some cases in palliative setup. So in through few real life scenarios, I would like to discuss few cases. In the first case, these are real cases which we came across in our hospitals. In the 2021, a 65-year-old lady without any history of any other comorbidities presented to the physician with anemia, and she required transfusion, multiple transfusions for almost more than 1 year. She didn't have any fever, jaundice, GI bleeding, anorexia, or weight loss. And initially during the presentation on examination, she was having only moderate pallor, no icterus, no lymphadenopathy, or no hepatosplenomegaly. The initial test showed the CBC had only hemoglobin of around 5, and WBC and differential counts were normal, with a platelet count of a bit in the higher range, like around 5 lakhs. And the reticulocyte count was normal, and the red cell indices, that's mean corpuscular volume, was a bit higher, that's 102, apart from a normal MCH, MCHC, and red cell distribution width. The peripherals were also shown that the red cells were having normal to macrocytic, while the differential count were normal, and there was no atypical cells, and platelet count was a bit on the higher side. The other tests like liver function, renal function, functions were essentially normal. The nutritional parameters were tried to rule out, and iron and B12 deficiency was checked out, and it was found that both were having a borderline low values. And in the treatment, she was treated with initially oral replacement of iron and B12, followed by injectable preparations because she didn't respond. And in between, she needed multiple blood transfusion, nearly 1 to 2 units every month. And it continued for almost a year without any signs of improvement, and she continued to require transfusions. And then she visited us. So we again did the basic test starting from the CBC, and the hemoglobin was 8, that is post-transfusion. WBC count was normal, differential count was also normal, platelet count was a bit higher. And similarly, the mean corpuscular volume was also a bit higher, more than 100.
And the peripheral smear on the right panel, you can see that the RBCs were normocytic, normochromic to a bit macrocytic, and there was increased platelet in the peripheral smear. And we again checked the nutritional parameter, that is commonly we check iron and B12, and they were normal this time. So to rule out other possibilities in hematological, primary hematologic disease, we did marrow. In the bone marrow aspiration and biopsy we did, in the below panel, we can see that in the aspiration, it showed presence of abnormal megakaryocytes. Those were atypical and hypolobated. There was hypolobation in the megakaryocytes. And we sent cytogenetics both by conventional method and by FISH method. And on the right side, you can see that there is deletion of the long arm of the 5th chromosome. That is 5q deletion. So it's a case of MDS, that is myelodysplastic syndrome with isolated 5q deletion. And we started treatment with lenalidomide, and today it's more than 4 years and she is free from transfusion. So what are the clues in this case? The common clues we could have checked checking the peripheral smear and the red cell indices. So when we saw that the nutritional parameter were in the borderline level, and even after replacement of those drugs, she was not responding, then we should have thought that we should reassess the patient, we should think of the other differential, other possibilities, and a timely referral could also help in early diagnosis. In the second case, in 2022, another female in his 50s came without any history of comorbidities. She had gum bleeding and reduced to dark skin spots and no history of fever, anorexia, any swelling, weight loss, or dyspnea. On examination, she was having few cervical nodes as examined and in the axillary region also. And there were multiple purpuric and petechial spots in the oral cavity and all over the body. And the initial test showed the hemoglobin was normal, WBC count was a bit higher, 15,000, with neutrophil 25%, lymphocyte 30%, and platelet count was 12,000. The other tests like liver function, renal function, and all the rest was normal. So she was thought to have having ITP, and but higher TLC, she was initially treated with some antibiotics, and after a course of antibiotics, she was treated with steroids. And after this, she responded beautifully, and the platelet count was normal, but again after 2 months she relapsed, and this time she was referred. So again during the examination, she was still having those cervical and axillary lymph nodes. The CBC again showed the hemoglobin was normal, WBC count was still high, 20,000, with presence of lymphocytic predominance, and platelet count was below 20,000. The peripheral smear, which is shown on the right side, was showed presence of lymphocytes with presence of small mature lymphocytes with few pro-lymphocyte and some smudge cells. And platelet count was low. The other tests were normal. So suspecting a lymphoproliferative disorder, we sent a flow cytometry from the peripheral blood, and it was suggestive of presence of atypical lymphoid cells, which were positive for CD5, CD23, 19, 20, 200, with light chain restriction in the kappa region, and it was diagnosed as CLL, that is chronic lymphocytic leukemia. And in chronic lymphocytic leukemia, they was treated with chemotherapy regimen, bendamustine rituximab, and she is maintaining remission till now. So what is the clues in this case? In the clinical examination during the initial presentation, we think that the patient is having ITP, but she is having some nodes. We should think that she may be presenting with some hematological malignancy, and the ITP may be a secondary presentation of that disease. And checking the peripheral smear is utmost important. The morphology gives a lot of clues during the initial diagnosis. And apart from that, before starting steroids in any benign disease, in hematological disease, we should think that are we missing anything? Can we safely start the steroid? So other differentials should be ruled out before starting steroids in these situations. In the third case, in 2024, a 55-year female presented with low-grade fever, weakness, and cough for 2 months. She was evaluated locally by some physician, and on examination, she was found to have severe pallor, no icterus, no lymph nodes, no edema, no liver, no spleen. And the CBC showed only low hemoglobin of around 4. WBC, platelet were normal. The nutritional parameter were normal. For cough, she was initially treated with antibiotic, but needed multiple course of antibiotic, but cough was persisting. And the tuberculosis was also ruled out. And the anemia progressed, and she received almost 8 to 10 transfusions in the last 2 months. still no improvement was there, and she was referred to our hospital. And on the initial test, so on the examination also, she was not having any suggestive clinical finding, no hepatosplenomegaly, no mass, no swelling, no lymph nodes. The initial test showed the hemoglobin was 5, WBC and differential counts were normal, platelet was normal, peripheral smear showed normocytic normochromic red cells, but the reticulocyte count was low, below normal, 0.1%. The liver function, renal function, LDH, uric acid were normal. To rule out any hemolysis, though the reticulocyte count was low, in hemolytic condition, retic count is usually high. But still we did in desperation do the Coombs test, the direct and indirect by both the methods, it was negative. And X-ray test was done for the persistent cough to look for any other mass, it was normal. Ultrasound abdomen was done, it was also normal. So to rule out other possibilities in the presence of persistent anemia or low retic count, we suspected PRCA, pure red cell aplasia, we did a marrow. In the bone marrow aspiration and biopsy, we found that there was deficiency of erythroid precursor, which was less than 1%. So we thought that is the case of PRCA, and the common causes are thymoma, thymic carcinoma, and parvovirus B19 infection. To rule out the secondary causes, we thought that we had done the X-rays already and it didn't show any mass in the mediastinum. So we should send the PCR for parvovirus, and it was negative. So we again had a doubt that what is the primary cause? It is primary PRCA or we have missed anything. So we did again the CT of thorax and abdomen. And we, to our utter surprise, we found that there was solid cystic mass in the lower mediastinum in the cardiophrenic angle, which was not visible in the either in the ultrasound or in the X-rays. And a CT guided biopsy from the mass was done, and it was thymoma. And after that, excision of the mass was done, and she is now having hemoglobin 12. It's 5 months post surgery, and she is transfusion free. And after, so it's a case of thymoma with secondary pure red cell aplasia. So usually thymoma presents in the upper mediastinum, but it's a rare entity. We found only in literature only few cases have been reported. And in this case, what is the clues? Severe anemia requiring frequent blood transfusion. We have to check the peripheral smear and the reticulocyte count. If the reticulocyte count is normal or high, it says that the marrow is functioning normally or it's functioning a bit higher, but it's actually functioning. But if the retic count is low, we should doubt that there is some pathology in the bone marrow. Apart from that, clinical examination, we should also look out for any mass, swelling, nodes, and when in doubt, bone marrow should be done, but should be checked by an experienced pathologist. And in this case, definitely CCT of thorax and abdomen helped us in clinching the diagnosis. And apart from that, when you suspect PRCA, we should rule out the other causes, whether it is secondary to some thymoma, thymic carcinoma, or parvovirus, or other B lymphoproliferative disorders. And otherwise, the patient is a case of primary PRCA, and she is now doing well. In the fourth case, in 2020, a 65-year-old male with history of hypertension for more than 10 years and a history of CVA before 5 years, he presented with chronic diarrhea for almost 1 year with watery stool nearly 2 to 3 times per day. He also had weight loss of almost 8 kgs in the last 6 months. He didn't have hematochezia, melena, fever, pain abdomen, nausea, vomiting, or any recent use of antibiotics when he presented to us. Initially, but initially he was evaluated by physicians, and they have done a very good job. On examination, he was having pallor only, mild pallor. There was bilateral pedal edema, no lymphadenopathy, but there was hepatomegaly of mild hepatomegaly of 2 centimeter, and they found that patient also having peripheral neuropathy grade 1. In the initial test, the CBC showed a bit low hemoglobin of around 9, normal WBC and normal platelet count, normal peripheral smear, liver function and kidney functions were normal. Apart from that, the alkaline phosphatase was a bit raised. It was 320. Stool was tested for any cyst parasite, but it was negative. CT was also negative. Celiac panel was also done, and it was negative. And with the help of gastroenterologist, upper GI endoscopy was done. It was found morphology on the scopy that it was like mild enteral gastritis. And the colonoscopy was also essentially normal, but they took a biopsy, and the biopsy from the duodenum and stomach showed on the right side. It showed that there is presence of diffuse lymphoplasmacytic infiltrate in the lamina propria, and there is deposition of an eosinophilic amorphous material in the interstitium, and which is positive for Congo red stain. Simultaneously, they have also done a bone marrow and biopsy, and it showed presence of increased plasma cell. It was 12% with presence of amorphous material in the bone marrow biopsy. And it was also positive for congruent stain, and it was also showed also apple green birefringent in the polarized light. So amyloidosis was now revealed, and the serum protein electrophoresis done after that showed presence of M band of 3.2 gram per deciliter, and simultaneously whole body PET CT scan showed presence of multiple skeletal lytic lesions. So they were diagnosed to have amyloidosis. So what are the clues in this case? Definitely this case was very difficult. To suspect amyloid is a very difficult task for anybody. And in case patient may have multiple system involvement, patient had here anemia, chronic diarrhea, hepatomegaly, peripheral neuropathy, but high alkaline phosphatase usually we suspect in those cases with high ALP could be a case with peripheral neuropathy, unexplained edema, amyloid could be a possibility, and biopsy in this case definitely helped in clinching the diagnosis, and high index of suspicion is usually very, very important, and the physician have done a very good job. Patient even before coming to us, he was already diagnosed to have amyloidosis. In the last case, in 2024, in the recently only, a 65-year-old male with history of hypertension only for more than 10 years, he was admitted under cardiology for pacemaker implantation for some arrhythmia. And for basic workup, showed that she was having a bit low hemoglobin of 9, a bit high WBC of 11,000 to 12,000 on 2 different tests. Platelet was 1.3 lakhs. And we got an information from the hematology lab that somebody in cardiology was having a leukoerythroblastic picture in the peripheral smear. So out of curiosity, we went to the bedside, searched the patient, and found that patient was having a large spleen. Clinically, the spleen was 5 centimeters enlarged, and patient didn't have give any history of any pre-existing hematological malignancy, and she was not aware of anything such, any such diseases. So we advised and convinced the patient for bone marrow study, and the aspiration and biopsy was done, which showed presence of primary myelofibrosis. And she had grade 3 fibrosis in the bone marrow biopsy. And molecular test was sent from the peripheral blood, and it showed presence of JAK2 V617F mutation, which was positive. So she was diagnosed to have primary myelofibrosis. What are the clues in this case? Clinical examination. Whatever the patient may present to us and whatever treatment department we may belong, but we should not forget to get a proper history and a complete examination. Even if the abdomen examination does not come under cardiology, but putting a hand in the abdomen sometimes gives us a lot of idea. So we should check thoroughly, may not be thoroughly, but at least grossly for other system examinations. So we should not miss. Liver, spleen, lymph node, any mass, lump should be checked. The CBC also, we should check the full reports. In the peripheral smear, if the pathologist has given some comments, we should not ignore that. And definitely, whenever in doubt, we should give timely referral to the concerned team. So in summary, managing hematological malignancies requires a multifaceted approach. Many times, patients come to us with non-specific vague complaints, and sometimes in emergency situations, and sometimes we have to face them in the critical care setup. The basic test like CBC, reticulocyte count, peripheral smear sometimes gives us a very broad idea regarding the underlying disease. And common tests like liver function test also sometimes gives us clues that altered AG ratio may be an initial presentation of a myeloma. Even a higher creatinine also sometimes may be an initial presentation of a myeloma. Whenever we find a patient having a lymph node or mass, we should know when we suspect that it could be an unusual size or pathology, we should prefer an excisional biopsy rather than a core biopsy or FNAC. And in case of ITP or AIHA like autoimmune situation, before starting steroid, you should rule out other differentials, and definitely timely referral saves a lot of resources. And by integrating all this, we can have an early diagnosis, avoid complications, and have improved outcomes. Thank you.
Thank you, Dr. Pakro. You have presented your talk on case was very nice. So I think all of this hematology malignancy you have covered, except leukemia. I think if there is any question or doubt, anybody can ask Dr. Pakro. Yes, sir. I have one doubt.
Yes, sir.
See, this pathologic report, one place to other place, another place to is different. So, in this situation, what is the ideal CBC to know the exact
In the CBC,
peripheral smear of this?
so whenever we,
Because we are very much confusing outside this report. So, any comment about it?
actually, for the pathologist, we should be aware that who are in our circle, whom we personally know, whose reports are usually authentic. Usually in our practice, we have our own pathologist because whom we rely upon in which difficult cases whom to refer. So we have our own circles. But in different places, suppose in your area, you are not, because many people do not see the comments, the smear comments. So that's why if we have any abnormal parameter in the CBC, in that case, suppose the patient WBC is a bit low, 3,900. We know that the range is 4,000 to 11,000, but it's the report is low. We should, sometimes we repeat the test. And sometimes we advise for an peripheral smear manual checking. So if we have advised something in the peripheral smear, if somebody has reported and before sending some test, we should have something in differential in our mind. Suppose these are the possibilities. Patient may be a megaloblastic anemia having macrocytosis. So we should have some differentials in our mind. Suppose a post-viral suppression or nutritional or any other malignancies. So before, if after getting a report, if that doesn't fit, we can have a discussion with the pathologist. You just ring him, and we usually try to collect the numbers, and we will discuss with them. What did you find? Did you find such things? I am suspecting this. Sometimes they also recheck their reports. So in that way, the doubts are usually cleared. And in any point, if he is also in doubt, he can take the help of his colleagues also.
Okay, sir. Thank you very much. Chairperson, please. No.
Hello, sir. Hello, sir. Small. Sir, I'm Dr. Narayan Swami from BSP, Visakhapatnam Steel Plant. Yes, sir. Just a small question regarding the AML, acute myeloid. So the problem is is there anything that the prognosis can be checked through the peripheral smear in an already diagnosed AML case? What is the role of peripheral smear?
In the AML, usually the peripheral smear is the first thing which helps in diagnosing AML. Patient in any acute leukemia patient usually presents with bone marrow failure, either in the form of anemia or thrombocytopenia or leukocytosis or leukopenia. Due to anemia, patient may present initially with any dyspnea, exertional dyspnea or weakness. Due to thrombocytopenia, patient may have bleeding symptom. And for neutropenia, leukocytosis, whatever, patient usually have repeated infections before coming to us. And initially, the first thing, whatever we do is the CBC and the peripheral smear. And in the peripheral smear, in the 90% of cases, we find the increase of blast, myeloblast in the peripheral smear. Only in the cases of leukemic leukemia, when the patient presenting with pancytopenia, in that cases only, finding a blast in the peripheral smear becomes difficult. But otherwise, usually in the peripheral smear, we get an impression the patient is having leukemia. Although differentiating a myeloblast from a lymphoblast sometimes become difficult by only morphology. So we have to depend upon other higher modalities like flow cytometry for that. Or in the basic laboratories, some labs have their other stains like myeloperoxidase stain, Sudan black B stains, that can be applied on the peripheral smear. And if that is AML, these are usually positive. And sometimes the prognostication cannot be done from a slide only because and apart from that, only a type of AML is there, that is acute promyelocytic leukemia, which is AML M3. That is a different kind of AML, and because the treatment is totally different from the other types of AML, and the prognosis of that AML is very good. Even the cure rate is more than 95%. So in that way only, if the patient is case of APML, it's a very good prognostic AML. And apart from that, the other AML differentiating risk stratification from the peripheral smear can be done from the peripheral smear basis. You have to depend on the molecular markers also.
I am Dr. Shantipriya, pathologist, sir, RANN. How do you follow up the case of lymphocytic leukocytosis? Nowadays, so many cases are coming.
Lymphocytic leukocytosis. Depends upon the what age the patient is presenting.
That patient is 40 to 50 years. Since 4-5 years, they are same findings. We are
30 to 35 years.
Yeah, 35 to 45.
How much is the WBC, man?
WBC 28,000, 35,000.
28,000, 30,000 presence of lymphocytosis.
And lymphocytosis is 80 to 85%.
Acha.
So
And since
like
how many months it's persisting?
Last 4-5 years, he is having like
Acha,
that.
acha. In that case, we should like to check whether the patient is also having some lymphadenopathy, hepatosplenomegaly or not.
No lymphadenopathy, no hepatosplenomegaly.
Then if the and the peripheral smell, we should check, and if and like possibly a flow cytometer from the peripheral blood would be advisable, and it may be a case of any chronic lymphoproliferative disorder like CLL with a low grade malignancy. Usually doesn't do any harm, but remains asymptomatically for many months or years. It might be that entity.
Okay, thank you.
Sir, thank you. With this, we conclude this session.
Thank you, sir. Thank you for the opportunity.
Thank you, sir. I may now request Dr. K.L. Himram, sir, Additional CMO, RSP, Rourkela, to present a token of appreciation to Dr. Pritish Chandra Patra, sir. I may now request Dr. S.N. Suresha, sir, Chief Consultant, Tata Steel, to kindly present a token of gratitude to Dr. K.L. Himram, Additional CMO, RSP, Rourkela. I may now request Dr. K.L. Himram, sir, to present a token of appreciation to Dr. S.N. Suresha, sir. Thank you, sir. और क्या बोलूं?
अपने लोग हैं
Thank you, everybody. We will meet everybody at German Club tonight for the dinner.